करून घ्यावा. उपस्थित सर्वांना या ठिकाणी विनंती आहे, आपली ही कॉन्फरन्स ऑनलाईन चालू आहे, त्यामुळं अनेक जण ही कॉन्फरन्स आपल्या मोबाईलवरती लॅपटॉपवरती पाहत आहेत. तेव्हा सर्वांना विनंती आहे की आपण आपल्यामध्ये थोडंसं अंतर ठेवा आणि आपलं आणि आपल्या शेजाऱ्याचं आरोग्य सुरक्षित राखावं अशी विनंती या ठिकाणी आपल्याला करतोय. आणि हॉलची रचना ही दोन्ही बाजूला आपली बैठक व्यवस्था करण्यात आलेली आहे. पाठीमागच्या बाजूला जे बसले त्यांना विनंती आहे आपण कृपया आपल्या उजव्या बाजूला या ठिकाणी काहींनी बसून घ्यावं, म्हणजे हालचा बॅलन्स अतिशय व्यवस्थित होईल आणि जे काय या ठिकाणी काही छायाचित्र फोटो जे काढले जाणार आहेत ते पाहणं सुद्धा या ठिकाणी आपल्याला चांगलं वाटेल. म्हणून या ठिकाणी विनंती आहे, पाठीमागचं आमचे जे मित्र आहेत त्यांना विनंती आहे आपण थोडंसं आपल्या डाव्या बाजूला उजव्या बाजूला बसून घ्या आणि दोन्हीकडचा बॅलन्स या ठिकाणी समान राहील याची आपण सर्वांनी काळजी घ्या. अगदी काही वेळात आपण या कार्यक्रमास प्रारंभ करतोय. मित्रांनो, शब्दांकडे हसतमुखानं बघणं किती छान असतं. शब्दांकडे हसतमुखानं बघणं किती छान असतं. सूर शब्दांची साथ घेत जगणं किती सुंदर होतं. गीत असतं आपल्या बरोबर, फक्त ते समजावं लागतं. आपण असतो आपल्या बरोबर, फक्त ते समजावं लागतं. शब्दस्वरांचं अतूट नातं हृदयापर्यंत पोहोचावं लागतं आणि मैत्र जीवांचं हे नातं जपावं लागतं. आणि असंच हे मैत्रीचं नातं जपण्यासाठी आपण या ठिकाणी आज उपस्थित आहात, त्याबद्दल आपण सर्वांचं मी सहर्ष स्वागत करतो. जे निमंत्रित आहेत, ज्यांनी आधी आपल्या डोक्यावरती फेटा परिधान केलेला नाही, त्यांना विनंती आहे की कृपया आपण आपल्या डोक्यावरती फेटा परिधान करून घ्यावा आणि कार्यक्रमास प्रारंभ होतोय. कार्यक्रमास प्रारंभ करण्याची विनंती या ठिकाणी डॉक्टर प्रिया कदम यांना या ठिकाणी मी करतोय.
Good morning, everyone. I, Dr. Priya Kadam, on behalf of IMA Clues, welcome all the special and excellent speakers of different faculties, renowned guests, and respected chairpersons, office bearers, online and offline delegates, who have no doubt increased the dignity of AMSCON 2021, held first time in the history of a Clues. Without wasting any time, we will start. I will call upon today's guest on the stage. Dr. Ramkrishna, President of today's event and President IMA Maharashtra State, to be escorted by Dr. Ninad Fade. Sir, please proceed on stage. Dr. Ravi Wankhedkar, Chief Guest of today's event, Treasurer, World Medical Association and past National President, escorted by Dr. Abhijit Gandhi. I would request Dr. Sanjay Sid sir to escort Dr. Anil Pansnekar, past President, IMA MS. I would request Dr. Shetty to escort Dr. Pankaj Bhandarkar, Secretary, IMA MS. Dr. Mukund Zamdar to escort Dr. Ravindra Kute, Vice President, IMA MS. Dr. Sanjay Sid escort Dr. Jayant Naurange, Chairman, IMA SSS. Dr. Sachin Fade to escort Dr. Prakash Marathe, Secretary, IMA SSS. Dr. Abhijit Gandhi to escort Dr. Santosh Kulkarni, Chairman, PCP NDT. Dr. Mukund Zamdar to escort Dr. Nitin Ikatpure, immediate past President. Dr. Rajiv Agrawal, Treasurer, IMA Maharashtra, to be escorted by Dr. Mukund Zamdar. I would request Dr. Nitin Ikatpure, immediate past President ACLUS, Dr. Santosh Khartare, President IMA ACLUS, and Dr. Nitin Rane, Secretary IMA ACLUS, to be seated on the stage.
Good morning all. I, Dr. Mansi Inamdar, on behalf of IMA ACLUS, would like to appeal everyone to maintain 1 minute silence for COVID warriors who have lost their lives in this COVID era. Om Shanti. Now I would request all respected guests on the stage to please proceed for the lamp lighting ceremony.
उजळला दीपकार्याचा प्रकाश चोहीकडे पडे, उजळला दीपकार्याचा प्रकाश चोहीकडे पडे, रुग्णसेवेचे काम आपले पाऊल पडते पुढे पुढे. आजच्या या कार्यक्रमाचा सुरुवात दीपप्रज्वलन करून या ठिकाणी संपन्न होते. कार्यक्रमाचं उद्घाटन या ठिकाणी दीपप्रज्वलन केलं जात आहे. मान्यवरांच्या शुभ हस्ते या ठिकाणी दीपप्रज्वलन होते. तमसो मा ज्योतिर्गमय हा भारतीय संस्कृतीचा संदेश आहे. तमसोमा ज्योतिर्गमय हा भारतीय संस्कृतीचा संदेश आहे. अंधारातून प्रकाशाकडे जाणे, अज्ञानातून ज्ञानाकडे जाणे, असत्याकडून सत्याकडे जाणे, या सर्वांचे प्रतीक म्हणजे दीप प्रज्वलन. आज या उजळणाऱ्या ज्योती ज्ञानाच्या आहेत, प्रतिभेच्या आहेत, विविध कलागुणांच्या आहेत आणि अशा या सुंदर अशा सोहळ्याचं उद्घाटन या ठिकाणी दीप प्रज्वलन करून या ठिकाणी करण्यात येत आहे. मान्यवरांच्या शुभास्ते या ठिकाणी दीप प्रज्वलन होते. दीप से दीप जलाते चलो, ज्ञान की गंगा बहाते चलो. मान्यवरांच्या शुभास्ते या ठिकाणी दीप प्रज्वलन केलं जात आहे. ज्योत पेटू ज्ञानाची, ज्योत ही अभिमानाची. ज्योत पेटू ज्ञानाची, ज्योत ही अभिमानाची. ज्योत तेवते अंधारात, वाट दाखवी जगण्याची. प्रकाश ही आपल्याला जगण्याची वाट दाखवतो आणि म्हणूनच प्रत्येक कार्यक्रमाची सुरुवात या ठिकाणी दीप प्रज्वलन करून केली जाते. मान्यवरांना विनंती आहे की आपण आपल्या शुभास्ती या ठिकाणी दीप प्रज्वलन करावं. कार्यक्रमाच्या निमित्तानं डॉक्टर रामकृष्ण लोंढे साहेब, डॉक्टर रवी मनखेडकर सर सन्माननीय, डॉक्टर अनिल पासनीकर सन्माननीय, डॉक्टर पंकज भंडारकर सन्माननीय, डॉक्टर रवींद्र कुटे, डॉक्टर जयंत नवरंगे, डॉक्टर प्रकाश मराठे, डॉक्टर संतोष कुलकर्णी या सर्वांच्या शुभास्ते या ठिकाणी दीप प्रज्वलन या ठिकाणी संपन्न झालेलं आहे. शब्दांच्या घेऊन ज्योती उजळू अज्ञानाच्या राती, शब्दांच्या घेऊन ज्योती उजळू अज्ञानाच्या राती. शब्दातून जोडत जाऊ जगी मानवतेची नाती. आणि आपल्याला असंच मानवतेचं नातं या ठिकाणी आपल्याला अखंड असं तेवत ठेवायचं आहे. आणि या कार्यक्रमाचं दीप प्रज्वलन मान्यवरांच्या शुभास्ते संपन्न झालेलं आहे.
Now I request Dr. Aditi Dhite to come on dais for IMA prayer and flag salutation as a symbol of IMA tradition. Thank you.
Thank you, Manasi. As our IMA tradition, after the lamp lightning, there is a time for IMA prayer. As we all are doctors, we always pray for others, not for us. According to this IMA prayer is also for those who are in pain and sorrow. We ask Almighty to alleviate the pain and sorrow of those who are in trouble. So I would request everyone to please be stand up, and I repeat the lines of IMA prayer, and please repeat after me. The prayer is also displayed on the screen also. May everybody be happy. May every one of us see to it that nobody suffers from any pain or sorrow. I do not ask for crown, nor I wish to be in heaven or reborn. I only want to alleviate the suffering of those people who are burning in fire of sorrow. Long live IMA. Jai IMA. Now there is a time for flag salutation. This flag salutation, I say the lines, but this time, remember, please do not repeat. We, the member of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as the accredited member of this national organization, we swear we will dedicate everything in our power to see it fly high in the committee of nation. Jai Hind, long live IMA. Thank you. Now I would request everyone to please be seated, and I hand over this session to Dr. Priya for further announcement. Thank you.
Thank you, Mansi and Aditi. I would request Dr. Khartade to come on the dais for his presidential speech. Dr. Santosh Khartade, sir, for the presidential speech.
respected dignitaries on the dais, and my dear friends. Good morning all. Myself, Dr. Santosh Khartare, President IMA Akluz branch, very pleased to here now for welcoming you all. It's my great pleasure to welcome you all in Akluz, situated on the bank of river Nira, also previously known as a village having Asia's biggest Gram Panchayat. Gurur Brahma, Gurur Vishnu, Gurur Devan Maheshwara, Gurur Sakshat Parar Brahma Tasmai Sri Guruve Namaha. Today, 5th September, obviously Teachers' Day. On this auspicious day, we are here for the inaugural ceremony of AMSCON 2021, IMA Maharashtra State Annual AMS Conference, which is in this year organized by IMA Akluz branch. I would like to extend a special welcome for today's chief guest, the man who continuously inspires me to do my best and always help me strive my goals, who traveled averagely 3,000 to 5,000 kilometers monthly for IMA only, a treasurer of World Medical Association and past national president of IMA headquarters, past president of SARC Medical Association and chief election commission of IMA National, none other than Dr. Ravi Wankhedkar sir. I also welcome president of today's function, who is a sitting president of IMA Maharashtra State, in which president post IMA enters in our own premises. Also, who is visiting and solving problems of small branches on every weekend, that none other than Dr. Ramakrishna Londe sir. Guidance, friendship, love and discipline, everything in one person. Also, past president of IMA Maharashtra State, always caring and smiling face of IMA, Dr. Anil Pachnekar sir. Tall and calm, always helpful, secretary of IMA Maharashtra State, Dr. Pankaj Bandarkar sir. Young, dynamic, active treasurer of IMA Maharashtra State, Dr. Rajiv Agarwal sir. The person who visited almost 185 branches in last 6 months, that is covered 90% of IMA branches, currently sitting vice president of IMA Maharashtra State, Dr. Ravindra Kute sir. I also welcome chairman of IMA Maharashtra State Social Security Scheme, Dr. Jayant Naurange sir. I also welcome a secretary of IMA Maharashtra State Social Security Scheme, Dr. Prakash Marathe sir. Both Naurange sir and Marathe sir are from Pune, working tirelessly for our social security scheme. I also welcome a chairman of PCPNDT Maharashtra State, Dr. Santosh Kulkarni sir. It's my pleasure to extend a cheerful welcome of all other seniors of IMM Akluz branch. All your presence makes us happy today, sir. Now we all needs a huge round of applause for all these today's guests who had traveled a long way for us only. A dream you dream alone is the only dream, but a dream you dream together is a reality. A single person can't do anything. I think togetherness is very important ingredient in organizing any event. For the success of any event, we require multiple hands. Here, while organizing this AMSCON, not only my office bearers of organizing team, but all the seniors of IMA Akluz have supported a lot and guided us day to day. सर, IMA अकलूज ही शाखा गेली 41 वर्षापासून कार्यरत आहे. अकलूज हे मेडिकल हब म्हणून या ठिकाणी प्रसिद्ध आहे. सोलापूर आणि पुणे या दोन्ही शहरांच्या सेंटरवरती अकलूज असल्यामुळं या ठिकाणी खूप सारे स्पेशालिस्ट, सुपर स्पेशालिस्ट डॉक्टर्स आहेत आणि मेडिकल हब म्हणून या ठिकाणी हे प्रसिद्ध आहे. या छोट्याशा गावामध्ये आमच्याकडे 3 कॅथ लॅब आणि मोठे मोठे असे जवळजवळ 5 हॉस्पिटल्स आहेत. समाजातल्या माणसाचं आणि माणसातल्या अंतःकरणाचं दुखणं ओळखून उपचार करणारे सर्व डॉक्टर्स असे आमच्या अकलूजचे डॉक्टर्स आहेत. महाराष्ट्रामध्ये IMA नी चालवलेली एकमेव रक्तपेढी ही फक्त IMA अकलूजची आहे आणि गेली 40 वर्ष सतत एकही दिवस बंद न होता समाजामध्ये रक्त पुरवठा करण्यासाठी ही रक्तपेढी रात्रंदिवस कार्यरत आहे. मित्रहो, वक्तृत्व, कर्तृत्व आणि नेतृत्वाचा सुरेख संगम असलेले आदरणीय डॉक्टर रवी सर आज आपल्याला उद्घाटक म्हणून लाभलेले आहेत. आपण त्यांचं स्पीच ऐकणार आहोतच. शेवटी जाता जाता मला एक सर्व पाहुण्यांसाठी असं म्हणावंसं वाटतं, सौ चांद भी आ जाए तो महफिल में ओ बात न रहेगी, सौ चांद भी आ जाए तो महफिल में ओ बात न रहेगी, सिर्फ आपके आने से ही हमारे महफिल की रौनक बढ़ेगी, सिर्फ आपके आने से ही हमारे महफिल की रौनक बढ़ेगी. धन्यवाद. जय हिंद, जय IMA.
धन्यवाद कडतरे सर. आपण जेव्हा बोलत असताच तेव्हा कार्यक्रमाची रौनक वाढलेली असते. अतिशय सुंदर असं प्रास्ताविक या ठिकाणी या कार्यक्रमाच्या निमित्तानं आपण सादर केलं.
Now I would call my dear friend and Mediqueen Maharashtra, Dr. Revati Rane, to share with all the scientific motive of AMSCON 2021. Thank you, Priya ma'am. Respected dignitaries on dais, seniors and my colleagues. It's my immense pleasure and privilege to be a part of this state level event. And I'm honored to be given an opportunity to play a vital role of clinical secretary of IMA Akluz to conduct this state level conference. The new elected team of IMA Office Bearers 2021 under the presidencyship of Dr. Santosh Khatare sir has began its tenure in April 2021, just 4 months back. And in spite of the hindrance of COVID pandemic, we managed to conduct webinars and celebrated Doctors' Day and much more. One should dream big and set a goal and work hard for it. Our president, Dr. Khatare sir, had a dream and a vision to conduct a state level conference. Initially, it felt like an unrealistic idea, but he had a clear vision and determination to pursue it. So he motivated the team to sail in the ship of journey towards this day. Because of COVID and its uncertainties with permission, attendance, and much more, the date, venue, time, physical or online, etc. decisions kept oscillating. And finally, with the multiple meetings and lots of discussion, this hybrid conference came into action. The theme emergencies in medical field was selected purposely to set aside COVID topic and to make the clinical input useful to all the delegates of different specialties. In this 2 days conference, we totally planned 28 lectures of renowned speakers from all over India, along with some international speakers too, covering almost all the specialties like medicine, surgery, gynec, ortho, pediatric, radio, ophthalm, psychiatry, and super specialties like cardio, neuro, and urology. Along with this, we were happy to have celebrated World Sexual Health Day on 4th September, that is yesterday, with special session on sexology and another session of IMA lectures by all the stalwarts who uplifted the conference to another level. Organizing this vast academic extravaganza was merely impossible without the support of office bearers and IMA members of different specialties
who approached all these eminent speakers and made this event into reality. A conference cannot just be made up of series of good lectures, but rather it's like a complex recipe which requires every spice, even a pinch of salt that matters. So along with the scientific committee, venue, stage, food, registration, etc., all committees played a vital role in this success. And special thanks to audiovisual team and DigiShield, without whom this hybrid conference wouldn't have been possible. Again, thank you team Occluse IMA and President Sir for uniting us and making us part of this wonderful lifetime event. Thank you.
Thank you, Revati. Now we will start with the felicitation of our eminent guests. I will request Dr. Santosh Khartare sir to felicitate Dr. Ramkrishna Londe sir, who is the president of this event and president IMA Maharashtra state.
आजच्या या कार्यक्रमाच्या निमित्तानं IMA महाराष्ट्र राज्याचे अध्यक्ष डॉक्टर रामकृष्ण लोंढे सर यांचा सन्मान IMA अकलूजचे अध्यक्ष सन्माननीय संतोष खडतरे सर यांच्या शुभ हस्ते या ठिकाणी संपन्न होतो आहे. सन्माननीय डॉक्टर रामकृष्ण लोंढे सरांना या ठिकाणी विनंती करतो की आपण आमच्या या सन्मानाचा स्वीकार करावा. अतिशय सुंदर असा हा सोहळा आपल्या सर्वांच्या उपस्थितीमध्ये संपन्न होतोय. आपल्या सर्वांचं या चर्चासत्राच्या निमित्ताने मी सहर्ष स्वागत करतो. महाराष्ट्रीयन माणसाच्या डोक्यावरती फेटा परिधान केल्यानंतर त्याचं व्यक्तिमत्व किती रुबाबदार दिसतं या ठिकाणी आपल्याला डॉक्टर रामकृष्ण लोंढे यांच्याकडे पाहिल्यानंतर या ठिकाणी दिसत असेल. चेहऱ्यावरती सुंदर असं स्मित हास्य, त्यांचा सन्मान या ठिकाणी तितकंच गोड आणि लाघवी बोलणारे आणि शब्दाने या ठिकाणी आम्हाला काबीज करणारे डॉक्टर संतोष खडतरे यांच्या शुभ हस्ते या ठिकाणी त्यांचा सन्मान संपन्न होतो आहे. रुग्णावरती कुठलंही संकट आलं तर त्याला त्या आजारातून बरे करण्याचं काम या ठिकाणी डॉक्टर्स मंडळी करतात आणि डॉक्टर्स खरं तर हे ईश्वर आहेत असं म्हटलं तर काय वावगं नाही. डोक्यावरती फेटा, मायेची शाल, स्नेहाचं प्रतीक पुष्पहार, ट्रॉफी देऊन या ठिकाणी मान्यवरांचा सन्मान या ठिकाणी संपन्न होतो आहे. त्याचबरोबर बुके आणि एक प्रेमाचं गिफ्ट या ठिकाणी मान्यवरांना देण्यात येत आहे. मान्यवरांना विनंती आहे की आपण आमच्या या सन्मानाचा आपण स्वीकार करायचा आहे. जे डॉक्टर्स मंडळी प्रथमच अकलूज आलेले त्यांच्यासाठी मी सांगेन की अकलूज हे आधुनिक पर्यटन स्थळ आहे आणि कोविड-19 मुळे काही पर्यटन स्थळ आमची बंद आहेत, परंतु आपण काही ठिकाणांना अवश्य भेटी देऊ शकता. सुंदर असं एक प्रेमाचं गिफ्ट देऊन या ठिकाणी त्यांचा सन्मान या ठिकाणी संपन्न झालेला आहे. धन्यवाद डॉक्टर, आपण आमच्या या सन्मानाचा मनापासून आपण स्वीकार केला.
Now I would request Dr. Nitin Ikatpure sir, immediate past president Occluse, to please felicitate Dr. Ravi Wankhedkar, who is the chief guest of today's program and treasurer World Medical Association and past national president.
डॉक्टर रवी वानखेडकर सर यांचा सन्मान या ठिकाणी माजी अध्यक्ष सन्माननीय डॉक्टर नितीन एकतपुरे सर यांच्या शुभ हस्ते या ठिकाणी संपन्न होतो आहे. वर्ल्ड मेडिकल असोसिएशनचे कोषाध्यक्ष आणि IMA भारत देशाचे माजी अध्यक्ष सन्माननीय डॉक्टर रवी वानखेडकर यांचा सन्मान या ठिकाणी संपन्न होतो आहे. फेटा, शाल, पुष्पहार, बुके आणि एक सुंदर असं गिफ्ट देऊन या ठिकाणी त्यांचा सन्मान केला जात आहे. समाजसेवा करणारी ही डॉक्टर्स मंडळी खरं तर ही आपल्या सर्वांसाठी अभिमानाची गोष्ट आहे की अतिशय चांगल्या प्रकारचं कार्य या मंडळी या ठिकाणी सातत्याने करत असतात. कुठलीही नैसर्गिक आपत्ती असो किंवा कोविड-19 असो, या प्रत्येक ह्याच्यामध्ये त्यांनी अतिशय चांगल्या पद्धतीचं काम केलेलं आहे.
Now I would request Dr. Jnandev Dhobre sir to please felicitate Dr. Anil Pansnekar, sir, past President IMA MS.
या सुंदर अशा सोहळ्याच्या निमित्तानं IMA महाराष्ट्र राज्याचे माजी अध्यक्ष सन्माननीय डॉक्टर अनिल पाचनेकर यांचा सन्मान डॉक्टर ढोबळे यांच्या शुभहस्ते या ठिकाणी संपन्न होतो आहे. फेटा, शाल, पुष्पहार, बुके आणि एक सुंदर असं प्रेमाचं गिफ्ट देऊन या ठिकाणी या मान्यवरांचा सन्मान या ठिकाणी केला जात आहे. कारण प्रेमाने दिलेली कुठलीही गोष्ट ही प्रिय असते आणि म्हणून प्रेमाचं गिफ्ट असं या ठिकाणी मी सातत्यानं म्हणतोय. आणि त्यांचा सन्मान या ठिकाणी या कार्यक्रमाच्या निमित्तानं व्यासपीठावरती संपन्न होतोय. हे अतिशय चांगल्या प्रकारचं कार्य यांचं आहे आणि त्यांचा सन्मान होणं हे फार महत्वाचं आहे.
Now I would request Dr. Sanjay Seth, sir, to please felicitate Dr. Rajiv Agrawal, treasurer of Maharashtra. Okay. I would request Dr. Sanjay Seth, sir, to please felicitate Dr. Pankaj Bandarkar, secretary IMA MS.
या कार्यक्रमाच्या निमित्तानं IMA महाराष्ट्र राज्याचे सेक्रेटरी सन्माननीय डॉक्टर पंकज भंडारकर यांचा सन्मान या ठिकाणी डॉक्टर सिद्ध यांच्या शुभहस्ते या ठिकाणी संपन्न होतो आहे. सन्माननीय पंकज भंडारकर सरांना या ठिकाणी विनंती करतो की आपण आमच्या या सन्मानाचा आपण स्वीकार करावा. फेटा, शाल, पुष्पहार, बुके आणि एक गिफ्ट देऊन या ठिकाणी एक ट्रॉफी या ठिकाणी त्यांना दिली जात आहे. त्यांना विनंती आहे आपण आमच्या या सन्मानाचा स्वीकार करावा. सुंदर अशा शुभसमयी या ठिकाणी हा सन्मान सोहळा या ठिकाणी संपन्न होतो आहे. थोडस हलकस ऊन, थंडगार हवा आणि अशा सुंदर वातावरणामध्ये हा सोहळा संपन्न होतोय. पुन्हा एकदा आपण सर्वांचं या कार्यक्रमाच्या निमित्तानं सर्व उपस्थितांचे या ठिकाणी मी सहर्ष स्वागत करतो. आणि एक सुंदर असं गिफ्ट मला खडतरी सरांनी सांगितलं की हे प्रेमाचं गिफ्ट आहे आणि म्हणून या ठिकाणी हे प्रेमाचं गिफ्ट देऊन त्यांचा सन्मान केला जात आहे.
Now I would request Dr. Mukund Zamdar to please felicitate Dr. Ravindra Kute, Vice President IMA MS.
या कार्यक्रमाच्या निमित्तानं IMA चे उपाध्यक्ष सन्माननीय डॉक्टर रवींद्र कुटे यांचा सन्मान डॉक्टर जमदार यांच्या शुभहस्ते या ठिकाणी संपन्न होतो आहे. सन्माननीय डॉक्टर रवींद्र कुटे यांना या ठिकाणी विनंती करतो की आपण आमच्या या सन्मानाचा स्वीकार करावा. कारण माळशिरस तालुका हा सहकार्याचा तालुका आहे आणि या तालुक्यामध्ये अतिथींचं अगदी मनापासून स्वागत केलं जातं, त्यांचा सन्मान केला जातो आणि त्याचाच हा सन्मान सोहळा या ठिकाणी या अकलूज नगरीमध्ये या ठिकाणी संपन्न होतोय. आपण अकलूजला आलात ही आमच्यासाठी अभिमानाची गोष्ट आहे आणि आपला सन्मान या ठिकाणी या कार्यक्रमाच्या निमित्तानं संपन्न होतोय. फेटा, शाल, पुष्पहार, बुके, ट्रॉफी आणि एक प्रेमाचं गिफ्ट देऊन या ठिकाणी मान्यवरांचा सन्मान संपन्न झालेला आहे. धन्यवाद सर, आपण आमच्या या सन्मानाचा आपण मनापासून स्वीकार केला.
I would request Dr. Vinod Shete to please felicitate Dr. Jayant Naurange, Chairman IMA SSS.
यानंतर SSS चे चेअरमन त्याचबरोबर सोशल सेक्रेटरी स्कीम डॉक्टर जयंत नवरंगे सर यांचा सन्मान या ठिकाणी शेट्टी सरांच्या शुभहस्ते या ठिकाणी संपन्न होतो आहे. डॉक्टर जयंत नवरंगे यांना या ठिकाणी विनंती करतो की आपण आमच्या या सन्मानाचा स्वीकार करावा. आपला सन्मान या सुंदर अशा कॉन्फरन्सच्या निमित्ताने या ठिकाणी संपन्न होतोय. आपण अकलूज नगरमध्ये आलात, आमचा पाहुणचार या ठिकाणी स्वीकारला, आपलं बहुमोल असं मार्गदर्शन या ठिकाणी आपण आम्हाला केलं, त्याबद्दल आपला सन्मान अकलूज IMAच्या वतीने या ठिकाणी संपन्न होतो आहे. पुष्पहार, फेटा, शाल, गिफ्ट, बुके आणि एक प्रेमाचं गिफ्ट देऊन या ठिकाणी त्यांचा सन्मान या ठिकाणी केलं जात आहे. आणि प्रेमाचं गिफ्ट हे आपण आपल्या घरी गेल्यानंतरच प्रेमानं पाहायचं असतं. अतिशय सुंदर असा हा सोहळा या ठिकाणी आपल्या सर्वांच्या उपस्थितीमध्ये संपन्न होतोय. पुन्हा एकदा आपल्या सर्वांचं सहर्ष स्वागत.
Now I would request Dr. Nitin Rane, Secretary IMA Aklus, to please felicitate Dr. Rajiv Agrawal, Treasurer IMA SSS.
या कार्यक्रमाच्या निमित्तानं IMASS चे सचिव सन्माननीय डॉक्टर प्रकाश मराठे सर यांचा सन्मान या ठिकाणी डॉक्टर राजीव अग्रवाल यांचा सन्मान या ठिकाणी राणे सरांच्या शुभ हस्ते या ठिकाणी संपन्न होतो आहे. फेटा, शाल, पुष्पहार, बुके, ट्रॉफी आणि एक गिफ्ट देऊन या ठिकाणी त्यांचा सन्मान या ठिकाणी संपन्न केला जात आहे. डॉक्टर राजीव अग्रवाल यांचा सन्मान व्यासपीठावरती IMA अकलूजच्या वतीने या ठिकाणी संपन्न होतो आहे. IMA अकलूज ह्या कार्यक्रमाचे आयोजक आहेत. सर्व आयोजकांनी अतिशय सुंदर असं आयोजन केलेलं आहे, त्याबद्दल त्यांचं या ठिकाणी मी मनापासून सहर्ष स्वागत करतो.
I would request Dr. Suresh Suryavanshi to please felicitate Dr. Prakash Marathe, Secretary IMA SSS.
IMASS चे सचिव सन्माननीय डॉक्टर प्रकाश मराठे यांचा सन्मान डॉक्टर सूर्यवंशी यांच्या शुभ हस्ते या ठिकाणी संपन्न होतो आहे. फेटा, शाल, पुष्पहार, बुके, ट्रॉफी आणि एक गिफ्ट देऊन या ठिकाणी मान्यवरांचा सन्मान या ठिकाणी संपन्न केला जात आहे. उजळलेला दीपक कार्याचा प्रकाश चोहीकडे पडे, उजळलेला दीपक कार्याचा प्रकाश चोहीकडे पडे, रुग्णसेवेचे लोकसेवेचे काम आपले पाऊल पडते पुढे पुढे. आणि रुग्णसेवा हीच आपली ईश्वर सेवा समजून या ठिकाणी ही सर्व मंडळी काम करतात. दिवस रात्र अगदी 24 तास रुग्णसेवेसाठी ते आपले देत असतात आणि अशा मंडळीचा व्यासपीठावरती संपन्न होतो आहे. अतिशय चांगल्या प्रकारचं कार्य त्यांचं या ठिकाणी आपण सर्वजण पाहत आहोत. धन्यवाद. आपण आमच्या या सन्मानाचा आपण मनापासून स्वीकार केला.
Now I would request Dr. Ninad Fade to please felicitate Dr. Santosh Kulkarni, Chairman PCP NDT.
या सुंदर अशा कार्यक्रमाच्या निमित्तानं PCP NDT चे चेअरमन सन्माननीय डॉक्टर संतोष कुलकर्णी यांचा सन्मान सन्माननीय डॉक्टर निनाद फडे यांच्या शुभ हस्ते या ठिकाणी संपन्न होतो आहे. फेटा, शाल, बुके, ट्रॉफी आणि एक सुंदर असं गिफ्ट देऊन या ठिकाणी डॉक्टर संतोष कुलकर्णी यांचा सन्मान या ठिकाणी संपन्न होतो आहे. ते PCP NDT चे चेअरमन आहेत आणि त्यांचा सन्मान या ठिकाणी व्यासपीठावरती संपन्न झालेला आहे.
आमच्या सर्वांचं भरभरून स्वागत केलेलं आहे आणि जो माणूस आमचं एवढं भरभरून स्वागत करतो आहे त्याचं स्वागत करणं हे कर्तव्य आहे. IMA महाराष्ट्र स्टेटकडनं श्रीमान संतोष खडतरे यांचं मी हार्दिक स्वागत करतो, सत्कार करतो. थँक्यू. आमचे ट्रेजरर्स आणि सेक्रेटरीना पुढे बोलवतो.
आजच्या या कार्यक्रमाचे आयोजक IMA अकलूजचे अध्यक्ष माननीय डॉक्टर संतोष खडतरे यांचा सन्मान या ठिकाणी व्यासपीठावरील सर्व मान्यवरांच्या उपस्थितीमध्ये आणि त्यांच्या वतीने या ठिकाणी केला जात आहे. म्हणजे हा कार्यक्रम अतिशय यशस्वी झालेला आहे, यशस्वी केलेला आहे असं म्हणून या ठिकाणी त्यांचा सन्मान या ठिकाणी संपन्न होतो आहे. खडतरे सर, आपके आंखों में कुछ महके हुए से राज है, आपके आंखों में कुछ महके हुए से राज है, आपसे भी खूबसूरत आपके अंदाज है. अतिशय सुंदर असा हा सोहळा आपल्या सर्वांच्या उपस्थितीमध्ये या ठिकाणी संपन्न होतोय. सर्व मान्यवरांचा सन्मान सोहळा या ठिकाणी संपन्न झालेला आहे. पुढे कार्यक्रम या ठिकाणी जातो आहे.
Now we will felicitate our chairpersons who are the stars of Acclus IMA, and I thank Almighty for giving us these supportive seniors as our angels. So we will proceed with the felicitation of the renowned chairpersons.
Now I'll request President Sir, IMA Maharashtra State, Dr. Ramkrishna Londe Sir, to felicitate our chairperson, Dr. M.K. Inamdar Sir.
या परिसरामध्ये ज्यांच्या एकदा शब्दानं किंवा ज्यांना रुग्णां शब्दांचा आधार दिल्यानंतर सुद्धा रुग्ण बरे होतात, अशा आमच्या सर्वांचे लाडकं व्यक्तिमत्व माननीय डॉक्टर एकमे इनामदार साहेब यांचा सन्मान या ठिकाणी मान्यवरांच्या शुभास्ते या ठिकाणी बुके देऊन संपन्न होतो आहे.
Now I request Dr. Vivek Guzar Sir.
कार्यक्रमाच्या निमित्तानं डॉक्टर विवेक गुजर चेअरपर्सन यांचा सन्मान या ठिकाणी मान्यवरांच्या शुभास्ते या ठिकाणी संपन्न होतो आहे. रुग्णसेवा हीच ईश्वर सेवा समजून या ठिकाणी ही सर्व मंडळ या ठिकाणी काम करत आहेत आणि त्यांचा सन्मान व्यासपीठावरती संपन्न होतो आहे. शाल आणि बुके देऊन या ठिकाणी त्यांचा सन्मान मान्यवरांच्या शुभास्ते या ठिकाणी संपन्न झालेला आहे.
Now I request Dr. Santosh.
अकलूजमधील प्रसिद्ध डॉक्टर संतोष जोशी यांचा सन्मान या ठिकाणी या कार्यक्रमाच्या निमित्तानं व्यासपीठावरती संपन्न होतो आहे. त्यांना विनंती, आपण आमच्या या सन्मानाचा स्वीकार करावा. शाल आणि बुके देऊन त्यांचा सन्मान व्यासपीठावरती संपन्न होतो आहे.
Now I request Dr. Arvind Gandhi Sir.
डॉक्टर अरविंद गांधी यांचा सन्मान या ठिकाणी मान्यवरांच्या शुभास्ते या ठिकाणी संपन्न होतोय. ही सर्व ज्येष्ठ मंडळी या ठिकाणी तरुणांना या ठिकाणी मार्गदर्शन करण्याचं काम या ठिकाणी करतात आणि अधिकाधिक चांगल्या प्रकारचं काम या ठिकाणी ही तरुणांकडून करून घेत आहेत आणि त्यांचा सन्मान व्यासपीठावरती संपन्न होतो.
Thank you, sir. Now I request Dr. Ravi Wankhede sir to felicitate Dr. Rajiv Rane sir.
डॉक्टर राजीव राणे प्रसिद्ध बालरोग तज्ञ यांचा सन्मान या ठिकाणी या कार्यक्रमाच्या निमित्तानं संपन्न होतो आहे. शाल आणि बुके देऊन त्यांचा सन्मान मान्यवरांच्या शुभास्ते या ठिकाणी संपन्न होतो.
Dr. हर्षवर्धन दोबाडा सर. Dr. महावीर गांधी सर. Dr. सतीश जोशी सर.
मित्रांनो, आज दुग्ध शर्करा युक्त आहे. आज शिक्षक दिन आहे आणि शिक्षकांच्या हस्ते शिक्षकांचा सत्कार होणं हे किती भाग्याचं आहे बघा आपण.
आणि गुरु आणि शिष्यांचा सन्मान या ठिकाणी एकमेकांच्या शुभास्ते या ठिकाणी संपन्न होतो आहे. गुरु शिष्याचं नातं हे पवित्र असतं, अतूट असतं आणि असं हे नातं सदैव टिकून राहतं.
Dr. अमोल शिंदे सर. Now I request Dr. Anil Pansnerkar sir to felicitate Dr. Mrs. Savita Guzar madam.
अकलूजमधील प्रसिद्ध स्त्रीरोग तज्ञ डॉक्टर सविता गुजर यांचा सन्मान या ठिकाणी मान्यवरांच्या शुभास्ते व्यासपीठावरती संपन्न होतो आहे. त्यांना विनंती आहे आपण आमच्या या सन्मानाचा आपण स्वीकार करावा. शाल आणि बुके देऊन त्यांचा सन्मान या ठिकाणी संपन्न झालेला आहे. धन्यवाद.
डॉक्टर संतोष खडतरे सर.
डॉक्टर आजच्या या कार्यक्रमाचे आयोजक IMA अकलूजचे अध्यक्ष माननीय डॉक्टर संतोष खडतरे यांचा सन्मान या ठिकाणी मान्यवरांच्या शुभास या ठिकाणी संपन्न होतोय. शाल आणि पुष्पगुच्छ देऊन या ठिकाणी त्यांचा सन्मान संपन्न झालेला आहे.
डॉक्टर विद्युत शहा सर.
आपल्या या अकलूजमधीलच नव्हे तर सोलापूर जिल्ह्यातील प्रसिद्ध सर्जन डॉक्टर विद्युत शहा यांचा सन्मान या ठिकाणी व्यासपीठावरती संपन्न होतो आहे. त्यांना विनंती आहे आपण आमच्या या सन्मानाचा स्वीकार करावा. शाल आणि बुके देऊन त्यांचा सन्मान व्यासपीठावरती संपन्न होतो आहे. अखंड रुग्णसेवा करणारे डॉक्टर विद्युत शहा. धन्यवाद सर.
डॉक्टर दिलीप सिद्धपुरा सर.
एक मिनिट. अकलूज IMAच्या इतिहासामध्ये आजचा दिवस खूपच मानाचा ठरेल. यशस्वी कॉन्फरन्सच्या दिवशी मला एक शेर आठवलाय, तेवढाच फक्त एकच मिनिटात म्हणतो. खडतरे सर, मंजिले उन्हीं को मिलती है, मंजिले उन्हीं को मिलती है जिनके सपनों में जान होती है, मंजिले उन्हीं को मिलती है जिनके सपनों में जान होती है. अरे उड़ान तो हौसलों से होती है, पंखों से नहीं. थँक्यू.
सर्वांना बरोबर घेऊन येण्याचं काम या ठिकाणी डॉक्टर संतोष खडतरे करतात.
डॉक्टर दिलीप सिद्धपुरा सर.
अकलूजमधील प्रसिद्ध भूलरोग तज्ञ डॉक्टर दिलीप सिद्धपुरा यांचा सन्मान या ठिकाणी व्यासपीठावरती संपन्न होतो आहे. शाल आणि बुके देऊन त्यांचा सन्मान व्यासपीठावरती संपन्न होतो आहे.
डॉक्टर HN शेटे सर.
डॉक्टर शेट्टी सरांचा सन्मान व्यासपीठावरती संपन्न होतो आहे. मान्यवरांच्या शुभास्ते हा सन्मान या ठिकाणी संपन्न केला जात आहे. शाल आणि बुके देऊन त्यांचा सन्मान संपन्न होतो.
I request Dr. Pankaj Bandarkar sir to felicitate Dr. HN Shete sir. I request Dr. Nitin Ekatpure sir.
अकलूज IMAचे माजी अध्यक्ष तथा या पंचकृषीतील प्रसिद्ध बालरोग तज्ञ डॉक्टर नितीन एकतपुरे यांचा सन्मान मान्यवरांच्या शुभास्ते या ठिकाणी संपन्न होतोय. शाल आणि बुके देऊन त्यांचा सन्मान संपन्न केला जातो.
Now I would request our next chief guest, Dr. Ravindra Kute sir, to felicitate our next chairpersons. Dr. Dhanesh Gandhi sir.
अकलूजमधील प्रसिद्ध हृदयरोग तज्ञ डॉक्टर धनेश गांधी सरांचा सन्मान या ठिकाणी व्यासपीठावरती संपन्न केला जात आहे. त्यांना विनंती आहे आपण आमच्या या सन्मानाचा स्वीकार करावा. शाल आणि बुके देऊन त्यांचा सन्मान संपन्न होतो आहे. धन्यवाद सर.
Dr. Ajit Shah sir. Dr. Samir Bandgar sir.
प्रसिद्ध हृदयरोग तज्ञ डॉक्टर समीर बंडगर यांचा सन्मान या ठिकाणी या कार्यक्रमाच्या निमित्तानं संपन्न होतो आहे. डॉक्टर बंडगर सरांचा या ठिकाणी सन्मान शाल आणि बुके देऊन या ठिकाणी संपन्न केला जात आहे. सन्माननीय डॉक्टर समीर बंडगर सरांना विनंती आपण आमच्या या सन्मानाचा स्वीकार करावा.
Thank you sir. Now I would request Dr. Jayant Naurange sir to felicitate our next chairperson. Dr. Nivant Harale sir.
डॉक्टर निवांत हराळे सर प्रसिद्ध मानवोपचार तज्ञ त्यांचा सन्मान या ठिकाणी या कार्यक्रमाच्या निमित्तानं व्यासपीठावरती मान्यवरांच्या शुभास्ते या ठिकाणी संपन्न होतो आहे. शाल आणि बुके देऊन त्यांचा सन्मान या ठिकाणी केला जात आहे.
डॉक्टर नितीन थिटे सर.
डॉक्टर नितीन थिटे सर यांचा सन्मान व्यासपीठावरती मान्यवरांच्या शुभ हस्ते या ठिकाणी संपन्न होतोय. डॉक्टर नितीन थिटे सरांना या ठिकाणी विनंती करतो की आपण आमच्या या सन्मानाचा स्वीकार करावा.
डॉक्टर अभिजित गांधी सर.
कार्यक्रम पुढे जातो आहे.
I would request Dr. Prakash Marathe sir to be felicitated by
डॉक्टर अभिजित गांधी.
felicitate our next chairperson.
डॉक्टर अभिजित गांधी यांचा
Dr.
सन्मान
Abhijit Gandhi sir.
यांचा सन्मान या ठिकाणी व्यासपीठावरती संपन्न होतो आहे. शाल आणि बुके देऊन त्यांचा सन्मान या ठिकाणी संपन्न केला जात आहे. त्यांना विनंती आपण आमच्या सन्मानाचा स्वीकार करावा. धन्यवाद.
Dr. Nilesh Thite sir.
डॉक्टर निलेश थिटे सर यांचा सन्मान या ठिकाणी मान्यवरांच्या शुभ हस्ते या ठिकाणी केला जात आहे. शाल आणि बुके देऊन त्यांचा सन्मान या ठिकाणी संपन्न होतो आहे. त्यांना विनंती आपण आमच्या या सन्मानाचा स्वीकार करावा.
Dr. Mukund Zamdar sir. Dr. Mukund Zamdar sir.
डॉक्टर मुकुंद जामदार सर यांचा सन्मान या ठिकाणी मान्यवरांच्या शुभ हस्ते या ठिकाणी संपन्न होतो आहे. आणि नॅपकिनचा बुके या ठिकाणी खास करून आपण आजच्या या सर्व मान्यवरांना दिलेला आहे. कारण फुलं ही टाकून दिली जातात, पायतळी तुडवली जातात आणि मग या नॅपकिनचा या ठिकाणी आपण वापर करू शकतो. म्हणून या ठिकाणी खास करून नॅपकिन बुके या ठिकाणी देण्यात येत आहे.
Thank you Marathe sir. Now I would request Dr. Santosh Kulkarni sir to felicitate our next chairperson. Dr. Santosh Kulkarni sir. Our next chairperson is Dr. Harpanhadi sir. Dr. Rohit Khade sir.
डॉक्टर रोहित फडे सरांचा सन्मान या ठिकाणी व्यासपीठावरती संपन्न होतो आहे. त्यांना विनंती आहे आपण आमच्या या सन्मानाचा स्वीकार करावा. अकलूजमध्ये आज
Dr.
तरुण
Trupti
डॉक्टरांची
Sid madam.
तरुण डॉक्टरांची या ठिकाणी आपल्याला फळी पाहायला मिळते. सुंदर असं कार्य त्यांचं या ठिकाणी आहे. डॉक्टर सिद मॅडम यांचा सन्मान या ठिकाणी व्यासपीठावरती संपन्न होतोय. त्यांना विनंती आहे आपण आमच्या या सन्मानाचा स्वीकार करावा.
Dr. Praveen Shinde sir. Dr. Praveen Shinde sir.
डॉक्टर प्रवीण शिंदे सरांचा सन्मान या ठिकाणी मान्यवरांच्या शुभ हस्ते या ठिकाणी संपन्न होतो आहे. आणि पुन्हा एकदा सांगतो की हे नॅपकिन बुके आहेत आणि याचा वापर या ठिकाणी आपल्याला करता येतो आणि म्हणून या ठिकाणी खास प्रकारची बुके या ठिकाणी बनवण्यात आलेली आहेत.
Dr. Dhobळे sir. Dr. Jnanadev Dhobळे sir.
डॉक्टर ज्ञानदेव ढोबळे सर यांचा सन्मान या ठिकाणी व्यासपीठावरती संपन्न होतोय. त्यांना विनंती आपण आमच्या या सन्मानाचा स्वीकार करावा.
Thank you Dr. Kulkarni sir. Thank you chief guest. Now I hand over this session to Dr. Manasi.
Now I request respected Dr. N.K. Namdar sir to deliver his thoughts for 2 minutes.
माननीय डॉक्टर एम के नामदार सर या ठिकाणी या कार्यक्रमाच्या निमित्तानं आपलं मनोगत या ठिकाणी व्यक्त करत आहेत. त्यांना विनंती आहे कार्यक्रमाच्या निमित्तानं आपण आपलं मनोगत व्यक्त करावं. डॉक्टर एम के इनामदार सर.
Today's chief guest, Sri Dr. Ravi Vankadkar sir, Treasurer World Medical Association and past President, National President, IMA. Dr. Ramkrishna Lunde, President, IMA. Dr. Anil Achanekar, past president IMA, Dr. Pankaj Bandarkar, secretary IMA, Dr. Rajiv Agrawal, treasurer IMA, Dr. Ravindra Kute, vice president IMA, Maharashtra, Dr. Jayant Naurange sir, sir, chairman IMA AMS Social Security Scheme, Dr. Prakash Marathe, secretary IMA MS Social Security Scheme, Dr. Santosh Kulkarni, chairperson PCP PNDT, President Dr. Khartare, Secretary Dr. Nitin Rane, and my dear friends. I am here to thank on behalf of IMA Cluj or chairpersons IMA Cluj, where Cluj has witnessed so many things in last so many years. Cluj medical field has taken leaps and bounds from last 50 years. And of course, I am a proud witness for last 42 years. It is from general practice to subspecialty. I am fortunate enough to witness all this. Evolving medical expertise and technology was caught up on very fast pace by Cluj. From simple surgeries to most complicated surgeries, complex surgeries, even the open heart surgeries are possible in Cluj. From single lead ECG to almost an invasive cardiac monitoring is possible in Cluj. In last 50 years, all simple diagnostic techniques to almost all sophisticated diagnosis is possible in Cluj. Small procedures, IV line to almost complex angioplasties is possible in Cluj nowadays. So in every branch of medicine, it has progressed very well. There was only one drawback up till now was that we could not arrange big conferences, district level or state level, only because it is a small place and we cannot accommodate this. Maybe it's a semi-webinar type of conference, but we have arranged it, and I'm sure in future we will continue with this, and we'll be arranging some state level conferences for this. I really appreciate all IMA team, president, secretary, all office bearers, and all volunteers who have taken immense pains and efforts to make this conference very successful. I am thankful to all dignitaries who have come from long distance to appreciate our work and to give us shabaski. Thank you very much. Thank you.
Thank you so much.
Now I would request Dr. Ravi Wankhedkar sir, Treasurer, World Medical Association and past National President, to come on the dais and please share his thoughts.
Very warm good morning. आजच्या या महाराष्ट्र स्टेट IMA AMSCON च्या उद्घाटन प्रसंगी अध्यक्षस्थानी असलेले व महाराष्ट्र राज्य शाखेचे अध्यक्ष आमचे सन्मित्र डॉक्टर रामकृष्ण लोंढे सर, अत्यंत शांतपणे कुठलाही आवाज न करता ज्यांचं कार्य चालू असतं ते महाराष्ट्र राज्याचे सचिव डॉक्टर पंकज बंदरकर, संपूर्ण आर्थिक जबाबदारी अत्यंत समर्थपणे जे पार पाडतात आहे ते आमचे बंधुतुल्य खजिनदार डॉक्टर राजीव अग्रवाल, अत्यंत दिलखुलास व्यक्तिमत्व व ज्याला मी अनेक वर्षापासून नॅशनल IMA चा हिरो नंबर 1 म्हणतो, ते महाराष्ट्र राज्याचे माजी उपाध्यक्ष व माजी राष्ट्रीय उपाध्यक्ष डॉक्टर अनिल पाचनेकर, आमचे गुरुतुल्य डॉक्टर जयंत नवरंगे सर, डॉक्टर प्रकाश मराठे, ज्यांच्यामुळे आज मी अकलूजला येऊ शकलो, ते माझे लहान बंधू व IMA अकलूज शाखेचे अध्यक्ष डॉक्टर संतोष सचिव डॉक्टर नितीन, इमिजिएट पास्ट प्रेसिडेंट डॉक्टर नितीन इकतपुरे आणि सध्या महाराष्ट्र राज्याचे उपाध्यक्ष व सन 21-22 साठी ज्यांची बिनविरोध अध्यक्ष म्हणून निवड झालेले आमचे सन्मित्र डॉक्टर रवींद्र कुटे, आमचे दुसरे लहान बंधू अतिशय तळमळीने मेडिको लिगल असेल किंवा कुठलाही प्रश्न, सर याचं असं केलं पाहिजे असा 2 दिवसाआड हा मेसेज 100% करणारे व अत्यंत तळमळीने आपली प्रत्येक व्यथा, त्यांची व्यथा नसते ती आपल्या सगळ्यांच्या वतीने ते मांडतात, ते डॉक्टर संतोष कुलकर्णी. आज सर्वप्रथम आपल्या सगळ्यांनाच शिक्षक दिनाच्या एका वैद्यकीय शिक्षकाकडून आपल्याला सगळ्यांना शुभेच्छा. आज खरं तर प्रथम मी आमचे IMA गुरु डॉक्टर नवरंगे सरांना खरंच नमन करतो. तसेच या ठिकाणी उपस्थित असलेले वयाने ज्येष्ठ, सर्वात गोष्टींनी श्रेष्ठ असलेले आणि मी एक सर्जन असल्यामुळे डॉक्टर अरविंद गांधी सर आणि सर्जनला जे लागतात सगळं, ज्याच्याशिवाय सर्जरी होऊ शकत नाही, असे आमचे ज्येष्ठ अॅनेस्थेटिस्ट डॉक्टर सिद्धापूर, पॅथॉलॉजिस्ट डॉक्टर संतोष जोशी, गायनेकोलॉजिस्ट डॉक्टर सतीश जोशी आणि ज्यांचं नाव संपूर्ण महाराष्ट्रात आहे आणि खरोखर गेली 40-50 वर्ष या भागात ते अविरत सेवा देतात आहे असे आदरणीय डॉक्टर इनामदार सर, आपल्या सगळ्यांनाच तुम्ही गुरु म्हणून मी वंदन करतो. खूप बरं वाटतं यंग डॉक्टर्स इथे आहेत, त्या सगळ्यांनाही शुभेच्छा. खूप बरं वाटलं आजच्या शिक्षक दिनी माझा एक अंडरग्रॅज्युएटचा विद्यार्थी आज आपल्या शहरात चांगली सेवा देतोय, डॉक्टर सुनील, आणि संपूर्ण टीम जी AMSCON ची आहे. सर्वप्रथम आपलं मी खरोखर अभिनंदन करतो की 1200-1500च्या वरती आज इथे रजिस्ट्रेशन झालेले आहेत आणि खरोखर ही एक खूप चांगली गोष्ट आज इथे आहे. मित्रो, सर्वप्रथम आज खरं मला दिल्लीला असणं अत्यंत गरजेचं होतं. आज शिक्षक दिनानिमित्त नॅशनल IMA प्रोफेसरशिप्स संपूर्ण भारतातल्या विशिष्ट 10-10-10 अशा 30 प्रोफेसर्सचं चयन करून त्यांना IMA प्रोफेसरशिप प्रदान करण्याचा खूप मोठा कार्यक्रम आहे. ती जी अकॅडमिक काउन्सिल आहे ज्यांनी हे सिलेक्शन केले त्याचा मी प्रमुख आहे. आय एम चेअरमन ऑफ दॅट कमिटी. तरी देखील मी दिल्लीला न जाता ठरवलं की आपण अकलूजलाच जायचं. खूप मोठा दबाव होता माझ्यावर की असं कसं होऊ शकतं की यू आर चेअरमन अँड इफ यू विल बी ऍबसेंट व्हॉट, हाऊ कॅन वी डू इट. परंतु त्याची 3 कारणं होते मित्र. एक म्हणजे अकलूज सारख्या रिलेटिव्हली छोट्या गावात ज्या वेळेला स्टेट कॉन्फरन्स सारखी एवढी मोठी ऍक्टिव्हिटी तुम्ही करतात, तेव्हा आमच्या सारख्यांचं कर्तव्य बनतं की तुम्हाला इथे येऊन प्रत्यक्षात प्रोत्साहन देण्याची गरज असते. दुसरं कारण, 2013 साली मी AMS चा नॅशनल चेअरमन होतो, त्याच्यामुळे AMS या विंगशी माझा विशेष लगाव आहे. आणि त्याही पेक्षा सगळ्यात महत्वाचं कारण म्हणजे आमचा भाऊ लहान संतोष खडतरे. आजपर्यंत कुठल्याही कार्यक्रमाला किंवा IMAच्या कुठल्याही कामाला त्याला एक फोन करावा आणि ते त्यांनी 100% करावं. आणि इतक्या वेळा त्यांनी आमंत्रण दिलं, परंतु असंच काहीतरी कुठला तरी दुसरा कार्यक्रम, राष्ट्रीय आंतरराष्ट्रीय कार्यक्रम असायचा आणि अकलूजला येणं कॅन्सल व्हायचं. आणि म्हणून मी या वेळेला ठरवलं, दुनिया इकडची तिकडे झाली तरी चालेल, आपल्याला अकलूजला जायचंच. आणि खरोखर मला खूप बरं वाटतंय आज इथे इतक्या चांगल्या पद्धतीने आपण ही कॉन्फरन्स आयोजित केली. मी छोट्या गावातून येतो, धुळं तसं काही फार मोठं नाहीये आणि त्या ठिकाणी अशा प्रकारचे कार्यक्रम घेण्यात किती अडचण येते हे आम्ही गेले 30 वर्षापासून बघतोय. की अगदी सुरुवातीला हॉटेल्सही नव्हते, त्यावेळेला आम्ही सर्जरीची स्टेट कॉन्फरन्स 89 साली घेतली होती, तेव्हा आपल्याच डॉक्टर मित्रांच्या घरी एक एक स्पीकरला ठेवणे, इथपासून तर आता तर परिस्थिती सगळीकडे खूप बदलली आहे. आज या ठिकाणी आपण सारखं म्हणतो की छोटी ब्रँच, but let me tell you friends, I have been moving around this IMA work for last 4-5 years throughout the country, and it is my firm belief that the strength of IMA is in local branches. It is not in the state, and least of it in the headquarter. अत्यंत जबाबदारीने एक माजी राष्ट्रीय अध्यक्ष हे विधान करतोय की IMA ची ताकद ही स्थानिक शाखांमध्ये आहे. जितक्या स्ट्रॉंग आपल्या लोकल ब्रांचेस आहेत, ती खरी स्ट्रेंथ इंडियन मेडिकल असोसिएशनची आहे. आणि असं अजिबात समजू नका की आपली छोटी ब्रांच आहे. सॉरी टू से, नो ऑफेन्स टू पुणे और मुंबई ब्रांच, परंतु 4-4 हजाराच्या ब्रांचेस मध्ये देखील आपण कार्यक्रम करतो तेव्हा एवढीच उपस्थिती असते. आणि आज इथे जवळजवळ अकलूज ब्रँचची 100% उपस्थिती आहे. ही स्ट्रेंथ आहे, ही ताकद छोट्या गावातल्या डॉक्टरांची आहे. आपल्यात एकी भरपूर असते, एकोपा असतो, काहीतरी करण्याची जिद्द उमेद असते, आणि त्यामुळे IMAचं नाव आज भारतातल्या कानाकोपऱ्यात पसरण्यासाठी आपल्या लोकल ब्रँचेसला सर्व क्रेडिट जातं. हेडक्वार्टरचं काय, एक फतवा काढतं, एक ईमेल पाठवतं स्टेटला, स्टेट एक ईमेल पाठवतं सगळ्या लोकल ब्रँचेसला. अल्टिमेटली काम हे लोकल ब्रँचेस मार्फतच होत असतं. आणि म्हणून सातत्याने मला अभिनंदन करावं असं वाटतं आपल्या स्टेट प्रेसिडेंट डॉक्टर लोंढे सरांचं. पण गेले सातत्याने ते कोरोनाचा काळ असला तरी सातत्याने छोट्या छोट्या ब्रँचेसला भेट देतात, त्यांच्या अडचणी समजून घेतात, त्यांना प्रोत्साहन देतात, आणि त्यामुळे आपली आज IMA संघटना नावारूपाला हळूहळू येत आहे. Everybody knows the golden era of medical practice is over. Whatever seniors, Dr. Inamdar already mentioned it in his speech. He is a first-hand witness to the changing scenario of the medical fraternity. The golden days are over. Maybe our era was silver era, but today my young friends are facing n number of problems in practice. May it be violence, may it be media trial, may it be assaults by various laws, legal actions, so on and so forth. Hence, Indian Medical Association is also changing its tenor, its work culture from a purely voluntary NGO to a trade union like activities, because it is the need of hour. The need of hour is to come together, to be united, to fight all these assaults. Gone are those golden days when the society is to think that we are cream of society. Unfortunately, today they think that we are criminals of the society. If you see the headlines की डॉक्टर लुटारू, एका बाजूला कोरोनाचं गुणगान गायचं आणि दुसऱ्या बाजूला हॉस्पिटल लूट करतात हे म्हणायचं, हॉस्पिटलचे चार्जेस कॅप करायचे, सगळी जबाबदारी हॉस्पिटल्स आणि डॉक्टर्स वर टाकायची की ऑक्सिजन नाही राहिला तरी तुम्हीच जबाबदार, औषध नाही मिळाले तरी तुम्हीच जबाबदार. हा असा दुजाभाव सातत्याने वाढत चालल्यामुळे ही काळाची गरज आहे की आपण आपल्या मदर ऑर्गनायझेशनच्या माध्यमातून आज इथे एकत्र आलं पाहिजे. आपण एकत्र येत आहोत. आपसातले मतभेद जरूर असतात. इंटलेक्च्युअलची संघटना बांधणे तेवढीच कठीण असते, कारण इथे प्रत्येक जण इंटलेक्च्युअली, फायनान्शियली, ऍडमिनिस्ट्रेटिव्हली ऑटोनॉमस असतो. तसं म्हटलं तर कुठल्याही डॉक्टरला संघटनेची गरज नाही, परंतु आज परिस्थितीचा रेटा एवढा आहे की आज आपल्याला एकमेकांचा साथ देणं ही काळाची गरज आहे मित्रांनो. आणि मला नक्कीच खात्री, मी जिथे जिथे जातो तिथे वुमन डॉक्टर्स ऍक्टिव्ह असतात, जिथे यंग डॉक्टर्स ऍक्टिव्ह असतात, तिथे IMAचं भविष्य मला नेहमीच चांगलं दिसतं. कारण तरुणाईमध्ये तो एक जोश असतो, नवीन काहीतरी करण्याचा एक उत्साह असतो. आणि इथे मला तो संगम दिसतोय की सिनियर्स मार्गदर्शन करून ज्युनियर्सला देखील बढावा देतात, ते पुढे आणतात आहे. म्हणून आपली काळाची गरज परत एकदा मी अधोरेखित करतो की आपली युनिटी ही सगळ्यात महत्वाची. आपण डॉक्टर झालो ते व्हॉलेंटरीली झालो, कोणी आपल्याला फोर्स नाही केला. मी कुठे जन्माला आलो माझ्या हातात नव्हतं, मी कुठल्या धर्मात जन्माला आलो माझ्या हातात नव्हतं, परंतु मी डॉक्टर होणं वॉज माय कॉन्शियस चॉईस. हेन्स वी कॉल IMA ॲज अ फ्रॅटर्निटी ऑर्गनायझेशन. इथे असलेला प्रत्येक डॉक्टर माझा भाऊ किंवा माझी बहीण आहे. ही आपली मदर ऑर्गनायझेशन आहे आणि तिच्यासाठी प्रत्येकाने जमेल तेवढं जमेल तसं कॉन्ट्रीब्युशन दिलं पाहिजे. कोणाला वेळ येता आला संतोष सारखा तर त्यांनी वेळ द्यावा. ज्यांना वेळ देता येत नाही, जे प्रॅक्टिस करतात त्याच्यातून पैसे कमवतात, त्यांनी त्यातले थोडे पैसे एका दिवसाचे पैसे IMA ला द्यावे, IMA कार्यात द्यावे. जे VIP डॉक्टर्स आहेत, समजा आज इनामदार सर आहे, त्यांच्याकडे आमदार खासदार मंत्री ट्रीटमेंटला येतात, त्यांनी त्यांच्या कानात सांगावं की हो हा क्लिनिकल एस्टॅब्लिशमेंट ऍक्ट खराब आहे, आमचा फायर NOCचा प्रॉब्लेम आहे, आमचा हॉस्पिटल रजिस्ट्रेशनचा प्रॉब्लेम आहे. प्रत्येक जण काही ना काही आपल्या संघटनेला कॉन्ट्रीब्यूट करू शकतो. अशी अपेक्षा अजिबात नाही की सगळ्यांनी इथे जे स्टेजवर बसले त्यांच्यासारखं मिशनरी म्हणजे घरादारावर तुळशीपत्र ठेवून फिरणे अशी अपेक्षा देखील नाही. पण आपण आपल्या जागी बसून आपल्यात असलेले गुण, आपल्यात असलेली कॅपॅसिटी, एव्हरीबडी कॅन कॉन्ट्रीब्यूट. नेव्हर फील दॅट वी आर सॉफ्ट टार्गेट्स. डॉक्टरांकडे काय कमी आहे? बुद्धिमत्ता, पैसा, संबंध. मग आपण का घाबरतो? आपण घाबरतो कारण आपण एकत्र यायला घाबरतो. लोक काय म्हणतील? लोक ऑलरेडी वाईट म्हणतात ते आपल्याला. अजिबात फिकीर करू नका त्याची की डॉक्टरांनी रस्त्यावर कसं उतरायचं, डॉक्टरांनी बंद कसा पाळायचा. तो गेला जमाना. म्हणून परत एकदा वेळेअभावी परत एकदा मी येईल अकलूजला, आपल्याशी अजून जास्ती हितगुज साधेल. मला इथं बोलवलं, माझा सन्मान केला. अतिशय चांगली ही परिषद आज आपण काल आणि आज इथे आपण आयोजित केली, त्याबद्दल परत एकदा संपूर्ण टीमचं अभिनंदन. जे निवेदक आहेत, निवेदिका आहेत, ते देखील खूप चांगलं काम करता आहेत. आपलं देखील अभिनंदन. धन्यवाद. जय हिंद, जय IMA.
Thank you, Ankhetkar sir, for your motivational speech.
आज प्रेसिडेंट स्पीचच्या अगोदर मला थोडासा जे आत्ताच सरांनी सांगितलं, निवेदकांनी खूप चांगलं निवेदन या ठिकाणी केलेलं आहे. सगळ्यांचा सन्मान झालेला आहे. मला आपल्या ह्या चारही निवेदिकांना स्टेजवर येण्याची मी विनंती करतोय. प्रिया मॅडम, आदिती मॅडम, मानसी मॅडम आणि रेवती मॅडम, आपण चौघींनी या स्टेजवरती यायचंय. मी रवी वानखेडकर सर आणि लोंढे सरांना विनंती करतो की 1 बाय 1 आपण निवेदकांचा सन्मान करावा. या ठिकाणी डॉक्टर निनाद, डॉक्टर सचिन फडे. ऑफिस बेअरर मध्ये ज्यांचा सन्मान राहिलाय त्यांनी वरती यायचंय. डॉक्टर संभाजी, शेटे सर तुमचं झालंय का? ऑफिस बेअरर मध्ये डॉक्टर सुनील नरोटे, चला जरा थोडस चला सर्वांनी यायचे पटकन. एक कोऑर्डिनेटर राहिलेले आहेत डॉक्टर सुजित गांधी सर. विद्यार्थ्याचा सन्मान या ठिकाणी होत आहे. डॉक्टर सुनील नरुटे सर हे रवी सरांचे विद्यार्थी आहेत. श्रीकांत देवडीकर सर. बालरोग तज्ञाचा सत्कार करताना या ठिकाणी आम्ही डॉक्टर बाहुबली दोषींना विनंती करतो की आपण स्टेजवरती यायचंय. ब्लड बँकेचं खूप चांगलं काम बघतायत ते. डॉक्टर प्रज्ञा गांधी मॅडम. डॉक्टर तृप्ती मॅडम. डॉक्टर सचिन गवळी. यायचे सर फास्ट मध्ये, ऑलरेडी आपल्या कार्यक्रमाला उशीर होतोय. जोशी मॅडम या. एक सन्मान हॉलमध्ये राहिल्यासारखा वाटतोय बहुतेक. डॉक्टर सुप्रिया खडतरे मॅडम. डॉक्टर रवी वानखेडकर सरांना विनंती आहे की आपण डॉक्टर सुप्रिया खडतरे मॅडम यांचा सन्मान करावा. सचिन गवळी सर झाले. सर्वांचे सन्मान या ठिकाणी झालेले आहेत. अनावधानाने कुणाचा राहिला असेल तर त्या ठिकाणी माफ करावं. सर्वात छान सूत्रसंचालन आज आमच्या IMA डॉक्टर्स बरोबर या ठिकाणी केलेलं आहे. सर, आज शिक्षक दिन आहे आणि शिक्षक दिना दिवशी एखाद्या शिक्षकाचा सन्मान करणं हे खूप छान मला या ठिकाणी वाटेल. मी आदरणीय गुजर सरांना या ठिकाणी विनंती करतो की आपण स्टेजवरती यावं आणि आपण सर्वांनी टाळ्या वाजवून त्यांचा आभार व्यक्त करावेत. IMA कुठलाही कार्यक्रम असला तर अतिशय सुंदर असं निवेदन गुजर सर नेहमीच करत आलेले आहेत. स्टेजवरील माईक अध्यक्षांच्या हातात देण्यापूर्वी मी IMA महाराष्ट्र स्टेटसाठी आताच रवी सरांनी सांगितलं की जेव्हा तुम्ही कार्यक्रम घेता तेव्हा कार्यक्रमापैकी काहीतरी हातभार IMA महाराष्ट्र स्टेटला आपण लावला पाहिजे आणि त्याचाच एक भाग म्हणून IMA अकलूज तर्फे मी आज ₹25,000चा चेक महाराष्ट्राचे अध्यक्ष ट्रेझरर यांच्या सन्मान प्रदान करत आहे. मी सेक्रेटरी सर नितीन राणे IPP एकतपुरे सर.
Thank you for the appreciation and motivation, sir. Thank you. Now I request Dr. Ramkrishna Londe, sir, to deliver his thoughts since we are about to start the conference.
थँक्यू. सर्वांना प्रथमतः नमस्कार. अकलूजला मी चौथ्यांदा येतो इथं. रोटरीच्या माध्यमातून दोनदा आलो आणि IMA च्या माध्यमातून सरांचं इन्स्टॉलेशनच्या कार्यक्रमाला मी एकदा आलो होतो आणि दुसऱ्यांदा आलो सरांच्या. आदरणीय व्यासपीठ, आमचे मेंटॉर, फिलॉसॉफर, गाईड आदरणीय रवी सर, आमचे ऑफिस बेअरर्स पंकज सर, अग्रवाल सर, तसेच संतोष कुलकर्णी, आमचे घनिष्ठ मित्र, जवळचे मित्र, बाकीचे आहेत तसा मुद्दा वेगळा. आतापर्यंत IMA MS चे ते व्हाईस प्रेसिडेंट होते आणि यानंतर आता सरांनी सांगितल्याप्रमाणे 1-2 वर्षानंतर जे प्रेसिडेंट होणार आहेत असे आदरणीय डॉक्टर रवींद्र कुटे सर, व्हेरी डायनॅमिक पर्सन फ्रॉम मुंबई, धारावी, ज्याने की जगामध्ये नेऊन सोडली. धारावी पॅटर्न काय असतो, धारावी पॅटर्न आपण कसं कंट्रोल करू शकतो ह्याच्यामध्ये कोविडमध्ये, असे माजी व्हाईस प्रेसिडेंट, माजी स्टेट नॅशनल प्रेसिडेंट, व्हाईस नॅशनल प्रेसिडेंट, ओके, आणि माजी स्टेट प्रेसिडेंट. कारण बऱ्याचशा पोस्ट घेतल्यामुळे हा प्रॉब्लेम होतो थोडा बहुत, हा तुम्ही समजू शका. असे आमचे व्हेरी डायनॅमिक, आम्ही त्यांना नेहमीच म्हणतो की जिन्ना दिल आदमी काय असतं ते भानगड. तसे अनिल सर, अनिल पाचनेकर सर, सरांचे नावं घेणं शक्य नाही, वेळ खूप होत आहे, कारण परत पुढे जायचंय. सरांचा सारखा फोन येतोय, जायचं, सरांना द्यायचे, मला द्यायचे. आणि त्या अनुषंगाने IMA MS चे राहिलेले ऑफिस बेअरर, सोशल सिक्युरिटीचे आमचे नवरंगे सर, मराठे सर, आणि त्यानंतर आमचे पेडियाट्रिक डिपार्टमेंटचे इथले माजी प्रेसिडेंट एकातपुरे सर, सध्याचे प्रेसिडेंट आमचे खडतरे सर, त्यांचे सेक्रेटरी आणि इतर पदाधिकारी, विशेषतः इनामदार सरांचा उल्लेख केला आहे, कारण त्यांच्या पेशंटला मला भेटायला जायचंय. सर सांगायचं म्हणजे आरणकर सरांना मला भेटायला जायचं, त्यांचा आताच फोन होता. घरीच या, म्हणजे तुमचा वेळ कमी होईल. सगळ्या लोकांना बोलवलंय म्हणे घरी मी. कारण काय झालंय, आमचा प्रोग्राम सगळा म्हणजे हे विस्कटला थोडा, काही आम्ही जे टायमिंग दिला होता त्याच्यामुळे नंतर आम्ही 1 तास लेट चालू लागलेलो आहोत. आणि तुमच्या प्रेमा खातर इथे येणं आणि इथून जाणं बी अवघड झालेलं आहे. आमचा पाय बी निघाणा झालाय, पण जायचंय. सांगायचं म्हणजे प्रथमतः खडतऱ्यांचं मी मनापासून अभिनंदन करतो. त्यांनी फार चांगल्या प्रकारे सुसूत्रपणे व्हेरी मेटिक्युलसली ही जी कॉन्फरन्स अरेंज केली आहे, त्यासाठी आपण एकदा जोरात टाळ्याने त्यांचं स्वागत करूयात, अभिनंदन करूयात. विशेष म्हणजे मला आज ड्रेस कोड आवडला सर, कारण कसं असतं ड्रेस कोड मध्ये असलं की आपण ओळखतो आपण कोण आहे ते, आणि त्याच्यामध्ये मला त्यांचं अभिनंदन याच्यासाठी करायचे की मी माझ्या ऑफिस बेअररला ड्रेस म्हणजे आमचे नेम प्लेट दिल्या होत्या, सरांनी पण दिल्या, ते त्याच्यानंतर तुमचा मी आभारी सर. असं प्रत्येक ऑफिस बेअररनी, प्रत्येक प्रेसिडेंटनी, सेक्रेटरीने असं अंमलबजावणी करावी. हे जे ड्रेस कोड आहे, हे जे नेम प्लेट्स वगैरे आहे, हे मी रोटरी मधनं शिकलो सर. आपण आपल्या IMA मध्ये खूप सारं शिकतो, परंतु पब्लिक मध्ये कसं बिहेव करावं, सरांनी सांगितल्याप्रमाणे आपण एज्युकेशन क्वालिफाईड असतो, पण पब्लिक मध्ये आपण कसं राहिलं पाहिजे, कसं बिहेव केलं पाहिजे, हे आपण बाकीच्या संघटनेकडनं शिकतो. लायन्स आहे, रोटरी आहे. मी रोटरीचा माझी प्रेसिडेंट राहिलो माझ्या क्लबचा, आणि बेस्ट असिस्टंट गव्हर्नर्स मी पण अवॉर्डी आहे, सांगायची गोष्ट म्हणजे, आणि बेस्ट प्रोग्राम ऑर्गनायझर म्हणून. तो हा मुद्दा वेगळा आहे. आता मुख्य गोष्ट अशी आहे, मी सरांच्या पावलावर पाऊल टाकून म्हणा किंवा सरांचं अनुकरण करून, सर आहे त्यांच्या काळामध्ये रवी सर 50,000 किलोमीटर हे सायकल रॅली केलेली होती सरांनी, पूर्व पश्चिम दक्षिण उत्तर. एम आय राईट सर? 50,000 किलोमीटर प्रवास करणार हा महाराष्ट्रात नाही, भारतातला कोणी नाही एवढा आतापर्यंत. विमानानं करतील सांगायचं म्हणजे, पण असे बाय रोड इट इज व्हेरी व्हेरी इम्पॉसिबल, रादर इम्पॉसिबल. आणि तेच मी सूत्र अनुसरण केलेलं आहे. मी 20 जिल्हे फिरलो सर आतापर्यंत, 20 जिल्हे, 20. तुम्हालाही कल्पना करून हा माणूस कसं काय फिरू शकला असेल. मी रोडवरच फिरलो काही सांगायचं म्हणजे. आणि हे फिरत असताना सरांनी सांगितल्याप्रमाणे मी प्रत्येक ब्रँचचा प्रॉब्लेम, जाणून घेतला. आम्ही तिथून हेच केलं पाहिजे, तेच केलं पाहिजे. आम्ही आमचं स्वतःचं काय म्हणते त्याला हुद्देशाही किंवा आमचं डॉक्युमेंटिझम दाखवलं नाही तिथं. मित्रांच्या बरोबर बसलो, चर्चा केली, त्यांचे प्रॉब्लेम सॉल्व्ह करायचा प्रयत्न केला, त्याला सोल्युशन दिलं सर. नुसते आम्ही सल्ले दिले नाही, सोल्युशन पण दिले प्रत्येकाला. आणि हे करत असताना एक गोष्ट जाणवली, कोविडमध्ये गव्हर्नमेंटने आपल्याला खूप त्रास दिलाय. खूप म्हणजे ते आता आम्ही त्याला गव्हर्नमेंट असॉल्ट म्हणू शकतो किंवा सिव्हिक असॉल्ट म्हणू शकतो. आणि ते आपण सहन केलेलं आहे. आणि इथून पुढे सुद्धा जेव्हा गव्हर्नमेंट आपल्याला मदतीची अपेक्षा करेल, आपण त्यांना मदत करायची, पण कंडिशन टाकून करायची. आमचं हे करा तर आम्ही ते करू. म्हणजे सरसकट आपण त्याला काम करू नये असं माझं मत येतं. आणि माझ्या सदस्यांना अशी विनंती आहे, तुम्ही कुठल्याही संघटनेत काम करा, रोटरी करा, लायन करा, फ्रेंड्स क्लब करा, तुमचं बॅनर मागं लागलं पाहिजे. आता मी जेव्हा फिरलो, आता काल मी 7 ब्रांचेसच्या कॉन्टॅक्ट मध्ये आज झालो, तर फक्त 2 ठिकाणी आम्हाला बॅनर बघायला मिळाला. 2 ठिकाणी फक्त म्हणजे आपले प्रेयर म्हणण्यात आली, काही ठिकाणी नव्हती सांगायची म्हणजे. तर हे आपण प्रोटोकॉल पाळला पाहिजे. आणि तुम्ही जेव्हा जेव्हा बाहेर जाल तेव्हा स्वतःचा तिथं बिल्ला लावा आपल्या IMA. ते बघून ते लोक विचारतील तरी हे काय आहे, मग त्याला IMA काय आहे कळेल. किंवा तुमच्या वेटिंग रूम असतात, तिथं तुम्ही IMAच्या माध्यमातून IMAचं काहीतरी सांगा. आता बऱ्याच ठिकाणी आता टीव्हीचे काय आपण लावतो, टीव्हीचे कॅमेरे वगैरे चाललेले असतात किंवा काही सिरियल वगैरे दाखवतो, पण तिथे पण IMAचं काही राहील आपलं, जेणेकरून IMA हा त्या माणसाच्या लक्षात राहील, एक एज्युकेटेड राहील किंवा अडाणी असेल पण त्याला IMA समजेल असं आपण ठेवा. काही पुस्तकं ठेवायत लायब्ररी असतील तर आपलं बाहेरच्या बसत्या ठिकाणी, जेणेकरून आपणच आपल्या संघटनेचा एक ब्रँड अँबॅसेडर व्हावं असं मला वाटतं. चर्चेत आपण दुसरा सांगतो ही करावं ती करावं, आपल्यापासून आपण सुरुवात करावी अशी माझी धारणा आहे. दुसरी गोष्ट, जेव्हा आम्ही व्हिजिट करत होतो सर म्हटल्याप्रमाणे, काल सर मी 4:30ला गाडीत बसलो, एका ठिकाणी सांगितलं आम्ही मसवडला 9:30ला येऊ म्हणून सांगितलं, आम्ही 9:15ला पोहोचलो, मी आणि कुलकर्णी. तुम्ही थोडा टाइम बाउंड राहा, तुम्ही टाइम मॅनेजमेंट करा. असं जर केलं तर तुमचं यश तर त्याच्यामध्येच आहे, अर्ध यश. असं जर केलं गेलं तर त्याचा फायदा होईल. आणि दुसरी गोष्ट म्हणजे शेवटी आता सध्या आपण स्वतःच्या ऑफिसमध्ये गेलो, स्वतःच्या मालकीच्या जागेत गेलो मुंबईला, तर त्यासाठी फंड लागतात. मी तुम्हाला विनंती करेल सर म्हणल्याप्रमाणे 1 डे कॉन्ट्रीब्युशन, नॅशनल प्रेसिडेंट जयलालने सुद्धा सांगितले की 1 डे कॉन्ट्रीब्युशन तुम्ही द्या. तर शक्य आहे आपल्याला. आपण यापुढे आपण दुसऱ्यासाठी आपण मोफत ट्रीटमेंट द्यायचं आपण टाळलं पाहिजे. अर्ध्यावर द्या, मोफत काय देणं, का आपण द्यायचं. तोच पैसा जर आपण या कामासाठी वापरला गेला, तुम्ही काउंट करा तुम्ही किती मोफत देताय, तुम्ही काउंट करा किती मोफत द्या, तर दुसऱ्या वेळेस तुम्ही त्यातलं अर्ध मोफत द्या, अर्ध इकडे वळती करा संघटनेसाठी. आणि असं जर केलं, प्रत्येकाने जर असं केलं तर संघटना आपली खूप मोठी होईल, म्हणजे संघटनेला बळ येईल. शेवटी तुम्हाला असं सांगायचं की संघटनेमुळे तुम्ही काय करू शकता. अशी माझ्याकडे 2 उदाहरणं आहेत, ज्वलंत उदाहरणं आम्ही जवळ पाहिलेले. एक उदाहरण आहे भंडारा पेडियाट्रिशियन जे आहे ते, त्यांना कल्पना आहे व्हॉट इज भंडारा ते जळून मुलं वारले होते, 10 मुलं. त्यावेळेस मी दिल्लीला चाललो होतो, विमानतळ म्हणजे पुण्याला थांबलो होतो, गाडी आमच्या विमान उशिरा होतं. मला सकाळी फोन आला आमच्या कलिगचा, किंवा असं झालं आहे, तुम्ही काय करता, स्टेट काय करताय. मी लागलीच आम्ही स्टेट लेवलला ऑफिसमधनं पत्र तयार केलं, आणि ही पत्र तयार करून सही शिक्क्यानिशी पत्र आम्ही त्या नितीन तुरस्कर हे भंडाऱ्याचे आहेत, आपले चांगले काम करतात प्रेसिडेंट, त्यांच्याकडे आम्ही 11 पर्यंत पोहोचलं केलं. आणि 11 नंतर त्यांनी 11:30 पर्यंत ते सगळे ऑफिस बेअरर्स कलेक्टरला SP ना भेटले गेले. आणि आपले 4-5 डॉक्टर जे होते, सिव्हिल सर्जन होते, त्याच्यामध्ये कंत्राटी डॉक्टर 2 होते, सिस्टर होत्या, अशा लोकांवरचा जो मोठा गुन्हा दाखल होणार होता तो टळला. हे कशामुळे झालं, संघटनेमुळे झालं. कारण गव्हर्नमेंटवर दबाव आला. गव्हर्नमेंट ह्या लोकांवर गुन्हे दाखल करणार होते, आपली चूक नव्हती, परंतु आपण आपली चूक नाही ही आपण दरडावून सांगितले, ठोस सांगितली. असं जर केलं गेलं तर याचा एक चांगला परिणाम होतो. दुसरं एक आहे संघटना, म्हणजे आपल्या संघटनेचं बळ काय असतं. आमच्या जवळचीच घटना आहे बार्शीची. आपले एक फिजिशियन होते, त्यांना आता कोविडमध्ये तर पेशंट वारणारच आहे, इट इज बट नॅचरल. एक पेशंटच्या नातेवाईकांना, एक पेशंट वारल्याच्या त्याच्या नातेवाईकांनी त्यांच्यावर एक ब्लॅकमेलिंग सुरू केलं. सर म्हणल्याप्रमाणे म्हणजे टीव्ही मीडिया म्हणणं किंवा पत्रकाराच्या वेगळ्या मीडिया चालवणे, ट्रायल चालवणे, तेवढे पैसे द्या तेवढे पैसे द्या असं शेवटी सर वैतागले. ही वॉज व्हेरी क्वालिफाईड पर्सन, ही व्हेरी क्वालिफाईड पर्सन. परंतु सगळे मार्ग त्यांनी केले सर, स्वतःचा मार्ग म्हणजे हुद्दा वापरून बघितला, नातेवाईकाकडून पाहिलं, प्रयत्न करून पाहिलं, परंतु ते सक्सेस झाले नाही. शेवटी अप्रोच झाले IMA ला. आम्ही IMA स्टेट लेवलचं पत्र त्यांना रजिस्टर्ड एडीने पाठवले, SP ला, सिव्हिल सर्जनला, कलेक्टरला. परंतु कसं असतं, पत्रानं एवढा उल्लेख होत नाही. तुम्ही कलेक्टिव्हली जर गेला तिथं तर फरक होतो. नंतर पुन्हा ती लोकल संघटना, बाकीचे आसपासचे संघटना, काही पदाधिकारी SP ला भेटले, कलेक्टरला भेटले, प्रांताधिकाऱ्याला भेटले आणि याच्यामुळं काय झालं की त्यांचा प्रॉब्लेम मिटला. सांगायचं तात्पर्य, तुम्ही एकटा जाऊन कुठलं तुमचं काम होणार नाही. थोडं बहुत होईल, पण असे क्लिष्ट प्रॉब्लेम आहेत ते आपल्याला एकत्र सोडावं लागतील. आणि असं जर केलं गेलं तर संघटनेचं महत्व वाढत राहील. आपल्याकडे लोक आता सध्या चांगल्या दृष्टीने पाहतात, टेम्पररी का होत नाही सांगायचं म्हणजे. आणि हे जर आपल्याला इमेज चालू ठेवायचे असेल, लोक कोणी चांगलं म्हणणार नाही सर. तात्पुरतं लोकांना गरज आहे, तात्पुरतं म्हणतील, पण बहुतेक तर नाही. आता मी प्रत्येक ठिकाणी फिरलेलो आहे, मेट्रोमध्ये गेलेलो आहे, साध्या छोट्या गावात गेलेलो आहे, जिथे की 5 आणि 10 मेंबर आहेत अशा ठिकाणी पण गेलेलो आहे. तिथं मीडियम साईजचे ब्रांच आहेत तिथे गेलेलो आहे. बहुधा चांगले बोलत नाहीत. आपल्याला असं जर केलं गेलं तर आपली इमेज चांगल्या प्रकारे वाढू शकेल असं मला वाटतं. आणि हे करत असताना सर सांगितल्याप्रमाणे मेंबरशिप वाढवा, वेगवेगळ्या स्कीम्स आहेत, वेगवेगळ्या मीन्स आहेत, त्याचा उपयोग करा. सोशल सिक्युरिटी आहे, हॉस्पिटल बोर्ड आहे. जाता जाता तुम्हाला हे सांगायचं की तुमची ब्रांच मोठी आहे, मेडिकल हब आहे. सांगायचं म्हणजे 3 कॅथ लॅब आहेत, म्हणजे नॉट ए जोक. तर तुम्हाला SBI साठी फार स्कोप आहे. SBI तर तुम्ही करा, आसपासचे लोक करा. परवा कालच आम्ही दहीवडी वडूच एकत्र करायला लागले ते लोक. सांगायचे म्हणजे SBI जर आपण केलं गेलं तर एकाच बॅनर खाली आपले सगळे प्रॉब्लेम सुटतात. आपला व्यवसाय वैद्यकीयचे, आपलं प्रॉडक्ट काय आहे, सेवा आहे. तर त्याच्यासाठी जर आपण SBIच्या माध्यमातून करत गेलो काम तर सगळे प्रॉब्लेम होतील. तुमचे असॉल्ट ऑन डॉक्टरचा प्रॉब्लेम मिटून जाईल, दुसरा तुमचा कॉम्पोजिशनचा प्रॉब्लेम मिटून जाईल, बाकी सिव्हिकच्या सर्टिफिकेटचा प्रॉब्लेम मिटून जाईल. दुसरी गोष्ट म्हणजे सर, आता नर्सिंग होम ऍक्टचा आहे संदर्भ, रिन्युअलचा प्रॉब्लेम आहे. आपल्याला जो भेडसावतो प्रॉब्लेम 3 वर्षानं. तर झालं कसं, एक चंद्रपूरला मुनगंटीवारच्या माध्यमातून तिथले पॉलिटिशियन वगैरे भेटले, आपले डॉक्टर गुलवाडे भेटले, त्यांनी 10 वर्षाची मुदतवाढ दिली, 10 इयर्स. तर हेच मुदतवाढ पूर्ण महाराष्ट्रात मला लागू करायची आहे. मी गुरुवारी त्यांना भेटतोय, सांगायचं म्हणजे मुनगंटीवारला भेटतोय, चंद्रपूरला. आजच बोलणं झालं सकाळचं. आम्ही बाकीचे ऑफिस बेअरर घेऊन जातोय त्यांना भेटायला. कसं आहे, कुठल्या जरी माणसाकडनं जर होत असेल तर आपण काय करायचं, त्यात वावगं काय आहे. झालं तर आपल्या सगळ्या मेडिकल फॅटर्निटीचा फायदाच होणार आहे. असं एक आम्ही प्रयत्न करतो आहोत. दुसरी गोष्ट, नर्सिंग होम ऍक्ट मध्ये जे काही वेगळे अमेंडमेंट्स काढलेले आहेत गव्हर्नमेंटनं, सॉरी, त्या अमेंडमेंट मध्ये एवढी जागा पाहिजे, तेवढी जागा पाहिजे, वेगळे नॉर्म्स आहेत. जुनी जागा काही हलवता येत नाही. त्याच्यासाठी आपण गव्हर्नमेंटची वाटाघाटी करतोय, महाराष्ट्र स्टेट वाटाघाटी करतोय. आणि त्याच्याच बरोबर एक संघटना नागपूरची विदर्भ असोसिएशन सुप्रीम कोर्टात गेलंय. ज्या सुप्रीम कोर्टामार्फत आपण नॉन कोविड जे कॅपिंग झालं होतं ते आपण रद्दबादल केलेलं आहे. अरोरा म्हणणारे डॉक्टर आहेत, खूप म्हणजे स्टडीड पर्सन आहे, भेटलेलो मी त्यांना, आणि ते जात आहेत, त्यांनी दाखल केलेला आहे. आणि आम्ही त्यांना रिजॉइंडर करत नाही, कारण आपण इकडे गव्हर्नमेंटची वाटाघाटी करतोय बा, दोन्ही 2 टायर, आपल्या 2 डगरीवर हात जे म्हणतो ना आपण, पण आपण इथे सक्सेस होणार आहे. गव्हर्नमेंटची वाटाघाटी करतोय, एक सुप्रीम कोर्टात गेलेला आहे, तिथं पण आपल्याला फायदा होईल. म्हणजे मला सांगायचं म्हणजे या काळामध्ये सर की आपल्या स्वतःला जागा मिळाली, मेडिकलचे जे काही प्रॉब्लेम आहेत ते पण सॉल्व्ह होऊ लागलेले आहेत. 2 ज्वलन प्रॉब्लेम आहेत आपण नर्सिंग होम ऍक्ट म्हणजे रजिस्ट्रेशन आणि हे जे असॉल्ट ऑन डॉक्टर संदर्भात जे आहे वगैरे. तर ह्यामध्ये आपण प्रयत्न करतो, निश्चितच यश येईल असं मला खात्री आहे. आणि तुम्ही मला टोकन मनी जो दिलाय आम्हाला, सरबरायाम सत्कार केला, खाऊ घातलं, जाताना तुम्ही दक्षिणा पण दिली, धन्यवाद त्या तुमच्या IMA अकलूजचा. सरांनी मला 25,000 हे टोकन मनी दिली, इसाराची म्हणतो ना रक्कम देतो, टोकन मनी. आणि काही म्हणा दॅट्स, तुम्ही कुठली काय म्हणा, पण ठोस ह्याच्या, आता आमचे अग्रवाल सर शुड बी हॅपी त्यांच्या डोनेशनला. त्यांनी आकडेवारी सांगितली तर 1 लाखापेक्षा ते देणार आहेत. हा, इसाराची रक्कम ओके, तीच ना, आणखीन 1 लाख देणार, मी 1.25 लाख तुम्हाला मिळणार आहे सर, अशी मी त्यांच्याकडनं कबूल करून घेतो, वरतून घेतो. ते आता डिक्लेअर करायला सर, या सर. आणि असेच खडतऱ्यांना आपण पाठिंबा देऊ, त्यांना आणखीन पुढे घेऊन जाऊ स्टेट लेवलला, नॅशनल लेवलला. माझं त्यांना 101% पाठिंबा आहे वैयक्तिक. या सर, काय डिक्लेअर करताय सर? नो, थँक्यू सर. ओ सॉरी नाही, मी तुम्हाला कंटाळेल असं भाषण, मला जायचं आहे ना पुढं. मी जास्त बोलणार नाही तुम्हाला तर निश्चित, कारण मी पेडियाट्रिशियन आहे. मी भयंकर थोडं बोलतोय, सांगायचं म्हणजे. जास्त बोलायचं काम हे सर्जन लोकांच्याकडे आहे. ते खूप सारे, कारण लॅप्रोटॉमी करणारे लोक आहेत हे. सांगायचं म्हणजे परत माझा तुम्ही शब्द ऐकून घेतले, तुमचा सत्कार केला. विशेषतः एमओसी जी टीम आहे त्यांचा मी आभारी आहे. खूप छानपैकी सूत्रसंचलन केलं आणि सर्वांचा आभारी आहे. धन्यवाद.
Thank you so much, sir. Now I request
आभार प्रदर्शनाच्या अगोदर
काल गेलो होतो. कालच्या 6 ब्रँच मधनं मला 2,16,000 रुपये मिळाले आहे. 15 मिळाले. 2,15,000 त्याचे काही चेक्स आणलेले आहेत. आदरणीय आमचे ट्रेझरर यांना मी विनंती करतो. या
वाचून दाखव.
तुझं वाचून दाखव 1 लाख सर.
या ठिकाणी
वैयक्तिक डोनेशनला देऊ शकता. एक मंडळी आहे 25,000 रुपये काल एक वैयक्तिक संघटनेनेच द्यावा अशातला काही भाग नाही. काल मला एक जणाने 10,000 रुपये दिले, एकानं 25,000 दिले. तर तुमची दातृत्व शक्ती भरमसाठ आहे. किती द्या, वी आर रेडी टू एक्सेप्ट इट. थँक्यू सर. हा सगळे देऊ शकतात.
आदरणीय रवी सरांनी आता सुप्रिया खडतर मॅडमचा जेव्हा सत्कारच्या वेळेस आमचा सपत्नीक सत्कार केला, त्यावरून मला सर एक सत्कार राहिल्यासारखा वाटतोय. सर, आपणा सर्वांना अभिमानानं असं सांगावं वाटतं की आमच्या IMA अकलूजच्या या इथच्या निवेदिका आहेत रेवती मॅडम. तर ह्या नुकत्याच गेल्या महिन्यामध्ये मेडिक्वीन महाराष्ट्र, तर हा पुरस्कार त्यांना या ठिकाणी मिळालेला आहे महाराष्ट्राचा. तर मला वाटतं डॉक्टर रेवती मॅडमनी स्टेजवरती यावं आणि आमचे सेक्रेटरी जे नितीन राणे आहेत त्यांच्या ते मिसेस आहेत, त्यामुळे ते पण मला वाटतं एका शालीमध्ये तो सत्कार झाला पाहिजे.
ऑनलाईन 400 लोक आहेत.
सही. खर तर काल रवी सर आपण येणार आणि आपण येणार यामुळे आम्ही खूप चांगली तयारी केली होती सर. पण तुम्हाला सुद्धा कार्यक्रम होता आणि शेवटी जेव्हा कुठे सरांचा फोन आला तेव्हा मी ओळखले की पहिल्यांदा कुठे सर सांगणार की अशी अशी अडचण आहे. मी कुठे सरांना डिनाय केला. मी म्हटलं कुठे सरांना नाही, मला रवी सरांच्या बरोबरच बोलायचंय. रवी सरांनी मला काहीतरी सांगितलं होतं हे ते, आणि मग शेवटी लगेच मी रवी सरांना फोन लावला. सर म्हटले की नाही, थोडीशी इथंच अडचण आहे, उशीर लागतोय, त्यामुळे मी तुझ्याकडे उद्या सकाळी येतो. सर, खास तुम्ही येणार त्यामुळं आमचे एक सिंगर आहेत सर आमच्या IMA चे, त्यांनी खूप बहारदार परफॉर्म करतात. अमोल भैया, तुमचा सन्मान राहिला होता, तुम्ही आता उशिरा आलेला आहे. आपण स्टेजवरती यावं आणि नेक्स्ट टाइम रवी सर संध्याकाळी या सर. तुम्ही नेक्स्ट टाइम आमच्या
6 वाजेचा कार्यक्रम 8 वाजता चालू झाला, 10:30 ला संपला.
बरोबर तू बोल. मी शेटे सर, विनोद शेटे सरांना विनंती करतो की त्यांनी ज्या सर्वांना फेटा बांधला त्या दोघांचा आपण सत्कार करावा. मानसी मॅडम, ओव्हर टू यू.
Now I request Dr. Nitin Rane, sir, Secretary IMA Akluz, to come on dais for vote of thanks.
Good morning, all. First of all, I would like to thank all the dignitaries present on the stage who have come from different parts of, actually, I would say India, to this state for the IMA state conference, which has been conducted by IMA Akluz. Actually, sir, this is first kind of event we have conducted over here in a form of hybrid format. This is all new to us, but we have tried a level best, and considering the online responses and all the responses what we have got from yesterday's delegates, they have appreciated our efforts. Thank you very much, sir, for gracing the occasion. Because of your presence, the मराठीत म्हणायचं म्हटलं जसं शोभा वाढली आमच्या कार्यक्रमाची, सर. Thank you very much. So I would like to thank all the dignitaries, all the staff, all the delegates who are present over here. Not only the physical presence, also the online presence. काल सर 1600 लोक ऑनलाईन एका वेळी रजिस्टर्ड होती आणि they were viewing the program, so that was also an achievement for us. So thank you all, and we would be continuing with our scientific session after this program. All the online people are asking how we are starting, so we are starting very soon. I would also call upon Marathi sir. He would be telling us in short about the social security scheme. So please, over to you, sir. Okay, so we would conclude this presentation program and felicitation of the guest program. So now we would move on to the scientific session. Thank you.
Hello. After the short presentation by Dr. Prakash Marathe sir on social security scheme, we would start with our conference. Over to you, Dr. Prakash Marathe sir.
Hello. Hello, good morning, all of you. It will be a short presentation about one of the important schemes of IMA Maharashtra, that is Social Security Scheme. Focus करून. केलं का ते? नाही ना. Okay. I think it is the scheme which is started by Indian Medical Association, and these are the office bearers, Dr. Jayan Davrange sir, who is the stalwart and chairman of this scheme, along with me as secretary Dr. Prakash Marathe, treasurer Dr. Meenakshi Deshpande, and joint secretary Dr. Amrish Shahade. This is the team which is held by managing committee members of IMA Maharashtra across the state, as well as team of volunteers from IMA Pune. This scheme previously started in 1990 till 2005 at Pune, and afterwards from 2005 to 2019 at Mumbai, and again after 2019 it is shifted to Pune. What are the objectives of this scheme? Provide immediate financial help to the family of the deceased member to cope up the financial crisis in the immediate period after death of the member. Increase brotherhood amongst Indian Medical Association Maharashtra state life members. I think this is the graph which shows increase in the membership enrollment number of Social Security scheme of IMA Maharashtra. To start with, just the number was 336. Now it is beyond 8,300. What is the aim and objective of this particular scheme? You sow and nominee reaps. Suppose it is the mango tree, mango seed, which is by the grandfather, then the grandson or grandchildren, they get the benefit. So this is the same objective for IMA Maharashtra Social Security Scheme. So what is the basic aim? Financial assistance to bereaved family of member doctor to overcome the crisis period. And what is the difference? Difference between LIC and other insurance schemes, as compared to that, our scheme is comparatively small. It is a variable premium, very low operating cost, disbursement only on death, and no premium liability after 25 installments, though benefit amount increases day by day. No medical examination is required. Promptest payment, usually within 1 to 2 weeks, and with the list of the formalities. What are the benefits of the scheme? It starts after 1 year of membership, except in case of accidents, where benefit is extended even before completing 1 year. But otherwise, the benefit is after the death to the nominee, means to the family. So you have to contribute for 25 fraternity fund contributions only. As the membership number grows, so the death claim benefit increases. What are the highlights of this particular scheme? It is established in 1990 by stalwarts those days, Dr. Y.G. Kelkar from Pune, Dr. Jimulia from Mumbai. Dr. Y.G. Kelkar was the founder chairman, and today's enrollment number of Social Security scheme is 8,388. We have helped 460 died members so far, whose families have been given the benefit. Our goal is to reach 10,000. That is minimum 500 members every year. Nowadays, the death claim benefit given to the nominee of the doctor who is no more is rupees 8,68,100 for this year of 2021-22. All the corpus fund is invested in nationalized banks and official, which is now allowed by Charity Commissioner as well as income tax. How does the scheme work? This particular slide is very important. The life member of IMA, that is a must. And the age should be less than 60 years of age. So if you have not completed 60 years of your age, please get enrollment today only. I have given these forms to President Dr. Khartare, President Akluj for this conference. You can gather those forms and fill those forms today only. What are the basic requirements? Apart from proof of life membership of IMA, duly completed application form, age proof, check or DD of appropriate amount. Nowadays, even you can pay this amount online. Name and signature of nominee, passport size photograph of member and his nominee. No medical examination is required. This is very important. So out of FFC of rupees 2,000 per day, what you have to give. Whenever you go for some birthday or marriage, you give gift to that person. But whenever it is a death, it is a sad situation, you don't give anything. So this is the opportunity to help the doctor's family at the time of his or her death. So you have to just contribute 200 rupees per death. And this is the way the calculation has to be done for that FFC. This particular chart shows how much membership fee you have to give at the start. So it depends upon your age. Less is the age, less is the amount. More is the age, more is the amount. But that way, before 60 years of age, you must try that. So don't wait and take this opportunity. What is the schedule of FFC payment? The notice is sent in the month of April by post, email or SMS. And you have to pay by 31st of May without late fees. And for 2021, now before September end, you have to pay that particular amount. To start with, it was 13,612. Now it is with the late fee of 354. So it comes rupees 13,966. Those who have not paid till date, I think this is the last opportunity to pay this amount before September end. If you don't pay in the month of October, that is from 1st October, your name gets deleted and you become revivable defaulter. So don't miss this opportunity. Pay as fast as possible. If you are going abroad, if you may not remember to pay the FFC, I think you have got the provision of paying voluntary deposit minimum rupees 10,000, and then in multiples of 5,000 you can pay with the scheme. It is without interest, but this is an opportunity for you to keep some deposit in the scheme, so that in case if you forget to pay FFC, your membership is not deleted. Again, there is some same sort of scheme at national level that is called as National Social Security Scheme. You can also avail that particular opportunity. Again, the eligibility is comparatively the same. So some distinctive points between national and state social security scheme. In National Social Security Scheme, no provision of disability claim settlement, whereas in state, it is there. In National Social Security Scheme, no provision of several reminders, and revival after default is not possible. In case of new members of IMA joining beyond 40 years of age, will have to wait till 3 years of IMA membership is completed in case of national. In case of state, you can just apply if you are IMA member. National scheme is run at Ahmedabad, whereas state scheme is run at Pune. So this is the present scenario. IMA Maharashtra membership more than 46,000. Members are 8,000 odd. Nationally, there are 3,50,000. Membership is around 19,000. So in short, if you see that many members, they have got the potential to become members of Social Security scheme. So don't lose that chance. So again, moving forward, this is the COVID era. There are unfortunate incidences for the doctors and their families are in trouble. So don't miss this opportunity. Take membership and safeguard your families. Don't wait even for a day. Collect the forms today and submit tomorrow, and you are the member of Social Security scheme. So in this particular COVID-19 pandemic, I think the importance of this scheme is very much. So don't lose the chance. And this is our team, our President Dr. Londe, our Chairman Dr. Navrange sir, and my office bearers of Social Security scheme. Thank you, AMSCON, IMA Cluj, for giving me this opportunity to present few words about Social Security scheme. Thank you. Thank you so much.
Thank you, sir. Now we would proceed with the session. For the first talk, we have cardiology session and the renowned speaker, Dr. Suhas Hardas sir. To coordinate the session, I call upon Dr. Sambhaji Raut and request him to welcome the chairpersons for the session.
Good morning, all. Today, our first session will be Nightmares in the Cath Lab, and our speaker will be my teacher, Dr. Suhas Hardas sir, who is currently Director of Cardiology at Sahyadri Group of Hospitals. Now, I call upon Chairperson, our eminent Dr. M.K. Inamdar sir, to chair this session. Actually, Inamdar sir, as such, he doesn't require any introduction, but he is an astute physician, practicing cardiologist, and I would say he is a super specialist of all the specialties. He has almost 40 years of vast experience of clinical practice, one of the few physicians to get fellowship of American College of Cardiology, that too at the after the age of retirement, that too after 60. And his passion and zeal for clinical practice, it still inspires many of our young generation doctors to become like him. Our other chairperson will be Dr. Vivek Gujar sir. I would call upon Dr. Vivek Gujar sir to chair the session. He is also one of the senior physicians with almost 25 years of vast experience in clinical practice of medicine. He is always ready to help. Attitude has attracted many of our doctors, young doctors. He is our mentor and guide to our many young generation doctors. Over to the
Now I request one of the chairpersons to please introduce today's speaker, Dr. Suhas Hardas.
Good morning and welcome you all. Dr. Suhas Hardas is a renowned senior cardiologist in the city of Pune. He His astronaut skills in the complex angioplasties, device implants, and various forms of cardiac therapies. They are very well known to the entire world. Recent accomplishments of TAVR, transcatheter aortic valve replacement on high to medium risk patients. He is a gold medalist in the various levels. He is known for his dedication, transparency, and the patient's centric attitude to his field. Recently, he is a head of Department of Cardiology, Sahyadri Group of Hospital, Pune. Over to Dr. Suhas Hardas.
Good morning to you. I think, can I have the privilege of sharing my screen, please?
Yes, sir. You can now. Yes, sir.
I can?
Yes, sir. I have stopped the sharing. You can share your screen.
Okay.
Yeah.
Yes. Is my screen visible?
Yes, sir.
All right. So good morning to all of you. I think we are already 1.5 hours late, but I must congratulate the office bearers of IMA Akluz for having put up a wonderful show of solidarity, unity, and strength, which is absolutely required at this time of the clinical practice that we are in. A few weeks back, when my student Samba approached me and asked me, sir, would you like to give a talk? I wasn't sure what the forum was going to be. Until very recently, I found out that the forum is going to be a mixed bag of practitioners from all areas, which means I have to cater to probably gynecologists, surgeons, and make my talk little simpler. At the end of my talk, if there are any queries, I'm more than happy to answer them. Basically, the title of my talk is Nightmares in Cath Lab. Now, first of all, let me bring out very, very important thing about nightmares. It is commoner in children. It is commoner in young adults, which means people who are naive to various experiences in life, they get more nightmares than people who are older and more matured in life. The second important thing is that it is very commonly seen during REM sleep, which is a deeper form of the sleep. And therefore, if you are sleepy or if you are sleeping in the cath lab, the nightmares are bound to occur. And most importantly, one should not forget that it is actually not a dream and it's a reality. So it may be a nightmare, but it's a reality that is happening in front of you. And it has been very rightly said that a good judgment comes from experience and experience comes from bad judgment. Now, I have my reservations about this particular statement, which I will subsequently make a mention about. There are certain things that I should mention at the beginning of my talk, that there are complications, there are nightmares, which may be dissections of the coronary arteries or various arteries, the access arteries, the perforations which can take place in the coronaries and the access arteries, the embolism, whether it is air embolism or a clot embolism or catheter piece embolism, sometimes when we tend to use and reuse and reuse catheters, especially in the peripheries. When I asked Dr. Raut as to why did you want me to speak about this particular topic, now I realize that it is more relevant because there are a lot of cath labs mushrooming in the periphery, and a lot of people are doing interventions and taking patients to the cath lab for treatment. 20 years back, when I met Dr. Inamdar, I must tell you, Dr. Inamdar, are you there? That yes, I was quite astonished to see your work.
Yes, sir. I'm
I was wondering, I used to wonder how come you could do gastroscopies so very effectively when you were actually a physician. I was surprised to see the way you handled variety of critical hemodynamic unstable patients and did a beautiful job with ventilated patients. I was wondering whether you are an intensivist at heart. Then I came to know that you were doing bronchoscopies. I was only hoping, because I must tell you that you have a lion's share in my initial success in the practice. You have contributed immensely. You have supported me immensely. I was only hoping that you don't turn into a cardiologist. Well, over a period of time, you did turn into a cardiologist as well. And I'm glad that you are manning a cath lab and very effectively running it.
Sir,
So
sir,
today's talk.
Sir, I'm international physician.
Yeah, that's actually a good term. I must accept that today's talk is actually dedicated to Dr. Inamdar and to Dr. Raut, who is my student, actually, who is one of my best students. Coming back to the complications and nightmares, you can have situations like non-deflation of the balloon. You can have bleeds at various sites. You can have intracranial bleeds, retroperitoneal bleeds, gastrointestinal bleeds, etc. You can have very gory dissections of the coronaries. Here is one of the nightmares that you see in the cath lab when you are actually doing the procedure. As you do the procedure, the patient begins to develop a big swelling in the groin and hematoma, which can worsen subsequently. Then the patient is shifted to the intensive care unit or to the wards. We have shifted, in fact, I have shifted from femoral route to radial route long back. And today, I think I do most of my coronary interventions, whether they are 7th French access, also through the radial route, believing that the radial route gives rise to lesser complications, lesser hematomas, lesser formations of AV fistulas, etc., etc. But mind you, there are situations where you can have compartment syndromes, you can have radial hematomas, you can have hematoma along the brachial artery, and you can have a situation like this. Another nightmare is the formation of AV fistula, and this happens when you have taken a puncture through the vein into the artery and gain access with a sheath across the vein into the artery, and then you have an arteriovenous fistula, which looks somewhat like this. This arteriovenous fistula can be closed by putting in a covered stent. Now, retroperitoneal hematoma, and I must tell those who are intensely concerned and are managing patients going to the cath lab, I keep on telling this repeatedly, that do not be in a hurry to tie pressure bandages, because pressure bandages will not allow the hematoma or will not allow the trickle of blood to come out, will not let you understand that the patient is bleeding, and the blood keeps on accumulating retroperitoneally, and that's how you see a very big retroperitoneal hematoma. It is so big that there is, in fact, a mass effect. Here is the hematoma. Now, coming to some nightmares like perforations. The perforations can occur because of guide wires, but most commonly, and I'm sure Dr. Inamdar and Dr. Raut will agree, that perforations occur because of balloon ruptures. The balloon ruptures can occur because there is a reuse and reuse of balloons. It can occur because your indiflator is not appropriate, and when it shows 10 atmospheric pressure, it actually is 25 atmospheres. There can be perforations during rotablation, which I'm going to show. High pressure balloon dilatations can lead, large balloon dilatations can lead to perforations, and weak media of vessels and the grafts. Here is an example of a perforation. You can see after the deployment of a stent, just a second. This is another example of a perforation due to rotablator. You can see here that there is a burr which is seen. Just a sec, please. At the top end of the guide, you can see that there is a burr inside, and this burr caused the perforation that I just showed you. However, this perforation was sealed with the use of a covered stent. This is another example of a complication due to rotablator burr. What is rotablation for those who are very naive to cardiological areas? Rotablation is a kind of a drill which goes inside the coronary and rotates at a very, very high speed, approximately 180,000 RPMs. And this burr can get stuck within the calcium in the coronary. You see here, that the burr was stuck inside the coronary and the patient had to be shifted to the cardiac surgical theaters. This is another example of a coronary perforation. You see at the top end here, the person has a very stable hemodynamic, and within few minutes, the person becomes tachycardic, and there is evidence of respiratory variability of the blood pressure, which is very common when you have a fluid or blood in the pericardium. This arrow points to the fluid, which is not actually too much, but even acutely, if you have an accumulation of a small amount of blood due to perforation, due to guide wire tip, you can have cardiac tamponade. Balloon rupture can cause perforations. Balloon ruptures are a variety of types, a linear rupture or a pinhole rupture. The rupture that you see here on the right side of the panel is the pinhole that is caused, and what happens is a very high atmospheric pressure is transmitted because of the burst of the balloon through this pinhole onto the arterial wall, causing the perforation. Here you can see at the top end that even with a very, very high pressure, there is a very tight waist seen at the point of critical lesion. This perforation due to balloon rupture was sealed with a covered stent. Abrupt vessel closures can occur at the time of angioplasty or as soon as the patient is wheeled out of the cath lab, and they occur because of severe coronary spasm. On the table, they can occur because of coronary air embolisms, formation of a thrombus within the stent, and dissections. No flow and reflow phenomena are very, very common in the acute coronary syndromes. This is the classification of various dissections. We are not going to go into the details of this. These are the two examples where the dissections are shown in front of you. One important thing for the cardiologist to understand is that if you see that there is a big luminal dilatation, if the coronary suddenly looks very, very big, it is nothing but a very bad spiral dissection, which in case extended from proximal to the distal end of the RCA and had to be fixed with multiple stents. This is another example of dissection. This is an example of coronary thrombosis, and I took up this one because the patient was transferred from occlus. But I mean, things can't be worse than this, where you have a total occlusion of the left main with a large thrombus, and after doing the thrombectomy, you can have a very good TIMI3 flow. Now, no reflow. I'm not going to go into the details of these. Coronary spasms. When you see that there is a coronary spasm, you have an associated significant ST elevation, what is called as Prince-Metals angina, and giving intracoronary nicoran or nitroglycerin will relieve the spasm completely. The necessary treatment of such a spasm is not a stent. However, in resistant spasms, stenting has been used besides intracoronary drugs that I've just mentioned. Coronary air embolism is commonly seen in uncoordinated cardiologist and assistant, where there is an aspiration when the two bursts are kept open and you see a bubbleogram like this. And the basic thing to do here is to increase the driving pressure, which is nothing but the systemic blood pressure, by giving appropriate vasopressors, making sure that patient is intermittently coughing, because coughing will increase the intrathoracic pressure, which will increase the intra-aortic pressure and will help you to drive all this air out of the circulation. Acute stent thrombosis, which is shown here, after having implanted the stent, the arrow shows that there is a formation of the thrombus, which becomes so intense that within few seconds, there's a total occlusion, which is seen in the third frame. This is another example. This is a rare thing, but I must mention here for the sake of cardiologists that stent fractures. Whenever you implant a stent at the points of angles or bends, these things occur either acutely, but they are more commonly seen on the follow-ups. So if a patient comes back to you with angina, with typical angina, but without ECG evidence, you should at least do a fluoroscopy if your fluoroscopy shows the stent, if the stent is visible fluoroscopically, or do a coronary angiogram. This is some more, few more examples of stent fracture or the split. The middle part shows you the OCT images, how the stent fracture looks, and the last image is of the intravascular ultrasound. Contrast-induced adverse reactions can be very, very intense and life-threatening, but these are now very rare, and I probably see one in every 2 years or 3 years of my practice, which is close to 3,000-4,000 odd cases. Complications which are related to medications, bleeding, very, very common. I still remember we had just taken the patient on the table for an angioplasty. I did a femoral puncture, and after having taken the femoral puncture, I gave a bolus of heparin, which was about 6,500 to 7,000 units of heparin, unfractionated heparin. And as soon as I gave that, he said he is very nauseous, and within next few seconds, he had a big bout of hematemesis. Now, this is also very important that whenever you take patients in the cath lab, you do a very proper and a meticulous assessment of associated problems. I remember one patient having needed to pass urine on the table, and when we saw what came out of the bladder after having voided the urine was clear blood, because he turned out to have a bladder malignancy that was subsequently diagnosed. It is very important that we understand patients very clearly. Unfortunately, I have felt time and again that a person, when drifts into cardiogenic shock, it is a very stepwise occurrence, and therefore the development of cardiogenic shock must not be missed in its initial stages. You can suspect that when a person is slowly developing tachycardia, is perspiring, is feeling cold, is tachypneic, looking pale, and if you have a gentleman who is diabetic, more than 18 hours of anterior wall infarction, a typical situation or a scenario when the patient is going to land up into cardiogenic shock. And this is important because when you diagnose cardiogenic shock very early, the treatment can be much more successful and the outcomes are much better. Whenever you have a hemodynamically collapsing person, please look for development of acute severe mitral regurg, which can be a very, very important reason for hemodynamic collapse. And so is interventricular septal rupture. The interventricular septal rupture in a situation, especially of the anterior wall myocardial infarction, typically occurs after 12 hours of onset of occlusion of the artery, but it occurs very slowly. And the interventricular septal rupture is not like a VSD. Yes, it is a interventricular communication, but it is slowly progressive. So if you diagnose it very early, just by way of auscultation, which is to be done timely and time and again, you would probably not miss a very large interventricular septal rupture later on. Development of bradycardias, AV blocks. Very important for the physicians who accompany their patients into the cath lab to understand what are non-sustained ventricular tachycardias, which are stable ventricular tachycardias, patients who have been successfully thrombolized and are probably getting AIVRs, and AIVRs to be differentiated from slightly rapid ventricular tachycardias and ventricular tachycardias which are absolutely pulseless. This is the overall algorithm of treating patients who have pulseless VT or ventricular fibrillation. I'm not going to go into the details, but physicians who love to accompany their patients to the cath lab where they are being treated by cardiologists, either by way of intra-aortic balloon pump or angioplasty. Please, if you can be of big help treating arrhythmias, it will be a boon for the cardiologist. Bradyarrhythmias, once again, I'm not going to go into the details of how to treat bradyarrhythmias and asystoles. One very, very important thing for the cardiologist, I must mention, you may be working in the peripheries, but you are dealing with human lives, and nothing stops you from having a good stock of snares in case you want to retrieve something which is broken, or stent which has been dislodged from the balloon, covered stents in case of various gory dissections or even perforations, or guidezilla, or what is called as the guide extension, basically. Bioptomes may be kept, but bioptomes have to be used very, very cautiously. DOC wires, the detach on command wires, how to make use of these, I think you can talk to me one-on-one, because this is a mixed bag of audience, and I'm not going to go into the details of why you should have these. Microcatheter, of course, a very, very important tool to have on the shelf. A glue can be kept, fibrin-based glue or non-fibrin-based glue. There are various types of coils. It is very, very important that people who are doing angioplasties, they know the use of coils and how to use glue, microcatheter, guide extensions, covered stents, etc., and the life support devices in case you are going for more advanced therapeutics in your cath lab. Very important, and this is an important take-home message. Never lose your access. I have seen that in panic, in a bad situation, cardiologists have actually pulled out their guides and have pulled out the wire which was across the narrowing. Your best hope of salvaging a patient in case of a complication or in case of a nightmare is having an access across the stenosis that you are dealing with. Most importantly, never lose your cool, your calm, and do not hesitate to call for help. Thank you very much.
Thank you, sir. Now I request Dr. M.K. Namdar, sir, to thank sir with the e-memento.
Thank you, Suhas, sir.
Hello, sir.
Excellent presentation.
Yeah.
Actually, you are very much expert in cath lab procedures. I like your clear ways of explaining it and doing. In all, you are my good friend and very good teacher for Sambhaji. I thank you very much for giving this wonderful talk. Thank you.
Thank you very much, sir.
Yeah, thank you, sir. Now I request Dr. Sambhaji Raut, sir, to felicitate our today's chairperson, Dr. M.K. Namdar, sir, and Dr. Vivek Gujar, sir. Thank you, sir. Thanks a lot. It was a wonderful session. And moving on to the next session, it's neurology.
My basic idea was to stick to the time. So thank you very much.
Yes, yes. Thank you, sir. And sorry for the delay. We are running really late because of the inauguration function. It started late because all the guests were traveling here. They all had come physically. Now moving on to the next lecture. To coordinate the session, I request Dr. Ninath Pade to please come on stage and welcome the chairpersons for the lecture of Dr. Ichhapuria Nasli, sir. We have been eagerly waiting for this lecture.
Hello, good morning all. Now we have the neurology session. I would like to call my friend, my mentor, Dr. Dhanesh Gandhi and Dr. Samir Bangar on the stage to introduce our chairperson, Dr. Ichhapuria, sir.
I request Danesh Gandhi sir to please introduce today's speaker.
A very good morning to all of you. Hope you all will enjoy today's Sunday. On this auspicious occasion of Teachers' Day, it's my pleasure to invite my stroke subject mentor, stroke thrombolysis pioneer in India, a dynamic, energetic, very helpful, friendly and ambitious gem of a person, Dr. Nasli Ichapuria. I wish you a happy Teachers' Day, sir.
Thank you so much. You have taught me more things than I have taught you, man.
No, it's your greatness, sir. Dr. Nasli Ichapuria is a director of neurology department at Sahyadri Hospital, Nagar Road, Pune. He reads MBBS and MD medicine from BJ Medical College, Pune, and DM Neuro from Nimans, Bangalore. He has been instrumental in setting up first neuro ICU and starting neuro-intensive care as a specialty in city of Pune. He has been a pioneer in thrombolysis treatment for stroke in India, having done the first thrombolysis and having then done more than 1,000 IV and IA thrombolysis. He has set up a first stroke unit in the city, Pune. He is an avid public speaker in the field of stroke neurology with more than 300 public lectures and workshops on stroke. He has also written extensively on stroke prevention and treatment. He has an invited speaker for numerous conferences and has been preceptor for stroke thrombolysis all over the country and abroad. He is a postgraduate teacher with numerous national and international publications and a large number of students spread all over the world. He is a DNB neuro examiner. He has started first year stroke fellowship program. Dr. Sanjay Pawar was his first student for stroke fellowship program. He is also principal investigator for a number of multinational stroke trials. He is an active member of Indian Stroke Association and organizing president of StrokeCon 212, which was held in Pune. Also an organizing president of ISS Stroke School, which was held in Lonavala in August 2014. Actually, in that stroke school, Akluz Critical Care has presented their stroke thrombolysis data. Both were highly acclaimed by stroke enthusiasts. He is the ex-president of Society of Neurosciences Pune and ex-president of Maharashtra Academy of Neurology. And recently he has been awarded as a health icon by Times of India Group. He is an honorary Rotarian. He is an avid traveler, sportsman, photographer, environmentalist, mentalist, and anthropologist. Now I welcome sir with big round of applause for his dedicated work in stroke thrombolysis in India. And because of him, the percentage of stroke thrombolysis, which was 1% in 2009, now it is 30 to 40% today. Now I am moving to now I call Dr. Ichapuria to present his lecture not on stroke thrombolysis, but today's topic is random musing on epileptic seizures. It's over to you, sir.
Sir, you can share your screen now.
Yeah, I'm trying to share this.
Yes.
Yep. Yeah. Can you see?
Sir, not yet. Yes. Now you can see, sir.
Yes. First of all, thank you very much for the very kind invitation and for the very kind words of introduction. And let me tell you that Akluz is one of the leaders in stroke treatment among the smaller cities. And it has achieved worldwide fame. Worldwide, it is not local. It's not in Maharashtra. It's not in India. And it was the work done by all the Akluz physicians has been lauded in the World Stroke Conference also. So congratulations to all of you for the dedication and the hard work that you all have done in stroke care. But today's topic I thought would be slightly different. And here I would be talking on random musings about epilepsy. So, wait, I can't get the full screen somehow. Just a minute, just a minute. Yes. So you would know, I'll just minimize this. Just a minute. Yeah. We all know that epilepsy is a very, very common disorder, and it has twice the prevalence as so many other neurological disorders, and the incidence is very high. Forget the figures. Now, if you want to be a good physician, you have to know the overall goals of treating epilepsy. The most important goal is making the patient seizure free. Now, this is not easy. It's not easy. But if you make the patient seizure free, you are avoiding all the problems that patients will have with epilepsy. So this is first primary goal. Of course, this goal cannot be achieved in many, many patients, and many patients cannot become seizure free. So this is now the next step. So even if so your first goal is to make the patient seizure free. Second goal is to avoid neurological morbidity, because they can get depressed, they can get epileptic encephalopathy, they can get status epilepticus. So many things can occur. So avoid neurological morbidity. And very, very important is to eliminate lifestyle limitations. So, these people, young people, they cannot, nobody wants to give them a job, nobody wants to marry them, their education suffers, and the quality of life suffers. And the parents also become very distraught and very upset with the whole situation. So as a good physician, you should have these three goals. They are not easy to achieve, but you must try your level best to achieve them. Seizure free, avoid neurological morbidity, and eliminate lifestyle limitations. Now, as definitions go, definitions keep on changing, human beings keep on changing. Epilepsy is a disease and not a disorder. And epilepsy occurs when the patient has an epileptic seizure. So he should have an epileptic seizure, and the brain demonstrates either by imaging or by EEG or by any other method, a pathological and enduring tendency to have recurrent seizures. So if you even have one seizure and the brain demonstrates a pathology, then this person is called an epileptic, and it is a disease and not a disorder. So even if he has one seizure and has a 60% probability of having another seizure in the next 10 years, then yes, he is an epileptic. So this definition has changed. Now, just to go through the various things, this is a little theoretical, but it's important. Epilepsy types are either focal or generalized. And if it is focal, you determine where it's coming from by various methods. Now, when you see a patient, you must ask for a seizure description. This is most important, because many, many mistakes occur in patients who come with episodic loss of consciousness. Many of them are syncope, many of them are functional, many of them are not seizures. So you must ask the patient, you must ask the witness, and you must ask the relative or the patient to describe the symptoms. And now you should ask the relative to show you a video of what happens. So this video is far important. And with home cameras, not home cameras, mobile phones and all, you can easily take pictures, and people take pictures. Also, they have color, these CCT cameras. So that also, so you must make all effort to see the seizure or whatever it is. It can be functional. So, many functional cases are diagnosed by seeing that video. You do an EEG. Initially, we used to do only interictal EEG because we didn't have the technology. But now we are able to do ictal EEGs. So if you do ictal EEGs and record habitual seizures, then your diagnosis becomes more important. So you'll be surprised that how many patients who have been labeled as epilepsy are not epileptic. And you are doing harm to the patient by calling him epileptic and by treating him for epilepsy. So you're doing more harm than good. So don't be in too much hurry. If a patient presents with 1 or 2 attacks, be very, very careful before you make a diagnosis of epilepsy, because your diagnosis can be wrong in about 30% of patients. This is not only at the community level, this is at university hospital level, you know, with old professors also diagnosing epilepsy. You can be wrong 30% of the time. So be very careful. And then if you have diagnosed epilepsy, then you try to classify it according to the seizure type. You record the frequency. Always record the triggers. The triggers are very important. You know, lack of sleep, alcohol, psychogenic drugs, so many antibiotics can produce seizures, timing of the seizure, awareness of attacks, risk factors. All these are very important if you want to treat the patient properly. And then there are so many causes of epilepsy. We won't go into all of that. There are structural, it can be metabolic because of low sodium, high sugar, high blood sugar, low blood sugar. Very, very common. You know, sugars 400, 500. They are extremely epileptogenic. And especially if the sugars are accompanied by non-ketotic hyperglycemia. You know, ketosis with acidosis protects the brain from seizures. So non-ketotic hyperglycemia, very important cause. Hypoxia, CO2 retention, the renal failure, other things, metabolic, the genetic, infection. So many infections can produce epileptic seizures. Immune. Now, you know, we've diagnosed so many cases of immune encephalopathy. We'll touch on that a little later, and some are unknown. But as I told you, we have to look at the non-epileptic seizures, very important. Depression, anxiety. Anxiety is so common, you know. They are anxious. They are anxious about getting another seizure. So anxiety, depression, attention deficit. Many of these children become hyperactive. Even older people can become hyperactive. They have cognitive impairment and they can die suddenly. Mortality, this is called sudden unexpected death in epilepsy, called SUDEP. So many epileptic patients, not many I would say, but a startling minority. You know, a person dies suddenly at the age of 25 or at the age of 30. It is a big tragedy to the family. So even though the numbers are small, epilepsy per se has higher mortality than the general population. So you must be aware of that. Now, if you look at the drug treatment for epilepsy, about 50% respond to the first anti-epileptic agent. And if you add the second one, you add 13%. And if you add the third, you had only 4%. So, you know, we find many times, many physicians are writing 3 and 4 drugs to the patient. It's stupidity. It doesn't work. Because you see, if you add the third drug, you are only increasing it by 4%. And it is producing a lot of financial strain to the family and a lot of psychological morbidity to the patient. And about 30% or 35% of these patients of the total pool are refractory to medical treatment. And you may have to do surgical treatment for these patients. So you have to be very careful with the first drug you select, because that determines how well the patient will do. Now, let's talk about how to manage seizures. You know, this is very important. And I find that, you know, most physicians are not able to understand and manage seizures in the community properly. And this is creating a lot of problems. So first is what we call brief seizures. Brief seizures are less than 5 minutes. You don't need to do anything. You don't need to give any drug for this. Okay? But what you have to do is you have to prevent injury. You have to prevent injury if these types of attacks occur. Prevent falls, prevent drowning, prevent tongue falling back. So don't put anything in the mouth. Don't give that key and onion and whatever. Just loosen the clothes, turn the patient to one side, let the saliva drip out, and that's all that you need to do. But if the seizure lasts for more than 5 minutes, then this is called a prolonged seizure. And now here you have to intervene very, very importantly. And we'll talk about this, of how you will intervene and what drug you will give to these type of patients. So this is a very important group, lasting 5 to 30 minutes. So any seizure which lasts for more than 5 minutes is dangerous. Dangerous. Less than 5 minutes, just prevent injury. Don't do anything. Just prevent injury. But if it lasts for more than 5 minutes, yes, you have to intervene. And what we call so even these prolonged seizures actually are dangerous, so you have to intervene in these. But if it lasts for more than 30 minutes of continuous seizure activity or greater than 2 sequential seizures without full recovery of consciousness, this is very important because cerebral autoregulation and neuronal damage occurs after 30 minutes. So don't let the patient go to 30 minutes. You have to act within 5 to 30 minutes. At this time, you have to be very aggressive. And most of these patients are not in the hospital. They are at home. So you have to manage these patients at home, and the caregivers have to learn how to manage these patients. Okay. And then the other group of patients is acute repetitive seizures, where the mental status is preserved. More than 3 attacks occur per day. There is an increased risk of prolonged seizures. This is physically and socially disabling, and it is a common concern of patients with intractable epilepsy. So these are little difficult to manage. Many of them, these people come to the hospital and they have to be managed in the hospital, some of them at home. So why are we talking of this 5 and 30 minutes? Because most seizures are brief. Most of them are brief, but after 5 minutes of seizure activity, the risk of prolonged seizure increases. And 5-minute threshold minimizes the risk of prolonged seizures and adverse outcomes from needless intervention during brief self-limited seizures. So don't do unnecessary intervention if the seizure is brief, but if it is more than 5 minutes, you have to act very, very fast and very, very aggressively. And after 30 minutes of convulsive status epilepticus, this may lead to permanent neuronal damage. So don't let the seizure go to 30 minutes. For God's sake, if it is more than 5 minutes, you have to be aggressive and you have to act very fast. So if the seizures last for more than 30 minutes, there is loss of cerebral autoregulation and neuronal damage, and hippocampal and neocortical neuronal loss occurs, and complications occur: hypothermia, acidosis, hypotension, respiratory failure, and rhabdomyolysis. So 30 minutes is too much, too much. You have failed if it goes to 30 minutes. Okay, so how does these present? They can present with convulsive, non-convulsive, or repeated partial. I have talked to you all about this. Non-convulsive is also very common. This subtle status epilepticus, this spike wave stupor, continuous of fluctuating epileptic twilight state. So, these convulsive, if you treat them partially, they can go to non-convulsive, or non-convulsive also can come de novo. So convulsive and non-convulsive. Non-convulsive, you will be able to diagnose with EEG. So I urge you to be able to do EEGs, especially in the ICU. And in the ICU setting, it's very important to diagnose these non-convulsive status epilepticus and treat them accordingly. Now, if you see what are the causes of status epilepticus? Now you see vascular, very, very high, highest. But I would think that in India, medication change is most important. Patients don't take the medicines, or they are defaulters, or they feel that they are okay, or you tell them to take the medicine twice a day, because of various reasons, including less money. They take it only once a day, or they stop the treatment, or they do alternative treatment with various non-allopathic drugs. So this is a very, very important thing: medication change or medication avoidance. Vascular anoxia, that means after cardiac arrest or drowning. Drug related, this is also very important. You must look at various drugs. So many antibiotics, all the quinolones can produce this, meropenem, imipenem, all of these, and there are similar many other drugs which can produce their seizures. So look at the drug history. People are using antibiotics left, right, and center for very trivial reasons, and this is also very important. And then metabolic causes, I've told you: infection, trauma, and tumor. These are the various causes of epilepsy. But most important to remember is the big three or big four. Okay, so this is mortality, I've told you. Now look at this. This is what I was trying to tell you. If the seizures last for 10 to 29 minutes, this is the mortality. But if it lasts more than 30 minutes, zoom, the mortality shoots up to 20%. So don't allow this to happen. Treat the seizures quickly, very fast, and this is very important. And after status epilepticus, also the patients don't come out normal. You treat a bad status epilepticus, they don't come out normal. They have hippocampal damage, they have cortical atrophy, they have temporal lobe atrophy, they have cognitive decline, they have secondary hippocampal sclerosis, they have cytotoxic edema. So they come out impaired. So don't allow these things to go to that level, and treat them vigorously. So how do you treat these patients? So, at about 5 minutes, the drugs to be used, and people are not using these drugs. I want to emphasize this. Lorazepam, IV. Lorazepam has to be used IV, maximum 4 milligram, and you can repeat once if it doesn't stop in the next 3 to 4 minutes. Or you can give midazolam, 10 milligram intramuscularly also. You can give it IV, but if you don't have access, if the patient is in the periphery and is in the ambulance people cannot give it, you can give it IM, not lorazepam, but midazolam. And all this while we were teaching our students that the drug of choice is phenytoin or fosphenytoin. I've stopped using phenytoin for the last 15 years or so. Now we use fosphenytoin, but very important to understand that levetiracetam, phenytoin, and valproate are all equivalent. All are equally good. And now most people in the casualty or in the emergency unit are using levetiracetam. It has overtaken phenytoin. Initially, there was a lot of skepticism that will levetiracetam also work as well as the phenytoin. But the studies have shown that it is equally good. But you have to use a proper dose. You have to use 1.5, 2 grams, 2.5 grams of levetiracetam. And this you must administer in 10 to 15 minutes. Don't let it go to 30 minutes. That 30 minute is the threshold, Baba. You have to treat the patient very quickly, 0 to 5 minutes, this thing. Yep. Okay. And then these patients come to the ICU, the neurological ICU, and then you have to do all various maneuvers and use propofol and midazolam if it goes up to more than 30 minutes. And then it becomes very difficult to manage these patients, very difficult. And the mortality is also high. So use IV propofol with infusion, or I prefer to use midazolam bolus followed by infusion. Lacosamide also is a very good drug. It can be used. I rarely use phenobarbital, though many people like it because it produces a lot of sedation and hypotension and cardiac dysfunction. So lacosamide is a very good drug, and this midazolam is easy to use. Of course, many people like to use propofol and ketamine, but I don't use ketamine too much. I use this midazolam drip and lacosamide in the second or third stage, but still before 30 minutes. Before 30 minutes, don't let it go to 30 minutes. Now, initial treatment, IM midazolam or IV lorazepam, if there is IV access. No significant difference between lorazepam and diazepam, but hardly we use diazepam anymore. We use lorazepam and midazolam. Benzodiazepines preferred over phenobarbital, and there are new approvals. So we'll talk about this. Now, this is a very important study called the ASSET study, and they found that levetiracetam, fosphenytoin, and sodium valproate were equal. They were equal. So fosphenytoin use has gone down, levetiracetam use has come up, but another very good drug to use is also sodium valproate. And if it still prolongs, then we would like to use lacosamide. As I told you, it's a very good drug. It can be used IV. In elderly, it's a little bit of problem because it can produce some AV blocks and cardiac dysrhythmias and bradycardia, etc. So be careful in elderly, but otherwise, it's a very good drug. As I told you now, it goes on for more than 40 minutes, then you have to use all these anesthetic doses of pentothal, midazolam, pentobarbital, propofol, and then it becomes really tough. And this is called super refractory status epilepticus. As I told you now, most important is to treat out of home. So many patients, before they come to the hospital, you have to teach the parents, or you have to teach the spouse or teach somebody how to use midazolam. And midazolam is the benzodiazepine which is now recommended for first-line use for treating convulsive status epilepticus, safe and effective. And the use of midazolam by caregivers in the community is widely accepted, but off-label practice. It must be carefully planned, supervised, and controlled. And the way to give it is intranasal or intrabuccal for acute seizures. So every patient prescription, you should write that you keep this midazolam spray handy. It's available now quite available. In between, there was a little problem in getting it because the raw material couldn't be got from China, but now it's available. And most seizure emergencies occur outside the hospital, and there is need for treatment interventions can be administered quickly and safely by non-clinical caregivers. So the family members should give it. Intranasal benzodiazepine does not require intravenous access and offers rapid seizure cessation within 4 to 5 minutes. Intranasal midazolam is faster at aborting seizure than rectal diazepam, quicker to administer than intravenous. So I urge you for every patient to use this drug because it is very useful. And every patient should have this handy in their home or in their office or in their workplace so that quickly somebody can administer these drugs. I won't go into the details of this, but I urge you that every ICU should have access to an EEG, if not continuous monitoring, at least long-term monitoring with an EEG, because it can diagnose so many non-convulsive patients, non-convulsive epileptic patients, and also useful for metabolic encephalopathy and patients who come with coma and you don't know the cause. Many times this EEG can tell you whether it is a non-convulsive status or a metabolic encephalopathy or a structural lesion. So it's very, very useful drug. I mean, very, very useful investigation to have. Of course, you should have imaging, CT scan, MRI, all that. Of course, you have to do. But many people don't use this in the ICU, and it's a very, very important tool. And then there are these new syndromes. Suddenly a patient, this is called NORS. This is new onset refractory status epilepticus, new onset refractory status epilepticus. Recently described clinical presentation that can affect all ages. It occurs in patients without active epilepsy or other predisposing cause and has no clear clinical or active surgical, structural, toxic or metabolic cause. So it's idiopathic. It suddenly comes out of the blue and the patient comes with 5, 10, 15 seizures in a few hours. And this is terrifying because the patient was perfectly normal in the beginning, and this is new onset refractory status epilepticus, and it needs to be treated. Another one which occurs in children is febrile infection related epilepsy syndrome called FIRES. It requires a preceding febrile infection and fever previously, and then refractory status epilepticus, and literally the brain is on fire. So these are two very important new conditions that you must know of, and you should know how to treat it. And the super refractory status epilepticus occurs in many of these conditions, and it's very, very difficult to treat. It is not common, but it has high mortality and morbidity. And another very important type of encephalopathy or encephalitis that we are seeing now is autoimmune encephalitis. This is either NMDA or VJKC or so many other different types of autoimmune disorders. And these, even NORs and all, need to be treated with IV methylprednisolone or IVIG or Plex for the first 5 days, followed by rituximab and cyclophosphamide. I can't go into this for lack of time, but it's very important that these super refractory cases you treat with immunotherapy quickly. Don't wait for 5 days, 6 days. If the seizures are not getting under control and there is no known cause, there's probably NORS or this thing or autoimmune encephalitis, and you treat with immunotherapy, IVMP or IVIG or the IVMP plus IVIG or Plex for the first 5 days, followed by rituximab. And we've seen wonderful results with these treatments. It's rare, but when it occurs, it needs very important treatment. I think now, I think I'm exceeding my time, so I'll go fast. Let me not do this. Okay. Now, what precautions? Every patient, you must tell them this. Wear a helmet when biking or horseback riding. This is from America, so they've said horseback riding. But biking means cycle. Arey Baba, in India, they don't even wear it for motorcycle and scooter. And yesterday only, I saw 2 patients who are brain dead after motorcycle accident. Those bloody idiots don't wear a helmet. So wearing a helmet is so very important. This biking means for cycling, not for motorcycling. No unsupervised swimming, we know all that. Use a shower than a bathtub. But you'll say that who uses bathtub in India? Very few rich people use a bathtub, but you've heard of some celebrities drowning in bathtubs also. So use either a bucket bath or a shower. Okay, most people in India use a bucket bath. Others adjust the temperature of hot water heater to lower the risk of scalding. Use a microwave versus a stove top. You know, I tell all my patients ki te जेवणाकडे जायचं नाही, kitchen मध्ये जायचं नाही. But this is a good alternative. If you use a microwave, you can cook the food. So don't use a gas stove or a other stove. But if you use a microwave, you can use. Always tell your patients that don't lock the bathroom or bedroom door. So many times we have to break open the bathroom door. You know, this bathroom, there is a whole concept called bathroom neurology. I call it bathroom neurology. So many incidents occur in the bathroom. Strokes occur, convulsions occur, syncope occurs, hot water epilepsy occurs, gas geyser things occur. So avoid locking the bathroom or bedroom door. Use an epilepsy safety pillow. Use soft or padded furniture. Avoid high ladders. Driving local regulations. And please, for God's sake, take medications as prescribed. And as I told you, this SUDEP is a sudden, unexpected, non-traumatic, non-drowning death in a person where autopsy fails to reveal any other anatomical or toxicological cause of death. And this is usually due to cardiac arrhythmia or breathing difficulty. So never ask a patient to sleep on his stomach. He should always sleep on his back or on the side. And if it is a child, they should, you know, initially I used to say that, you know, children should not sleep with their parents, but epileptic children, I think, should sleep near their parents, or there should be a video camera in their room or an alarm, because most of these are unwitnessed. And if a child dies with epilepsy, it is a big tragedy for the family. So this, though it is rare, it is very important to understand. Thank you so very much.
Thank you very much, sir. I would please request you to stop sharing your screen so that we can present the e-memento to you. I would request Dr. Samir Bangar to please.
Yeah.
Thanks, sir.
Hello.
How do I stop sharing this?
Thank you, sir, for your excellent and elaborative talk on status epilepticus management. Sir. It will be very useful for us in future.
Thank you so much.
Thank you, sir.
Thank you very much, sir. Thank you for your excellent presentation.
Yes.
Now
thank
I
you.
would, yes, sir. Thank you very much. I would request Dr. Ninath Fade to please felicitate our chairpersons, Dr. Dhanesh Gandhi and Dr. Samir Bangar. Thank you, chairpersons, and thank you, coordinator, Dr. Ninath Fade, for conducting this session. For the next session, I would like to call upon Dr. Trupti Sid as a coordinator. The next session we would be having on anesthesia, and she would call upon the chairpersons. The chairpersons are Dr. H.N. Shetty sir and Dr. Dhobre sir. Over to you, Dr. Trupti Sid.
Good afternoon, all. Our today's topic for anesthesia is management of common chronic painful disorders by Dr. Manoj Shinde sir. Now I would call upon Dr. H.N. Shetty sir, our chairperson and senior anesthesiologist practicing since 35 years in Akluz. Sir has very vast experience in anesthesia and very much known for high risk and challenging cases. I would also call upon Dr. Dhobre sir, well-known anesthesiologist practicing in Maharashtra area. Now I request one of our chairpersons to introduce Dr. Manoj Shinde sir. Thank you.
Hello. Dr. Manoj Shinde. He has done MBBS and diploma in anesthesiology from Dr. VM Medical College, Solapur. He is fellow of Indian Academy of Pain Medicine. He is professionally trained anesthesiologist specialized in regional anesthesia and chronic pain management. He has published role of genicular nerve radiofrequency ablation of chronic knee pain due to osteoarthritis, role of spinopalatine ganglion radiofrequency ablation of resistant and typical trigeminal neuralgia. Please, sir.
Should I share my screen now?
Yes, sir. Yeah, just hold on a second, sir. We have stopped. Yes, you can share your screen now, sir. Yeah, thank you, sir.
So, good afternoon to all. From last 9 years, I am working as a full-time pain management specialist in Karanji. This is our new upcoming mega project, which is situated in Sangli. This is 350 plus bedded multi-super specialty hospital with 100 bedded ICU and 12 operation theaters. It is going to be opened within next few months. So for performing all the interventional procedures, you need procedure room with all necessary gadgets. So just 1 minute. I am not able to see it properly. Okay. So what is meant by pain? Pain is an unpleasant sensory and emotional experience associated in terms of actual or potential tissue damage or described in terms of such damage. So pain has got two components. One is sensory, and other is emotional. So pain doesn't not only hurts suffering individual physically, but it hurts on other parameters of the life. The suffering individual's quality of life is hampered, his functional capacity is reduced grossly, he cannot work, and that leads to the economical losses. And because of this, patient has emotional disturbances. Not only the individual suffers, but his family also suffers because of this chronic pain. What is meant by interventional pain management? Interventional pain management is a discipline of medicine devoted to the diagnosis and treatment of chronic pain-related disorders. Initially, there are only uh, two things. One is conservative treatment and other is operative treatment. But this is in between these two treatment modalities. So here, for reaching to the diagnosis or to know the pain generator, we have to take full history and to examine the patient clinically. After examination, we have to we have to advise to investigation to confirm our diagnosis in the form of laboratory test, CT scan, MRI, X-rays, or ultrasonography. The goal is to relieve the patient from severe dreadful pain or to reduce or manage pain in case of cancer pain and improve overall patient's quality of life. Of course, there are so many advantages of this interventional pain management. It is minimally invasive and percutaneous procedure. There is no cutting or no sutures, no blood loss. Most of the procedures are done under local anesthesia, and these are cheaper, economical to the patient. In most of the procedures, patient does not require any admission. Patient can be sent to home on the same day, or on the in few uh, procedures, patient can be can go to the work. Also, these procedures are done under vision with the help of ultrasonography or X-ray system, that is CM control, or under CT scan. So these there is least chances of complications, because every time dye pattern study is confirmed. So we are able to get the pain generator, so patient gets excellent pain relief. These procedures are, of course, suitable for the high risk patients also. Of course, pain is major cause of suffering to the mankind. If pain is not treated adequately and effectively within time, then it becomes a disease state, because the chronic painful signals from the periphery, they induce certain changes in the central nervous system. These changes are called as neuroplastic changes or cerebral reorganization. And due to this, even if those the initial pathology is of lesser magnitude, but pain felt is very worst, and that leads to the depression, anxiety, and restricted life. So chronic pain doesn't remain as a symptom, it becomes a disease state after a certain period. The incidence of chronic pain is 26%. I can say in Hindi, ये कहानी घर घर की है. There are 1 to 2 patients of chronic pain in every family. So this is very big volume. Of course, pain is a fifth vital sign after heart rate, blood pressure, temperature, and respiratory rate. Pain is broadly classified as per the mechanism of injury as a nociceptive pain or neuropathic pain. Nociceptive pain further classified as a visceral pain, somatic pain, and inflammatory pain. According to the intensity, pain can be further classified as a mild, moderate, severe, and rated on the rating scale from 0 to 10. According to the time course, pain can be acute or chronic. When you can call any pain as a chronic pain? If the pain persists for more than 3 months to 6 months, or even after the period of healing, then you can term this pain as a chronic pain. These are other classifications of pain. Nociceptive pain is because of the injury to the organs or trauma to the muscular system. It is many times serious one. Inflammatory pain, best example is rheumatoid arthritis pain. Neuropathic pain is due to the injury to the nervous system or injury to the dysfunction of the nervous system. There is another kind of pain that is called as dysfunctional pain, where there is no any noxious stimulation or inflammation, but still that individual suffers from severe pain. You can get this type of pain in fibromyalgia, IBS, tension time headache, or TM joint dysfunction. Of course, injudicious use of analgesics can produce significant damage. So in many dialysis center, you will see this type of scenario where patients are taking over the counter of analgesics and NSAIDs for back pain, knee pain, headache, and they land with this chronic renal failure. So common painful disorders, we will come to the topic now. To conquer this severe unbearable pain because of this chronic pain, there are new modalities and new discoveries. And these discoveries offer very good pain relief and improve the patient's quality of life. So first, common chronic painful disorder is ONE pain. In ONE, there is main pathology is wear and tear of the articular cartilage. So here, main brunt is fall on articular cartilage and meniscus, joint space is narrowed, osteophytes are formed. In contrast to this, in rheumatoid arthritis, there is a marked inflammation of the synovium. So 80% of people suffer from ONE by the age of 65 years, and it manifests clinically by the age of 35 to 40 years. The disease process actually starts by the age of 20 years. Obesity and injuries to the knee joint and aging process, these are the risk factors to predispose to this osteoarthritis. This chronic ONE pain is not managed effectively often because there are certain limitations to the NSAIDs and non-pharmacological management also does not work. Intra-articular steroid injection, they provide only temporary relief. The hyaluronic acid injections, intra-articular injections, they are expensive and they are not useful in ONE, KL grade, ONE grade 3 and 4. Few people are now trying platelet-rich plasma therapy in grade 2 and grade 3 patients. So in future, strong evidences will come out. So we can then talk about this. Of course, total knee replacement is very wonderful and excellent procedure for grade 4 total knee replacement, but this is not ideal choice for many young individuals or critically ill patients. Those are suffering from severe ONE. Even few percentage of people after total knee replacement, they suffer from severe unbearable knee pain. So what is the option? As pain management specialist, we do genicular nerve ablation. The genicular nerves are purely sensory nerves. There are total 10 nerves. Out of that, only 3 to 4 nerves are selected to denerve them. So this is the image showing radio frequency ablation of the genicular nerves of the knee. Here needle is placed under Siam guidance. There are two modes. One is sensory mode and motor mode that helps localization and identification of the genicular nerve. So with this, we can ablate now under local anesthesia. This total procedure is carried outside the joint capsule. There is no invasion of the joints. So the complication rate is very negligible. After this procedure, patient can go to work from the next day. From next day, we start his physiotherapy. Within 10 to 15 days, 70% of pain is reduced and patient After this pain relief can last for 1 to 3 years. Of course, this is daycare procedure, inexpensive, done under local anesthesia. The complications are negligible, just like local bruising or soreness. And this is the only option for the patients. Those are suffering from severe knee pain, even after total knee replacement. It helps in early rehabilitation of the patient. Next common issue is the back pain. This back pain affects from age group from 20 to 70 years. So it is quite expensive healthcare problem. There are pain generators in the spine. For example, intervertebral disc, facet joint, nerve roots, SI joints, muscles and ligaments around the spine. So this is one image showing radiofrequency ablation of the medial branch nerves. These medial branch nerves supply to these small joints. These facet joints are the joints in between the two vertebrae. So these are just like knee joint. So this joint can develop osteoarthritis. For this, there is no any replacement. So in patients suffering from severe back pain because of the facet joint arthropathy, this radiofrequency ablation give excellent pain relief. Another case is 24-year-old workers suffering from severe back pain and leg pain because of the ruptured L4 L5 disc, where left L5 root is compressed, and there is inflammation due to leakage of nucleus pulposus from the L4 L5 disc. Patient cannot walk more than 10 steps. Clinically, there is no any neurological deficit. This affects patient's work, and patient is depressed. So this was the MRI where there is rupture of L4 L5 disc, and this traversing L5 root is compressed here. So transforaminal neuroplasty, which gives excellent pain relief in these patients, where the with the help of CM study pattern was done, where after this study pattern in AP and lateral view, injection Kenacort in small dose along with injection bupivacaine, which relieves the patient's pain completely, so that major patient can rehabilitate and patient start his routine very soon. Here role of steroid acts as an anti-inflammatory agent to relieve the radiculitis because of the ruptured disc, and bupivacaine, that is local anesthetic agent that blocks the pain signals by A delta and C fibers to the central nervous system. Sacroiliac joint pain is one of the common cause for back pain, where sacroiliac joint injection under CM guidance with dye spread will give excellent pain relief. Post-laminectomy pain syndrome is another pain syndrome where many times patients are frustrated, depressed. So for reherniation, we do transforaminal neuroplasty after dye study, or for epidural fibrosis, we do epidural adhesiolysis with the help of 3% saline and RAS catheter. For facet arthropathy pain, we do radiofrequency ablation of the medial branch nerves, those supplying to the facet joints. Headache is another painful disorder, chronic painful disorder. Tension type headache is most common cause of chronic headaches. In migraine, we do sphenopalatine ganglion block or block followed by radiofrequency ablation after getting 80% pain relief. For cervicogenic headache, which is because of the facet arthropathy of C2, C3 facet joint, we do third occipital nerve block or greater or lesser occipital nerve block, which relieves his pain very nicely. In case of migraine, it is unilateral type of headache, where most of the time this abortive therapy and preventive therapy doesn't work. So even after following non-pharmacological therapy, as there are certain contract indication to the the abortive drugs and prophylactic drugs. Many times this migraine pain is very difficult to control. For these patients, we do sphenopalatine ganglion block. After getting wonderful or more than 80% pain relief, we do radiofrequency of the sphenopalatine ganglion. This is kind of rare headache, which is called as cluster headache, which is very common in males. Here also, this greater occipital nerve block, which is very superficial nerve block, gives 60% pain relief. If it doesn't work, then sphenopalatine ganglion block followed by radiofrequency, we relieve his dreadful painful attack. Trigeminal neuralgia, even though it is not very common, but it is very dreadful painful syndrome where pain is unilateral, intense, sharp, electric shock-like pain in the face, which lasts from few seconds to 2 minutes, felt in the distribution of trigeminal nerve. And one important feature of this pain is there is pain-free interval in between two attacks. And there are aggravating factors like touching the face or chewing the food can induce this painful attack. There are 3 branches of trigeminal nerve. One is ophthalmic, second is maxillary, and third is mandibular. This pain syndrome is because of, as age advances, these cerebellar vessels, they develop loops. As brain sinks down, they develop loop, and this loop irritates to the trigeminal nerve at root entry zone that lead to the demyelination. And those demyelinated neurons, they start ectopic firing, and that leads to this severe and dreadful pain syndrome. So for this, we do radiofrequency ablation under CM guidance with proper sensory and motor stimulation, which gives wonderful pain relief to the suffering individual. This is one video I would like to share. This is called as allodynia. Here, normal touch can induce severe pain. After radiofrequency ablation of maxillary, so with this patient becomes pain-free and their quality of life is improved very significantly. So like that, glossopharyngeal neuralgia or TM joint dysfunction, this can be very well treated with interventional pain management. Few patients suffer from severe facial pain, that is called as atypical facial pain, because that does not suit into the criteria of trigeminal neuralgia or glossopharyngeal neuralgia or other neuralgic pain syndromes. These patients can be treated very nicely with the help of sphenopalatine ganglion injection or radiofrequency. Most of the time, after dental extraction, patient develop this type of alveolar neuralgia. This is because of the caries tooth that leads to the irritation of inferior alar nerve. Here, inferior alar nerve block or radiofrequency can relieve the pain very nicely. This tennis elbow, golfer's elbow, and decurvence, tenosynovitis, carpal tunnel syndrome, tarsal tunnel syndrome, all these can be managed under UHG guidance, UHG guided blocks or local steroid injections very nicely in earlier stages. Complex seasonal pain syndrome is itself a very complex term. It has got multi-symptom, multi-system syndrome, usually affecting one or more extremities, but may affect virtually any part of the body. Here, there are two parts. One is peripheral sensitization, and another is central sensitization, and that lead to this severe unbearable pain syndrome. Often it is precipitated by minor trauma and other conditions like infection, surgery. This is a picture of chronic regional pain syndrome, where there are few differences in both extremities. You will get allodynia, you will get temperature changes in both extremities, you will get swelling in one leg. There is difference in hair growth pattern, nail bed. Also, there is restricted movements. So this can be very well managed by the this sympathetic block. I will show this one video. For leg pain CRPS, we do lumbar sympathetic plexus block followed by neurolysis. In the similar manner, we treat vascular pain syndromes with the help of steroid ganglion block or T2 T3 sympathetic block followed by the radiofrequency ablation. Post-operative neuralgia is another chronic painful disorder. Very commonly, it affects the trunk region or thoracic region. 52% patients develop herpes zoster at the thoracic region. Few patients develop at first. In few patients, there is involvement of ophthalmic division.
So we have cut short the lecture, sir. Can you please finish the lecture early?
Yeah. So good antiviral treatment usually prevents this type of post-herpetic neuralgia, but with the help of anticonvulsants and steroids, we can manage this pain with pulse radio frequency. With the help of pulse radio frequency, we reduce the excitability of the nerve so that patient becomes pain-free. This is one video. And after pulse, so in case of frozen shoulder, we do suprascapular nerve pulse radio frequency, which relieves pain and patient cooperates in physiotherapy very nicely. Likewise, we treat many other painful conditions like atypical or undiagnosed pelvic pain or this osteoporosis pain or diabetic neuropathy, myofascial pain. In cancer pain also, we give wonderful pain results with the help of this interventional pain management. So it is really our privilege to treat pain, for surely pain relief is a basic human right. Thank you so much.
Thank you, sir. Now I request our chairperson to thank sir for the lecture. Sir, can you please stop sharing the screen so that I can present e-memento?
Hello. Thank Dr. Manoj Shinde for his very informative lecture.
So just click on, yeah. No. Click on stop share.
Hello.
I am unable to do this. What to do? Pause share.
Sir, on the top of the screen, you'll see option. Okay.
And I request today's coordinator, Dr. Truptishit ma'am, to felicitate chairperson, Dr. H.N. Chete sir and Dr. Dhobe sir. Thank you, everyone. Now we move on to next lecture, the myths and facts of organ donation. And to coordinate this session, I call upon Dr. Vinod Chete sir to coordinate the session, and Mukund Jamdar sir to please chair the session. Welcome, Aarti. Sorry for the delay. We have
Hello.
been running really late.
Yes,
Jyoti,
no problem.
we are having the lecture that is myths and fact of organ donation, for which we got a speaker as Dr. Aarti Gokhale madam and chairperson Dr. Mukund Jamdar sir. I am here to introduce Dr. Mukund Jamdar sir. He has done his master of surgery. He is practicing as a senior surgeon in Aklu since last 20 years. He is also working as a medical superintendent in Sub-District Hospital, Akluz. We can call him as a pioneer of organ donation in Akluz city. The center for the eye donation is at a Sub-District Hospital, and the center for the body organ donation is at Dr. Inamdar Sir's Ashwini Hospital, Akluz. Up till now, they have done around about 42 eye donations and 3 total body donations. They have attempted 8 organ donations also. For there are so many myths in village area like Akluz, around the Akluz, for which Dr. Jamdar has taken lots of efforts, has done so many programs for all age groups in and around the Akluz. So please welcome Dr. Mukund Jamdar sir.
I request sir to introduce ma'am, and we will start with the lecture after that.
Good afternoon, one and all. Aarti Gokhale, ma'am, she is working as a chief at a ZTCC, that is Zonal Transplant Coordination Center, for last 8 years. Also, she representing the zone nationally at an NOTO, that is National Organ Transplant and Tissue Organization. She has a 25 years experience in the field of organ donation and a transplant coordinator. I'll request Aarti Gokhale ma'am to deliver the lecture. Thank you.
Yes. Thank you very much, Dr. Jamdar. And thank you very much, IMA Akluz, to give me this opportunity to speak about myths and facts about organ donation. Before I start my presentation, I would like to thank, yes, will you operate for me from there, or should I share my screen?
You can share your screen.
Yeah, because I have already, 1 minute. Yeah.
Yes, ma'am, it is visible.
It is visible?
Yes, yes.
Yeah, before I start my talk, I would like to thank Dr. Jamdar as he has given me this opportunity. And I'm in touch with Dr. Jamdar because he is very much enthusiastic to promote organ donation in Akluz and other peripheral area. But unfortunately, he was not successful in last, I think, 5 to 6 attempts. But I must appreciate his efforts that he has motivated so many families for eye donation as well as body donation, and keep on doing continuous IEC activities, which is he has sent me a detailed report about it. So I'm very much happy to see, and I encourage him that and give support from ZTCC that in near future, definitely we will have at least one donation from Aklus from Ashwini Hospital in near future. So the topic is given me for myths and facts about organ donation. So little introduction, this organ donation is when a person allows healthy transplantable organs and tissues to be removed either after death or when alive. Alive, as you all are medical practitioners, so you are aware that one of our kidney and a portion of liver can be donated when we are alive and transplanted into another person. Common transplantation include kidneys, heart, liver, pancreas, intestine, lungs, bones, bone marrow, skin, and corneas. Collective efforts by the medical professionals, government, and NGOs, the awareness with regard to organ donation has increased in last few years in India. But however, in many places, organ donation remains still a taboo even driven by the various myths. So let's find out what are the truths and what are the myths related to organ donation. Quick facts about organ donation, that there is no specified age for organ donation, but it is completely based on strict medical standards. In the case of natural death, tissues of the cornea, heart walls, bone, and skin can be donated, while other important organs like heart, liver, intestine, kidneys, lungs, and pancreas can be only donated in the case of brainstem death. After organ failure, vital organs like heart, kidneys, GI, lungs, and pancreas can be transplanted to the patient to aid the recipient to lead a good health status and a normal life. If anyone younger than the age of 18 wishes to donate an organ, then he or she must have a concerned agreement of parents or guardians. He cannot pledge his organs when he is alive. I mean to say that we have a pledge form, and that only after 18 years of age completion, you can fill up the pledge form. But if anyone dies before 18 years of his or her age, parents can give consent for organ donation. And in India, we have done so far many pediatric donations. Anyone can be organ donor regardless of age, caste, religion, community, etc. A person with life-threatening health conditions such as actively transmitting cancer, HIV, diabetes, kidney diseases, or cardiovascular diseases can donate specific organs. Like, say, for example, if there is a HIV infected deceased donor and or HBsAg infected or HBsAg donor, then certainly if we have on our waiting list HIV patient or HBsAg recipient, certainly his organs can be donated. So I have mentioned can donate specific organs as per the requirement. So let's go for the myths. So myth number one, there is not much need for organ donation in India. This is a myth, but the fact is it's not true. In India, almost 300 patients die every day due to organ failure. According to the statistics, out of 9.5 million deaths every year in our country, at least 1 lakh are potential donors. The conversion of brain dead patients into donors is still moving at a slower pace in India, and signing up for organ donation can save many lives. Myth number two, brain death patient can come back to life. No, the fact is brain death is often misunderstood as coma. Many times patient asks us, yes, brain death means he is in coma, so he'll come out of it. No, it is not like that. So these two are different conditions. Under coma, a patient is not brain dead and it is a reversible condition. And brain death, the brain stem at the base of the brain stops functioning, causing death. Eventually, the patient's heart will stop functioning. So what is myth number three is pledge cannot donate organ. There is no age limit to donate organs. Doctors go by strict medical standards while assessing the health condition of the donor and will not consider the age. If I'm an organ donor, the doctor may not focus on saving my life. No, it's not like that. This is a popular misconception among those worried about signing a donor registry Doctors always focus on saving your life, not the potential recipient of the organs. Many a time, the doctor treating you may not have anything to do with the organ transplantation. Donor's family should pay for organ retrieval? No. In the case of brain dead patient, the donor's family do not have to pay for organ retrieval. So I don't want to go much detail in this because there are certain rules laid down by the government, and whenever we come across with the donation, time to time the fact is to be explained to the donor family members. The hospital staff won't work as hard to save my life. Again, this is not true. When you go to the hospital for treatment, doctor focus on saving your life, not somebody else. A doctor will see you whose specialty most closely matches your particular condition. If I'm under age 18, I am too young to make this decision. That's true in a legal sense, but your parents or legal guardian can authorize this decision. You can express to your family about your wish to donate, and they can give their consent knowing that it's what you wanted. Children too are the need of organ transplants. We have many pediatric transplant waiting list recipients who need transplants, and they usually need organs smaller than those an adult can provide. I'm too old to donate. Nobody would want my organs. There is no defined cutoff age for donating organs. Medical criteria and not the age decides your use of the organs. Don't prematurely disqualify yourself. Let the doctors decide at the time of your death whether your organs and tissues are suitable for transplantation or not. Rich and famous people go to the top of the list when they need donor organ. No, again, it's not like that. The rich and famous aren't given priority when it comes to allocating the organs. It may seem that because of the amount of publicity generated when a celebrity receives a transplant, but they are treated no differently from anyone else. This is a classic example of late Chief Minister Vilasrao Deshmukh. You all must have known to this story that Vilasrao Deshmukh was not registered for liver transplant, and when he was in need of liver organ, he was registered in Chennai, one of the hospitals in Chennai. So relatives of him took him to the Chennai for the transplantation. So it is not like that no politician, rich people, they won't get organ on priority. Everyone is getting priority on the medical criteria. No any other criteria is used for the organ allocation. Religions, morbid organ donation and transplantation, all major faiths about support organ donation as a humanitarian act. Every religion endorse organ donation, and they also promote organ donation for transplantation. Once I sign for organ donation, I can never change my decision. Yes, you can always change and opt out for your decision. If now you think that I have signed the pledge card, but later on, if you think you can withdraw your pledge for donating organs, it's not compulsory that once you have pledged your organ, that means you have to have donated your organs after your death. An organ recipient cannot be a donor? No, it's not like that. If you are done a kidney transplant, we have few cases that those who have done kidney transplant in past, but after they declared brainstem death, they have donated their liver, corneas, and skin as well. So you can do that, and you can donate rest of your organs. If I donate my organs, body will not be given back to the relatives for rituals. No, it is not like that. After completing the retrieval process of organs, body is packed very neatly. Hospital staff pays tribute to the donor and handed over back to the family members for their final rituals. If I donate my organs, it will cause delay in my funeral arrangements. Yes, it is. But there is a possibility. However, given the altruistic nature of the donation, families usually accept this and take it as part of the process of the donation. Yeah, if you have given consent for all your organs like heart, lungs, kidney, liver, cornea, skin, bones, so Every team has to reach to the donor hospital site for the retrieval. It may happen that, suppose take an instance that you have a donor in Ashwini Hospital in Akluz, and donor has consented for all possible organs, and teams are coming from Hyderabad and Chennai, so they will reach time obviously. So it may delay for funeral process, and you may give surplus time to the donor families for giving body back to the on time. So it may happen. Organ donation mutilates the body. Donated organs are removed surgically with one incision from the top of the chest to the navel, which does not disfigure the body. Organ and all, it's an open casket funeral isn't an option for people who have donated organs or tissues. Organ and tissues donated doesn't interfere with having an open casket funeral. You must cover the donor's body for burial. People can buy and sell organs. The Transplantation of Human Organs Act prohibits any commercial dealings in organs and makes it a punishable offense. So it is not allowed by the law. Having a donor card is all that's required to become a donor. I don't need to tell my family that I want to be a donor because it's written in my will. No, it's not like that. As per the Human Organ Transplant Act, if you have pledged your organs, you have to have informed your relatives and friends that I have filled up the pledge form. But as per the Act, everyone who declares brainstem death or after the cardiac death, if you want to donate your tissues or solid organs, you need to have consent of your family. Otherwise, it is not possible. They may say no, that yes, the deceased person have expressed the wish of organ and tissue donation, but I don't want to give consent for any of organ and tissue donation. So it is better you inform your family and friends when you are alive for your organ and tissues donation after your death. So I just have 2 to 3 slides for ZTCC. This is our website. Pledge your organs and join the League of Real Heroes. Become a donor and become a hero. ztccpune.org. This is our website. We are also there on Twitter and Insta. So you can follow us on Instagram, and you can like and share your views there. And please also visit our Twitter. ZTCC Pune have produced 2 films. One is Fir Zindagi Life Continues. It is also available on YouTube channel. And recently we have launched one more film, name is Gulmohar. It is still not open for the public, but yes, we have sending for 2 film festival. It has been selected for 2 film festival. One is in UK and one in Bangalore, Karnataka. And soon we will be open for the public, and of course we will upload it on our website. This is our QR code. You can scan this QR code, be a hero, be an organ donor. If you scan this QR code, you will directly go on our website. You can fill up the pledge form and submit it online, and within few seconds you will receive a donor card on your handset, and you can circulate this QR code as much as whenever and whosoever on WhatsApp group or with your friends and family, and pledge and do the pledge form, fill up and become an organ donor. Thank you very much.
I'm sure you must have motivated many people to think about donating their organs. And I request Dr. Jamdar sir to felicitate ma'am with an e-memento. And thanks a lot for being patient and adjusting your lecture time. I know you had.
Thank you.
Yes, thank you, ma'am. And sorry for the delay again.
Thank you. No, it's all right.
Jamdar sir, I would like you to thank ma'am.
Thank you so much, ma'am. Thank you.
Thank you.
I request Dr. Shetty sir to felicitate our chairperson, Jamdar sir, for chairing the session. And we really appreciate his efforts and sincerity towards the enthusiasm and promoting the organ donation in small place like Akluz. Thank you, sir. Now we move on to quiz. Vatve sir will be joining us later because he had previous appointments. So this is a surprise element. And to declare about the quiz, I call Dr. Sunil Narute sir to give us information about it.
Hello. Good afternoon, all. The next session is exciting one, the quiz session. For quiz session, you have to log in the link that we have shared with your emails. Also, you can log in with DigiShield with DigiShield chat box. For that, for quiz session, you will get 15 minutes. You have to answer the 20 questions, and please answer carefully. There are exciting prizes for the winners. First prize is Littmann stethoscope. So best of luck to all of you, and just complete your quiz session within 15 minutes. Thank you.
The link is already in the chat box. So all of you, please take some time and answer it. Now, because of the time constraint, we are directly moving on to the next session. Is dedicated to pediatrics. To coordinate the session, I call Dr. Sujit Gandhi sir to please come on stage. And for the pediatric session, we have all senior pediatricians as chairperson. I request Dr. Rajiv Rani sir to please come on stage to chair the session. And Dr. Nitin Ekatpure sir and Dr. Praveen Shinde sir. Please come on stage. And I request Dr. Sujit Gandhi sir to introduce today's chair.
Thanks, Dr. Devati madam. Good afternoon, everyone. For pediatric meet in this AMSCON 2021, we have chairperson as Dr. Rajiv Rani. He is practicing as a pediatrician since 35 years. He's past IMA president of ACLUS. Right now, he's president of IIP ACLUS also. And he is going to chair for Dr. Sandeep Kadam sir's lecture in neonatology. Thank you.
I request sir to introduce Sandeep Kadam sir.
Hello, good afternoon everybody. Our next lecture is Emergencies in Newborn and its Management. The speech will be given by Dr. Sandeep Kadam. He is a MD pediatric and neonatology. He is a consultant neonatologist at KM Hospital, Pune. Over to you, Dr. Kadam.
Good afternoon, sir. I can't share my slides.
Yes, you can now.
Okay.
Yes. Yeah.
Please. Yeah, good afternoon, respected Chairperson Rane sir, Ekatpure sir, Dr. Sujit, Praveen sir, and IMA ACLUS. Thank you very much for this opportunity this afternoon. Actually, it's an odd hour, lunchtime, so I'll be very short and crisp to speak about common neonatal emergencies that we see in our day-to-day practice. Before going to emergencies, as a general practice in medicine, I would like to just remember a few normal things in newborn babies. Basically, newborn babies don't need much. They just need warmth. They need adequate feeding or mother's milk. They need to be kept away from infections, so keep them clean and aseptic. And we need to monitor their sugars. Normal heart rate of a newborn baby is 120 to 160 per minute, and normal respiratory rate is around 40 to 60 breaths per minute. And the capillary filling time that we see on the forehead or on the chest is instantaneous, and more than 3 seconds is prolonged capillary filling time. The temperature of a normal newborn baby is 36.5 degree to 37.5 degrees centigrade, and the normal saturation are around more than 90 definitely. We would like the saturations to remain between 90 to 95, and the blood sugar of a normal newborn baby should be more than 50. So these are some of the normal parameters that we would see in all newborn babies. So how will all of us recognize that a newborn baby is sick or a newborn baby has an emergency? So whenever a mother comes to any unit that my baby is unwell, my baby is sick, I think this history is very important. So we as practitioners should rely on the mother and never ignore the mother. And a good history will give us a lot of information about the history, about the diagnosis. And it is very important that we listen to the mother. And the second most important person is the nurse who is looking after the baby. So whenever we see a baby who is sick looking, this definitely tells us that this baby is unwell. And you look at the color of the baby. The normal newborn baby is red or pink in color. So whenever you see a baby who is pale, blue, yellow, mottled, ashen gray in complexion, these colors tell me that this baby is unwell. If you have a baby with heart rate less than 100 or heart rate more than 160, it is abnormal. Look at the peripheral pulses, capillary filling time more than 3 seconds, or your saturations are less than 90%. This baby is unwell. Look at the pattern of respiration. A normal baby should have respiratory rate between 40 to 60. If your respiratory rate is more than 60, or if you have a baby with grunting, or if you have a baby with intercostal and subcostal retractions, this baby has respiratory distress. So if all these parameters are not normal, this baby definitely has some unwell feature. This baby may be heading for an emergency. So we need to observe, we need to see, and we need to take a quick decisive action. So when you look at basic steps in neonatal emergency, it is a TOPS approach. T is for temperature. You maintain a temperature between 36.5 to 37.5. So if your baby is hypothermic or if your baby is hyperthermic, this baby is unwell. Maintain euthermia. Look at the respiration, and saturation should be between 90 to 95. Look at the perfusion. You may have to optimize by giving a volume and inotropes, and you need to correct hypoglycemia if any. So TOPS approach is very important when it comes to managing a newborn with emergency. Now let us look at what are the emergencies that we pediatricians see in our day-to-day practice. Let us go to the delivery room. So if you have a gynec setup or you're delivering babies, and these are some of the emergencies that we would see in the delivery room. A baby may not pass meconium in the first 24 hours. This is again not normal. So if you have a delayed passage of meconium, look, if the baby has passed meconium in utero, it could be a meconium Steinleicher, and the baby may not pass meconium in the first 24 hours. You have to rule out an imperforate anus. But if you still have a baby who has not passed meconium, then think of lower GI obstructions, rectal atresia, imperforate anus, Hirschsprung's disease, meconium plug syndrome, and sometimes one may have congenital hypothyroidism where the baby may not pass meconium in the first 24 hours. A baby who has not passed urine in the first 48 hours is abnormal. So if you have a delayed passage of urine beyond 48 hours, this baby definitely needs some evaluation. However, sometimes babies pass urine immediately after birth, which may go unnoticed. So this is something which we need to see. Look at the antenatal history if there is any oligohydramnios. Check for weight loss, because sometimes decreased feeding may be associated with oligoanuria. And last but not the least, an antenatal ultrasound to see if there are any obstructive uropathy, renal agenesis, PU valves, and oligohydramnios definitely tells us that this could be a renal dysplasia or renal agenesis. Now, looking at the delivery room emergency, the most important nightmare that we as pediatricians have is that baby has not cried at birth. And even the obstetrician or the practitioner who has delivered the baby is stressed. So what do I do if I see a baby who has not cried at birth? We have a detailed one-day workshop on what is called as neonatal resuscitation, but keeping it very simple in one slide, what you and me need to do is that we need to keep the baby warm, keep the baby in semi-extended position, dry and stimulate, that is the initial steps, suction only if required, so don't do routine suctioning. If the baby is not breathing or crying, start with positive pressure ventilation or bag and mask ventilation. And how do I do it? We have a simple self-inflating bag which we take it in our right hand and seal the nose and the mask and start bagging the baby. And how do I do it? Bag 2, 3, bag 2, 3, bag 2, 3, or squeeze 2, 3. And this algorithm gives about 40 to 60 breaths per minute. And if you give positive pressure ventilation, 95% of our babies are going to do well. What I would like all of us to remember is that When an adult or a pediatric patient dies, the heart stops first and then the breathing stops. Whereas a newborn, the breathing stops first and then the heart stops later. So when it comes to resuscitation, in an adult or a child, you give cardiac compression, whereas in a newborn baby, you have to give positive pressure ventilation and the heart rate will pick up. So that's why it is ventilation, ventilation, and ventilation in a baby who has not cried in the delivery room. The other emergencies are congenital anomalies. A baby may have choanal atresia, and how do I diagnose it? A baby who turns blue and when in quiet state, and when if the baby cries, the baby becomes pink. So the moment the baby opens the mouth, the baby is going to become pink. The moment the baby is quiet, it's going to turn blue. Look for choanal atresia. Cleft lip and cleft palate is a social emergency. The mother is going to be shocked. If you have a polyhydramnios in the mother, look for esophageal atresia and TO fistula, and a diaphragmatic hernia, wherein you have a scaphoid abdomen and the heart which is shifted to the right in a left-sided CDH. The other emergencies are a large head with a spina bifida with polyhydramnios, or a small head with a microcephaly. These are again shocking features for the mother and the relatives. You may have skeletal abnormalities where there could be agenesis of the thumbs, or there could be syndactyly or polydactyly, or you may have exomphalos. One of the social emergencies which previously used to say that it is ambiguous genitalia, the term ambiguous genitalia is now not in use. We call this terminology as disorders of sexual differentiation, where we don't know whether it's a male or a female or a hermaphrodite. I think it's very important to say that this is a disorder of sexual differentiation, wherein a chromosomal culture and then hormones would help us say whether it's a male or a female baby. So coming to basic approach of neonatal emergencies, it is important that we keep the babies euthermic. So warm the baby and keep the baby warm. You look at TABC, where it is temperature, airway, you position the baby in semi-extended position and assess respiration. If the baby is not breathing or apneic, you call for help and start with positive pressure ventilation. And C is for circulation, where you assess the heart rate, capillary filling time, and if there is poor perfusion, give a volume of 10 ml per kilo of normal saline and inotropes if required. Needless to say, it is TABC, but don't forget sugar, where if it is hypoglycemia, you need to treat aggressively. So the bottom line in terms of managing a baby who is sick and not well is to secure an IV line, check for saturations, give oxygen if required, warm the baby, correct hypoglycemia, and volume if required. So this is basically the crux or a 5-pronged approach to keep a newborn baby stable. Coming to respiratory emergencies, as I told you that normal breathing is 40 to 60 per minute. So anytime you have a newborn baby with respiratory rate more than 60, with subcostal or intercostal retractions and grunt, any 2 out of these 3 features is equal to respiratory distress. This is more common in preterm as compared to term. Again, the bottom line is keep the baby warm. Please remember, you may have a baby with tachypnea, but less retraction. This is more beneficial rather than having a baby with respiratory rate of 50, but significant retractions and grunt. The moment you have subcostal and intercostal retraction, it is equal to a lung disease. And this is something which we have to take care. The baby may need respiratory support. And common causes of respiratory disease in a term baby could be congenital pneumonia, meconium aspiration syndrome, transient tachypnea, or pulmonary hypertension. Whereas in a preterm baby, it is immaturity of the lung, which we call as RDS or hyaline membrane disease. And it could be because of infections or congenital pneumonia. Now looking at this X-ray, you could see that this baby is intubated, the lungs are low volume, there is whiteout, and there are some air bronchogram. Air bronchogram is a hallmark of hyaline membrane disease or RDS, which is respiratory distress syndrome, where there is surfactant deficiency. And you may have to give surfactant in the lungs. Now here in this X-ray, this is a term baby, again having respiratory distress. You could see that this baby has got areas of hyperinflation in bilateral lower lobes. Upper lobe, there is haziness. So this is a diffuse bilateral non-homogeneous disease. This is a classical meconium aspiration syndrome. Here you could see that this lung volume is good, but there is on the right side a transverse line which is visible. This is nothing but fissural fluid, and this is a transient tachypnea of newborn or retained lung fluid which starts at birth and improves in the next 24 to 48 hours time. This is tension pneumothorax, which can present as a respiratory distress, especially if a baby is on CPAP or mechanical ventilation. This is again an emergency where you have to put an intercostal drain and ventilate the baby. This is a baby who is on mechanical ventilation who suddenly worsens and has bradycardia. This is air around the heart and also in the mediastinum. So this is a pneumomediastinum with a pneumopericardium. So basically, you have to identify the cause of respiratory distress. Please remember, if you have grunting and retraction, it are warning signs. You start the baby with oxygen, IV fluids, keep the baby warm. And if there is a need for respiratory support, this baby may need CPAP or mechanical ventilation. In RDS, you may have to give surfactant, and in pneumonia, you give antibiotics. Now, in office practice, you may see a baby with cold, cough, coryza, tachypnea, retractions. Now, these are basically office-based emergencies in day-to-day practice, which you see in current era because of the viral pandemic. X-ray may show hyperinflation. You have to give oxygen if the saturations are less than 90. Supportive care, nebulization. Please remember that these are viral infections more often. But whenever you see a baby with viral infections in a newborn period, and if there is conjunctivitis, think of chlamydia, where the drug of choice could be azithromycin. If you have a right upper lobe collapse with cold cough, coryza, and the baby goes into intermittent apnea, this could be a respiratory syncytial virus, RSV, and this baby just needs nebulization and chest physiotherapy and supportive care. Coming to cardiac presentations or cardiac emergencies, basically cardiac emergencies don't present in the first 48 to 72 hours. They typically would present after 72 hours once the patent ductus arteriosus closes. The presentation could be either a blue baby, or it could be a pump failure and congestive cardiac failure, or it could be a severe shock. Rarely you may have arrhythmias where the heart rate is below 60 or heart rate is above 200. So coming to a blue baby, whenever you see a baby who is cyanosed, the cause could be respiratory, cardiac, or it could be a pulmonary vascular disease, or rarely it could be an abnormal hemoglobin. Basically, when you look at a cyanosed baby or a blue baby, you have to maintain euthermia, give oxygen, and see if the saturations are improving. If your saturations are improving after giving oxygen, then the cause is either respiratory or pulmonary hypertension, that is pulmonary vascular disease. But if there is no change in saturation, it could still be a cardiac disease or it could be PPHN. Here you need to do a 2D echo. If there is a difference between the right upper limb and lower limb, this is pulmonary hypertension. The treatment obviously is supportive care, ventilation. If you are thinking that this is a duct-dependent lesion like a pulmonary atresia, you may have to start prostaglandin, correct the underlying acidosis, because acidosis tends to cause pulmonary vasoconstriction. If you see a baby who is pale, then look for heart rate, capillary filling time, respiratory rate. Always remember to see the femoral artery pulsations, especially after 48 to 72 hours, because absence of femoral pulsations looks, it is probably a duct-dependent systemic circulation. This is a coarctation of aorta. If you have a baby who is pale, warm centrally and peripherally cold with core to peripheral temperature more than 2.5 or 3 degrees centigrade, this is infection. If you have a baby who is pale, it could be anemia. If you have jaundice with anemia, it is hemolysis, like RH isoimmunization or ABO incompatibility. If you have anemia with shock, look for blood loss, and this could be a blood loss either from the baby to the mother, baby to the placenta, or it could be hemorrhage in the baby itself, like IVH, or it could be subcapsular hematoma of liver, or it could be retroperitoneal hemorrhage. A day 3 baby becoming pale and shock, look for duct-dependent left ventricular outflow tract obstruction like aortic atresia, interrupted aortic arch, or coarctation. And once in a while, you may have a baby who is pale because of infection. Herein, this baby is going to have core to peripheral temperature difference, tachycardia, heart rate variability, and tachypnea. So pale baby, look at the hemoglobin. You may have to give volume, correct the anemia, give inotropes, correct hypothermia, hypoglycemia, and acidosis, and treat the underlying cause. Some of the gastrointestinal emergencies, you may have a baby who is vomiting. Vomiting could be bilious or non-bilious. You may have diarrhea. You may have GI bleeding, which are basically emergencies. Bilious vomiting is a surgical emergency unless proved otherwise. And you may have a baby with jaundice, which can come as an emergency. Now, this is an X-ray where you can see there are two shadows. One is the stomach and second is the intestinal shadow, and there is no gas beyond that. This is a classical double bubble shadow in a duodenal atresia. Look for polyhydramnios in the mother, and once in a while you can have a Down syndrome with duodenal atresia. Now, this baby has a large shadow, but there is nothing beyond that large shadow, and this is basically atresia where you can have air fluid levels. Now you see this baby is intensely yellow and the eyes are covered and the baby is under phototherapy and there is umbilical line in where we are doing an exchange. So this is a hyperbilirubinemia. Neonatal jaundice can be either unconjugated in the first week of life or it could be conjugated. Early jaundice in first 24 hours is emergency. It could be RH, ABO or minor blood group. Prolonged jaundice that is more than 2 weeks in term and more than 3 weeks in preterm deserves evaluation. You need to look at our specific bilirubin chart and start phototherapy and or exchange. Basically because neonatal hyperbilirubinemia is a preventable cause of cerebral palsy. Coming to some of the neurological emergencies, a baby who has had a fit or a seizure, lethargy, and refusal to feed. These are some of the manifestations of neurological emergencies. First thing that we should do is to do a blood sugar. Stabilize the baby, correct hypoglycemia if any, control the seizures by giving phenobarbital or levetiracetam or phenytoin, do a metabolic workup, sepsis workup for ruling out meningitis, EEG and MRI may be warranted. Coming to infectious emergencies, look for infections, which is one of the commonest killer as far as developing countries are concerned. Whenever you have a baby with hypothermia or hyperthermia, tachypnea, shock, looking unwell, distress, seizures, oliguria, you need to start thinking of infection. Don't wait to start antibiotics. Please take a blood culture, start antibiotics. Two things that I would like to tell you all today is that high CRP in newborn is not equal to sepsis. And you may have low CRP in the first 24 hours, but if you have two values with low CRP 48 hours apart, then it has helped you to rule out infection. So CRP is not going to help you diagnose infection. CRP is going to help you ruling out infection and thinking of other causes. So this is as regards infections. Coming to some of the endocrine emergencies, hypoglycemia is very common in newborns, especially preterm, IUGR, SGA babies, polycythemia, and infants of diabetic. Look for hyponatremia and hyperkalemia. Herein, you could have a history of consanguineous marriage and previous neonatal death because of hyperkalemia, which is undiagnosed. This is a case of congenital adrenal hyperplasia, and this is something where if you give fludrocortisone and hydrocortisone, these babies can lead a normal life. Hyperthyroidism can present as tachycardia, weight loss or failure to gain weight, and this is again an endocrine emergency. And if you have a baby with 3H, that is hypotension, hypoglycemia, and hyperkalemia, look for adrenal insufficiency or adrenal hemorrhage. Neonatal hypoglycemia, normally the WHO defines as less than 47, but if you have a value which is less than 50 milligram per deciliter, it should be treated, observed, and aggressively managed. If you have a blood sugar between 20 to 40, try a oral feeding, repeat a sugar in an hour's time. If the sugar is still low, start IV glucose infusion. If the sugar is more than 40, feed and monitor. Please remember that hypoglycemia is a preventable cause of brain injury. If your blood sugar is less than 20 and or anytime you have a symptomatic hypoglycemia, start glucose infusion. There is no need of giving IV glucose bolus in asymptomatic babies. But if you have a hypoglycemia with seizure, you may give a bolus and start with IV glucose infusion. So basically, whenever you have a neonatal emergency, it is or apparently life-threatening episodes. This is combination of apnea, bradycardia, color change, gagging or choking. You need to look at few things. One is to look if there is any acid-base disturbance like acidosis, anemia, is there any arrhythmia, is there any hyponatremia or hyperkalemia, is there any reflux and aspiration and choking episodes, hypoglycemia which can present as lethargy or seizure, hypothermia which can present with distress or the baby looking pale and shocked, seizures which can manifest with heart rate irregularities and desaturations, and sometimes you may have encephalopathy like intracranial hemorrhage or meningitis and infections presenting as apparent life-threatening episodes. So basic crux of the matter is that whenever you see a baby with neonatal emergencies, you stabilize the baby by keeping the baby warm, give oxygen, give respiratory support, start a IV line, do a blood sugar, correct hypoglycemia. You may have to give a bolus of normal saline to correct the shock, correct acidosis and dyselectrolytemia. You may have to use inotropes if required, but you need to find the cause and manage the cause accordingly. So with this, I think we need to have a very clear understanding that it is early detection, prompt treatment, and referral if required, which are the crux of the matter to reduce neonatal mortality related to neonatal emergencies. I thank you all for your patient listening. Thank you very much.
Thank you very much, sir. Would you please stop sharing your screen so that we can present in memento from our side?
Yes.
I would like our chairperson to please felicitate sir with any memento. Memento for you, sir.
Hello.
Thank you very much.
Thoroughly covered all the neonatal emergencies and its management. Definitely, it will be helpful to not only to the pediatrician but to the all IMA members. Thank you, Dr. Kadam. Thank you.
Thank you, sir. Thank you very much.
Thank you, Mary, sir. So moving on to our next lecture, I would request our chairperson to please introduce our next speaker, Dr. Mahesh Mohite, sir.
Hello. Good afternoon, everybody. Good afternoon, sir. Welcome to Aklu, sir. We are missing you all, sir, over here. I would like to welcome Dr. Mahesh Mohite, sir. He is a pediatric and neonatal intensivist practicing at New Panvel. He has his own hospital, Sai Child Care Clinic in New Panvel. He is also working as an honorarium in Vijayawada Children's Hospital. He was president-elect he is the president-elect 2022 IIP Intensive Care Unit, teacher and a council member in Pediatric Care India. Sir has a good number of patients over there, and I would like to tell you one thing, that sir has, I think, a record break of patients of dengue patients. Sir has managed a lot of dengue patients and the dengue hemorrhagic shock syndromes also. Sir, over to you for your lecture, sir. Thank you.
Thank you very much, IMA Akulus and IMA Maharashtra, for giving me this opportunity. Thank you very much, Dr. Rane sir. He's there. Actually, long time I met him. I'll start sharing my slides. Am I audible? And
yes, sir, you are audible.
My slides can be seen properly.
Yeah, the slides are proper, sir.
Thank you very much. So in the next about 20-22 minutes, I'll try to give you some briefs. Basically, shock in pediatrics, or for that matter in adult, is a very big topic, and there are annually Tata Hospital conduct 3 days only hemodynamic workshop called as thematics for last more than 20 years. I've attended it twice myself. So it's a very big topic. What I'm going to do is to give you some basics which will be utilized or can be useful to the general pediatric practitioner as well as to the consultant, just to review their knowledge. Now, here's the case. A 7-year-old girl brought with fever for 3 to 4 days, followed by a febrile period for 2 days, and then subsequently by severe abdominal pain. She was admitted in local hospital for 24 hours and then transferred to us for altered sensorium and abdominal pain. Now, a typical story in epidemics. I'm sure many of you must have seen these kind of cases. So when she was brought, she was drowsy, she was low-grade fever, mild tachycardia, tachypneic, blood pressure on lower side, 84/70. I wanted her to be at least 90 systolic. And you can notice the narrow pulse pressure, which was very obvious in her presentation. So this was definitely low pulse pressure, about 14 is the pulse pressure. Her capillary fill was delayed, weak peripheral pulses, macular rash on the trunk, and she was pale. And on history, child had not passed urine for more than 12 hours. Her liver was 3 centimeters in tender, and there are no significant neurological signs apart from drowsiness. Her system was normal. Now, investigations were sent. Counts were not very kind of a significant. Hemoglobin was 14. Then we checked her papers. Somebody had done it about 3 or 4 days in early days of fever, and hemoglobin was just about 10.5. A platelet count was 29,000. Peripheral smear was not showing a malarial parasite. Her liver parameters are slightly raised. Electrolytes and rest of the critical parameters are normal. USG abdomen was showing hepatomegaly, thin rim of pleural fluid, and thickened gallbladder. Obviously, this kind of a combination in the epidemic period, many of you have seen dengue. So you have a hemoconcentration, you have got narrow pulse pressure, as I showed in the previous slide, or a typical history of fever, followed by a febrile period, and then second phase getting into shocky phase. So not to our surprise and very clear cut, it was a dengue. So this is how the upfront presentation was just abdominal pain. Now somebody will ask me, why abdominal pain in a shocky child? I'll take that in a subsequent slides. So what is shock? Shock is basically, it's an imbalance between the demand and supply due to circulatory failure. What demand and supply? Oxygen and nutrients. So what the tissue require is not being fulfilled by the supply from the cardiocirculatory system. So cardiocirculatory failure, not being able to supply the oxygen and nutrients required by the tissue, that's exactly shock. So either the supply is bad, which is a common scenario, or sometimes the demands may be very high, which also may behave like a shock. Now you will ask, what is essential for maintaining the balance? Once I say imbalance, so what is essential to maintain the balance? Essentially, we are looking at 4 components. There should be adequate intravascular volume. There should be a proper cardiac pump to push that volume. The flow to the system should be uninterrupted, unblocked. And finally, whatever blood is pushed into the system should be properly distributed. Now, what happens if there is any fault in one of the systems? So if the volume is not adequate, then that's what will lead to hypovolemic shock. If the heart is not pumping adequately, that will lead to cardiogenic shock. If there is any kind of obstruction in the flow, so may it be a pericardial effusion, pericardial tamponade, maybe a pneumothorax, there may be any severe obstruction to aortic outlet like a severe aortic stenosis or a coarctation that can give rise to obstructive shock. And finally, if the whatever blood is pushed into circulation is not being distributed properly to all body, then that's what we call it as maldistributed shock. Classically, the septic shock is the commonest example. Other two being could be a neurological shock or anaphylactic shock. These are 4 important distributors or kind of components or types of shock. Now, in a given single patient, say in a sepsis, you may have the maldistribution. In addition, you may have hypovolemia, you may have a myocardial dysfunction because to cardiogenic, and finally somebody may additionally develop pericardial fluid, which can add to. So in a given patient, you may have all 4 components, but generally most of them may have one single component to start with. Now, types of shock. So mechanism based, we can make it as cases, causes that require primarily volume infusion, typically hypovolemia, that we get gastroenteritis, vomiting, and also so sometimes in dengue, because of third spacing and capillary leak, you will develop hypovolemic shock. And in the traumatic case, the hemorrhagic shock, which again is a hypovolemia, where you require volume replacement, may in the form of normal saline or blood. Few may require an improvement of pump function, as in case of cardiogenic shock. Classically, myocardial dysfunction, could be myocarditis, cardiac failure due to congenital anomalies, congenital heart diseases. And late part of the septic shock, we have myocardial dysfunction. Few may require volume support and vasopressor support. Now, this is, as I said, in a septic shock, which is maldistributed shock, where there is a capillary leak and hypovolemia, as well as there is a vasoplasia, peripheral vasodilatation, which is causing maldistribution. There could be a component which requires immediate relief from obstruction to cardiac output, as in case of pneumothorax or cardiac tamponade, that is typically an obstructive shock. And few components are rare ones, like you may have abnormal hemoglobin, which cannot carry adequate oxygen, and hence the oxygen content of the blood goes down, which will behave like a shock, typically methemoglobinemia, synemethemoglobinemia, etc. Now, what are the compensatory mechanisms? So there are 2 broad categories we make. One is a typical hypovolemia prototype, and second is a maldistribution. So what is the difference? In case of hypovolemia, as the volume in the vessels starts going down, gradually the body withdraws the blood from not so vital organs, pushing it into vital organs. So obviously, the brain, the heart, the lungs, liver will get the blood at the expense of blood being withdrawn from the skin, the kidneys, and intestine. So here is a child will have cold extremities, tachycardia, photo temperature difference being there, and maybe you reduced urine output, but the child is sensorium all right, and his heart may be perfused well. This is typical prototype of a distributive shock or proper rain, and you may have maldistribution, wherein this kind of a prototype is lost, wherein you upfront develop altered sensorium, tachypnea due to underperfused lung, and while doing so, the child is having warm extremities, CRT being normal, and urine output may be normal. So how does the body respond to plain simple hypovolemia? You need to understand this cartoon. You want to perfuse the tissues well. So if you have to perfuse the tissue well, you need to maintain oxygen content and the cardiac output. Where does the cardiac output come from? It is a complex of stroke volume multiplied by heart rate, and stroke volume is contributed by preload, that is intravascular volume, myocardial contractility, that is cardiac function. So either of these fails will reduce the stroke volume, whatever tachycardia, it may not compensate over the time and the cardiac output fails. Now, typically cardiac output and the stroke volume makes the blood pressure. So that's how we take blood pressure drop as a surrogate of a tissue under perfusion. Mind you, in this cartoon, what are the clinical parameters you'll pick up? Up front, you will see as a compensatory mechanism to one of these two losses, you will have tachycardia rising. If that cannot maintain the cardiac output, next thing to happen is a stroke, the systemic vascular resistance going up. That will cause decreased perfusion to the screen. So cold extremities, then you will have capillary fill going down. And then finally, last will be the blood pressure to drop. So when you document hypotension, you are perhaps too late in the resuscitation phase. This cartoon also try to remember when it comes to the management part, wherein you can do something on the preload by pushing volumes. You can improve the contractility by giving inotropes. You can maybe reduce sometimes stroke volume or this, and you can improve the oxygenation. So those are kind of targets later on resuscitation. How does body compensate for hypovolemia? So initially, this is the cartoon. It's very interesting to see when the volume of blood drops. How does body compensate? By increasing the systemic vascular resistance. What does it lead to? That will try to maintain the cardiac output and mean arterial pressure. That's your blood pressure. This will happen till maybe 20 to 30% of the volume being lost. And this will be seen as tachycardia mounting up, fall in the urine output, prolonged capillary time. And this is typically a normotensive shock where the blood pressure is maintained, but the parameters are already showing you that a shock has started. Now, if this volume goes down further, what will happen? Now your stroke systemic vascular resistance can no more maintain the mean arterial pressure and cardiac output. And that is what we call it as hypotensive shock, wherein you will set into multi-organ failure. And that is a very ominous sign. Once a patient loses the peripheral pulse and gets no central pulses, then the survival rate goes down very drastically. So you should essentially pick up the child in a normotensive shock phase. So what are the clinical correlates or signs of it? As I said, tachycardia will set in first. Then you will see the features of decreased tissue perfusion, which in case clinically, skin will be showing a delayed capillary refill time. Any refill time more than 3 or 4 seconds is abnormal. Increased core toe temperature. So at a normal core toe temperature of 37, if the peripheries are showing less than 34 degrees centigrade, that is the increased core toe temperature. So more than 3 degrees drop in the drop in the peripheral temperature. And then you have decreased hourly urine output. And then finally, altered sensorium, as I showed in the previous case, wherein you lose the Glasgow Coma scale or ABPU scale, wherein you can follow this scale, which is very easy bedside. The AVPU, A stands for alert child, V stands for responsive to voice, P for responsive to pain, and U for unresponsive. And then you will have poor peripheral pulses as the shock progresses, and blood pressure in a protocol shock is the last one to drop. So hypotension is a late sign of shock. Far before that, you have to focus on this feature. So dengue patient comes, you monitor these 6 signs and you will pick them early and you can resuscitate them early. Now, septic shock, as I said, is unique. It's a mal-distributed shock. So the vital organs will be under-perfused far before the non-vital organs. And hypotension and poor vital organ perfusion may be present despite good skin perfusion. Hypotension is still a sign of decompensation. Mind you, here, when you suspect septic shock, don't forget to screen the systems, all the systems, clinically as well as by lab, to find out how many more systems are affected. You got a liver dysfunction, as I showed in this previous case, you got HGOT-PAT raised, then perhaps that's add-on symptoms. The more the number of systems being affected, more critical the shock, more chances of multi-organ failure and death. Categorization of shock, we call it, as I said already, normotensive shock, which is early compensatory shock, and then the hypotensive, which is the decompensated shock. As it goes from normotensive to hypotensive, prognosis becomes more and more bad. Now we need to understand what are the numbers in pediatric patient. I have been focusing on pediatric simply because I'm a pediatrician. So we need to know the third percentile, the lower cutoffs of blood pressure. In case of systolic cutoffs, at an age less than 1 month, 60 millimeters of systolic that you need, 1 to 12 months, 70 millimeters of systolic, between 1 year to 10 years, it's 70 plus age into 2. So something like at 5 years, you want 70 plus age into 5, that's about 80 systolic. That's what you need minimally. Below that is to be called as hypotension. And after 10 years, it's 90 systolic that you desire to have. Nowadays, we follow mean arterial pressure because in pediatric, you need to be cup space. The proper size cup has to be available to follow these numbers. A large size, small size cup can make a difference. So if you have a non-invasive or invasive blood pressure monitor, monitor the mean arterial pressure, which is true perfusion pressure, and the numbers for that is 45 plus age into 1.5. That's the number you want to have on mean arterial pressure. Now, this is a new concept. We don't follow the old cold and warm shock. We follow narrow pulse pressure and wide pulse pressure, or wide pulse pressure with vasoplegic shock, and narrow pulse pressure is the vasoconstrictive shock, which will help us in subsequent inotropic resuscitation, especially in case of septic shock. How do we monitor? We classify the monitoring system as upstream monitors and a downstream parameters. Upstream is something what is being monitoring the parameters which are supplying the tissue, and downstream means the parameters which tell you what the tissues are taken and what is coming back. So heart rate, tachycardia, capillary fill delayed, core to temperature, blood pressure, saturation, these are upstream parameters, what is being supplied to the tissue. And downstream parameters are what you get out of it. So decreased urine output, altered sensorium, plasma lactate, bicarbs in pH, the acidosis, and mixed venous oxygen, which is dropping down, are all downstream parameters showing that the tissues are under perfused. So decreased urine output less than 1 ml per kg per hour, or we in fact follow less than 0.5 ml per kg per hour, telling us that the kidneys are being under perfused. Quickly on the treatment, as I told you the previous cartoon, again focus on that. On the cardiac output side, you have these two target parameters: optimize the fluid volumes and give a proper contractility, the cardiac contractility through vasoactive drugs and the cardiotonic drugs. And on the oxygenation front, monitor the hemoglobin, get it to normal numbers. So in a shock patient, anything more than 9 is desirable. Compensatory shock or no shock, you may be accepting 7 as a number. And oxygenation. So this patient who is spending so much of energy on his breathing, if you ventilate early, that will be additional feature helpful to resuscitate the shock. So treatment, we have, as I said, various focuses. So we first line of treatment is giving intravenous fluids, which are isotonic fluids. And we have debate between crystalloids and colloid fluids. Crystalloid being normal saline and ringer lactate, which are still the gold standards. Nowadays, we talk about balanced salt fluid, the plasma light and all. They are very costly, not having really great advantage. So we on an intensive care front still recommend the same thing. One thing I want to tell my practitioner friends, that glucose or dextrose is never a content of a resuscitation fluid. It should be only electrolyte with water, no glucose in the resuscitation fluid. Role of colloids, very limited, except maybe dengue or hypoalbuminic shock, like in nephrotic patients with shock, we may be giving. Otherwise, colloid does not have much advantage. Why? We are using colloid previously because colloid seems to be retaining much inside. You push 100 ml, 75 retained for at least about an hour or two. Vis-a-vis, we give crystalloid, most of it is washed out through the capillary leak in acute septic shock. This was our previous understanding. Now, first of all, we are giving very limited amount of fluids itself, so it has to avoid subsequent increased morbidity. And this is what from Cochrane review, there is hardly any difference between the final outcome and mortality benefit, whether you use crystalloid and colloids. Colloids, as I said, may be beneficial in dengue shock syndrome and albumin were dependent or kind of a hypoalbuminic shock, as in case of nephrotics. What about a vasoactive agent? We desire to have 3 level action. One, we want to have increase in cardiac contractility when there is myocardial dysfunction. We want vasoconstrictive action in case of vasoplegia. We want vasodilatation in cases of in case of there is a vasoconstrictive shock or narrow pulse pressure shock. Now, in case of increased cardiac contractility, which are the drugs which we'll be using? As a first line, we use epinephrine. Rarely we may add milrinone. I'm not going to details of this because it's a big chapter in itself. We want to use increased contractility drug. We use dobutamine or milrinone. Again, dobutamine has its own drawbacks. So milrinone is one which we use upfront. Vasoconstrictive alpha agonist. So the vasoplegia, then we are using norepinephrine upfront and vasopressin as second line drug. So these are the drugs that we use. I will not go into details of the doses. What are the further other management? What do you want to monitor and targets of it? You want to ultimately get the pulse rate back to normal. Before that, the blood pressure has to come back to normal. Capillary fill has to be settled down less than 3 seconds. Core to temperature has to come down to less than, the difference should come down less than 3 degrees. Urine output should be more. Improved mental status is very important. And finally, the labs have to come back to normal. If you go on the bedside, perhaps getting blood pressure back to normal within 1 hour. Lactate should come back to normal maybe within first to 2 hours, 2 to 6 hours. That has proven beyond doubt. Earlier, the reversal of lactate back to normal within 4 hours, better the survival, and the rest of the parameters definitely also. There were previously various principles tried, that early goal-directed therapy. Earlier, you get the things back to normal, better the survival. That was thought in 2000 years by a very big trial from Rivers. They said decrease mortality of 50% if you follow the goal-directed therapy of 1 hour and 6 hours, getting the numbers back to normal. Then over the time we found that's dangerous because it pushes a lot of fluids. Then the CFIS trial came in the South African countries where there's a lot of fluids are going to kill the children more. And today what we follow as a principle of thought, lesser the better, lesser the amount of fluids, optimize the things, do optimum time, optimum amount of fluid, early vasoactive agents, remove excess fluids. Once you stabilize the shock, remove that extra fluid early so that you will have a better survival and lesser morbidity. I'll quickly go through 1 or 2 cases which will, I'm sure, help you in understanding the issue better. So here is a 2-year-old brought with vomiting since 2 days, diarrhea since 1 day, frequent large quantity watery, no blood. On examination, shallow breathing, drowsy, radial pulses are weak. She's severely tachycardic, cold hands and feet, blood pressure not recordable, skin turgor is lost, fast urine, the typical hypovolemic shock in acute gastroenteritis. How to go about? Obviously, oxygen if the saturation is low. Now, this is something new. All shock patient, as we used to understand previously, should be given NRM oxygen. Today, we don't accept it. If the saturation of the patient is more than 95%, giving oxygen can be harmful. Don't give oxygen to these patients. Management, peripheral line, if it is not available, intraosseous line, quick boluses 20 ml per kg each. At the end of it, you have to review the situation and then monitor for any signs of fluid overload. We use a lot of bedside echocardiography for this nowadays and lung sonography. We have to recover the shock, then subsequently correct the underlying fluid deficit, and then look at the ongoing losses and the specific etiology of treatable. That's a classical gastroenteritis dehydration hypovolemic shock. In the case, 4-month baby boy referred to us for lethargy since morning, and he had fever 2 days initially and afebrile since 1 day. And he was kept for observation being such a small child with unusual symptoms. He was hemodynamically stable, rest was normal. Next day on round, mother said that baby is lethargic and not feeding well. I saw the child at 2 p.m. when I saw some staring episodes. Shifted to PIC for observation. He was having cold extremities, tachycardia, capillary fill delayed. We gave 2 boluses. CRT was better. Subsequently, these were the counts. CSF was done concerning it could be intracranial infection, which was normal. And then we thought whether it is septic shock. So blood culture sustained, first dose of ceftriaxone was given, fluid boluses were given, and then within no time he started crashing. We had to increase his artery, noradrenaline infusions, intubated at 2 hours in the ICU management because he was becoming more and more shocky, a refractory shock. He became fluid catecholamine resistant shock. Steroids were given, but he rapidly deteriorated in next hours by 10 a.m. So I started doing at 2 p.m., 10 p.m. he was bad. At 1 a.m., normotensive shock. We have been following this child with the echocardiography and so far nothing was there. Normotensive shock on noradrenaline, dobutamine, metabolic parameters were normal, calcium, sodium, potassium. At 1 a.m. his functional echo was normal, IVC was full, ejection fraction was good, pericardial fluids so normal, but he had metabolic acidosis. At 5 a.m. again I got a call from my colleague that he is crashing. So I went again, progressive deterioration at 5 a.m. and he had hypotensive shock, fluid catecholamine resistant. Now what to do? This is a time, again, your friendly echocardiography, which you have to learn as an intensivist to do it. This child had developed cardiac tamponade within a span of 4 hours. 1 a.m. there was nothing. At 5 a.m. full of fluid in the pericardial. We did the tap, pericardial tap bedside with 18 number angiocath under 2D echo monitoring, removed about 30 ml of pus. This was a fluid analysis of that, which was clear pus. Post-tapping shock rapidly recovered. Blood culture, Klebsiella pneumonia. He received meropenem for 14 days, got discharged after 14 days. And this was the post-tap picture. So these are kind of a miraculous things. I wanted to give few messages of these cases. Resistant septic shock management, my pediatrician friend, physician friend may be going through this. We have to optimize the fluid, titrate the inotropes, pressure agents, look for cardiac function periodically, look for the tamponade, look for obstructive shock component. If you don't get, you ruled out hypovolemic, ruled out your cardiogenic, look at the this kind of obstructive shock. Short knock responding predictably, we repeatedly should go through above 4 points. Since it is ongoing dynamic process and cardiac function may deteriorate gradually or tamponade may come up in a progressive way. So bedside echo is something which is to be learned. We have workshops now, all of us are doing. I think today in the ICU, we can work without a stethoscope, but we cannot work without an echocardiography. That's the importance of bedside echocardiography, lung sonography, and abdominal sonography, or neonate skull sonography. These have become our day-to-day. Every day I must be doing at least 10 echo and skull sono in my own ICUs. That's the importance of this modality. And these are the modalities. Those who are trying to venture into intensive care practice in future, they cannot go into that practice without doing an echo. H2 blocker, other modalities, there are controversies on that. Glucose again should be maintained above 120. Hemoglobin, if there is hemodynamically stable child more than 7, shocky child more than 10, and should we use intravenous hemoglobin in septic shock? Again, a controversy in neonates. Yes, we do use it at times, but then doubtful things. So friends, to summarize, shock is a state of circulatory failure. It can be classified as hypovolemic, cardiogenic, distributive, and obstructive. Clinically, it can be recognized by increased heart rate, tachypnea, abnormal capillary fill and pulses, hypotension, and altered mental status. Management is with fluid resuscitation, vasoactive drugs, optimization of oxygen and hemoglobin to this patient. Thank you very much.
Thank you, sir. Would you please stop sharing your screen so that we can share an e-memento from our side?
Sure.
Request the chairperson to please say a thank note to sir.
Thanks a lot, sir. On behalf of IMA, I would like to thank you. Thanks, Moite sir, for your excellent talk and guidance on the shock and its management. I would like to share with you, sir, that we have nearly all the pediatricians from ACLUS present in the hall over here. Your students are also there. We all, the students, nearly 4 or 5 students of you are present there in the hall, sir. Once again, thank you a lot. Thanks, sir.
Thank you very much.
Now I request Dr. Sujit Gandhi sir to please felicitate today's chairpersons. So moving on to the next session, that is radiology. I call upon Dr. Mansi Inamdar to coordinate the session. She is a radiologist herself. And I request Dr. Nilesh Thite sir and Dr. Nitin Thite sir to chair the session.
I request Dr. Nitin Thite sir and Nilesh Thite sir to chair this session. Dr. Nitin Thite sir is a senior radiologist from ACLUS, practicing since 21 years. He has done his MBBS from D.Y. Patil Medical College, Kolhapur, and PG from JJ Hospital, Mumbai. Dr. Nilesh Thite sir is radiologist practicing at Natepute since 14 years. He has done his MBBS from Bharati Vidyapeeth and PG from Praura Medical College. Now I request Dr. Nitin Thite sir to introduce our respected speaker, Dr. Yadav Munde sir.
Sir, आवाज नहीं.
Hello. It's my great pleasure to introduce Dr. Yadav Munde sir. At present, he is a Chief Interventional Radiologist at Ruby Hall Clinic, Pune, and also Associate Professor, Bharati Medical College, Pune. His academic qualifications is he is MBBS, DNB, and he has got his fellowship in Vascular and Interventional Radiology, KM Hospital, Mumbai. More than 50 presentations he has done as so far, and more than 7 publications. His main area of interest is hepatobiliary and onco interventions. He is awarded by Medical Excellence Award by Indian Solidarity Council in May 2018.
Over to you, sir. You can share your screen. Hello. Sir, please unmute yourself.
Yeah. Just a minute. I'm sharing my screen.
Yes.
So at the outset, I thank IMA Accludes for giving me such opportunity to present my work here. So now in next 20 to 25 minutes, we'll discuss about role of interventional radiology in emergency medicine. So as you may be knowing, most of the interventional radiology procedures are done on emergency basis, around 60 to 70%. And the principle of interventional radiology is same as surgery, and it is in practice since 18th century. So it is the first step towards pinhole surgery. So the principle is same like plumbing. Whenever there is overflow, we seal the leak, and whenever there is no flow, we clean the pipes. So these procedures can be divided in non-vascular and vascular interventions. So vascular interventions wise, we do arterial or venous revascularization by angioplasty, stenting, and thrombolysis. And whenever there is leak, that is bleeding from the vessels or tumors, we do embolization of those arteries and veins. And then IVC filter interruption for DVT, interventions for varicose veins and vascular access procedures. So today we'll discuss mainly the procedures which are done on emergent basis. Coming to non-vascular interventions, this can be percutaneous abscess drainages, nephrostomies, RF ablations, vertebroplasties, biliary drainages, etc. So first we'll see some examples of non-vascular interventions. Here in this case, you can see this is a 23-year-old male with necrotizing pancreatitis, and this was infected. So at this stage, he was not fit to undergo surgery. So here we help the surgeon by putting percutaneous drainage catheter, that is pictal drainage catheter, to drain the pus and reduce the bacterial load. And he was in sepsis, and after this procedure, he came out of sepsis. The another patient with sepsis, there is a large liver abscess in left lobe, which was again treated by percutaneous drainage by pictal drainage, and you can see after a month the abscess was completely resolved. So this is another case of distal CBD stricture. This was malignant stricture which was leading to cholangitis, and as you know, cholangitis has around 25 to 30% mortality. So here again patient was on many inotropes. So we took the patient in the cath lab. We do percutaneous access into the right duct, right biliary duct, went across the stricture, and the balloon dilatation was done in the stricture, and then stent was put. Once the stent was put, the infected bile was drained up, and patient's sepsis came down. Another case of proximal CBD stricture, again treated by putting metallic stent. So coming to the vascular procedures, see, most of the vascular procedures are done in cath lab. We call it as DSA lab also, digital subtraction angiography, under fluoroscopy guidance. And most of the times we take femoral artery access, and once we are into the arteries or vessels, we can reach anywhere in the body from brain till the toes. So you can treat any vessel in the body from head to toe, and I will show you some examples. So coming from head to toe, here you can see this was a patient of stroke presented to us within 4 hours from the onset. We did MR angiogram which showed left MCA complete occlusion, which was confirmed on angiography. You can see this is a DSA, digital subtraction angiography image. The MCA is completely occluded. So this patient we consult for thrombectomy. In that, what we do is we go into the artery, we reach beyond the occluded part. You can see this is the distal branch of the MCA, and we deploy the stent retriever in the occluded segment. And with the stent retriever, we take out the thrombus. And this is a post image. You can see the artery is completely opened up. This patient was having dense hemiplegia which improved to normal power within 24 hours. Another case having recurrent MCS stroke, we did DSA. You can see there is around 80 to 90% stenosis in the middle cerebral artery, which was treated by the stent graft. And you can see after the stenting, the flow is re-established, and there was no recurrent stroke after that. So this was done because even aggressive medical management could not solve the problem. So some patients may present with stroke having carotid artery disease. This is an example. You can see around more than 95% stenosis in the internal carotid artery. So in that case, we cross the lesion and we open that artery by putting stent. So coming to the bowel mesenteric ischemia, here again patients have, most of the patients have postprandial pain, and hence they eat less, then they will have weight loss, and at the end, if that is not taken care of, they can come with frank bowel gangrene. So this case was 45-year-old female having multiple hospital admissions for abdominal pain, but she was not investigated by CT angiography. So when she landed with us, we did CT angiogram, which showed significant stenosis at the origin of SMA. And you can see it was treated with the stent. This is a follow-up after 1 year. The stent is patent, and after the stenting, her pain was completely stopped. So some patients may present with accelerated hypertension and flash pulmonary edema. In this case, you can see this patient was having renal artery stenosis, which was treated by putting stent, and it was completely opened up. Coming to the peripheral vascular diseases, most of these patients will have claudication or ulcer or gangrene, and we have to take history. Most of them have diabetes and history of smoking, and feel for the pulsations. On examination, if there is doubt and if you feel there is a arterial insufficiency, do color Doppler, and on the color Doppler findings, we can consider if needed angiography, which helps in further treatment. So there are the risk factors for the PAD: smoking, high cholesterol, diabetes, overweight, high blood pressure, and inactive lifestyle. So these patients initially present with claudication and cramps, and later stages they can present with acute ischemia. So if these are the signs of acute ischemia, they can present with continuous pain in the limb or paleness at the initial stage, which may lead to cyanosis later, pulselessness, paresthesia, and paralysis. This severity of ALI can be divided into 4 grades depending on the patient symptoms and viability of the limb. And you should know that for marginally or immediately threatened limbs, that is category 2A and 2B ALI, revascularization should be performed emergently within 6 hours. And for viable limbs, revascularization should be performed on an urgent basis within 6 to 24 hours. So these are the pictures how patients present to us with the dry gangrene as well as wet gangrene. And earlier days, the only option was amputation, that is cutting the limb. But now we have different options. Either surgically, we can do bypass grafting, or by endovascular means, we can do angioplasty and stenting. And if patients present with acute thrombus in the arteries, then only angioplasty may not suffice. And in that case, we need to do catheter-directed thrombolysis or mechanical thrombectomy. In that case, what we do is we put a multi-hole catheter in the thrombus, and we give the thrombolytic agents over period like urokinase or TPA. I will show you some examples. This is a patient which was treated by catheter-directed thrombolysis. Angiography, you can see there is complete acute thrombosis of popliteal artery and tibioperoneal trunk, which was then cannulated. You can see this guide wire going across the lesion. Multi-hole infusion catheter was put, and urokinase infusion was given at 1 lakh international units per hour for 24 hours. And you can see after that thrombolysis, the arteries were completely opened up. This was because of embolic event, clot coming from the heart. So there was no underlying stenosis. So there was no need of angioplasty in this case. The another case with dry gangrene of great toe. When we evaluated, you can see he had complete aortoiliac occlusion, which we treated by kissing stent on right as well as left side. Same patient was also having occlusion in the tibioperoneal trunk, which was treated by balloon angioplasty, and it was completely opened up. And hence, this gangrene did not progress, and wound was healed completely after amputation of grade 2. There is another case of acute brachial artery thrombosis, again treated with TPA infusion over 24 hours. At the presentation, you can see the hand was dusky and cold, and this is post thrombolysis. You can see the hand is red, and earlier there was SpO2 was not recordable, which became 98% post procedure. Similarly, some patients of portal hypertension present with GI bleed, either upper GI or lower GI bleed. Most of the times we try endoscopic therapies to control that, but sometimes endoscopic therapies fail, and in that case we have to do emergency interventions like transjugular intrahepatic portal systemic stent. In that case, what we do, we come from the jugular vein into the right hepatic vein, and through that we puncture the portal vein and then bridge this with a covered stent. So we create a shunt. You can see this is an example of tips. Right hepatic vein was accessed. Then with the needle in the liver, we puncture the right portal vein. Then we dilate the tract, we create the tract, and that tract is covered by covered stent, so that the blood from the portal vein is directly communicated to the hepatic vein and then to the heart. Hence, the pressure into the portal system decreases and the variceal bleed stops. Coming to aortic aneurysms, this can be saccular, fusiform, or pseudoaneurysms. Again, you know the morbidity and mortality is very high if these aneurysms rupture. So for that, we have two options: either surgical graft placement or endovascular treatment by stent graft placement. As you know, surgery has a lot of morbidity and mortality, and hence we can avoid surgery by putting the endovascular stent graft. And in surgery, you can see there will be a large incision, and with the endovascular therapy, we take a small incision in the groin and put this stent graft. This is an example of aortobronchial fistula because of pseudoaneurysm from the descending thoracic aorta. Here you can see there is a pseudoaneurysm which was communicating with the bronchus, and patient was having hemoptysis. So what we did was we excluded this pseudoaneurysm from circulation by putting a covered stent into the thoracic aorta. Coming to the treatments for DVT, this can be due to long hospital stay or thrombotic profile. We do catheter-directed thrombolysis for the patients who are having acute or subacute DVT and having involvement of central veins, that is femoral vein, iliac vein, or IVC. So in that case, what we do is we access the jugular vein under ultrasound guidance, put the sheath. At the same time, we access the popliteal vein from down, and access sheath is put. So before starting thrombolysis, we put IVC filter in the infrarenal IVC, so that once we start thrombolysis, the thrombus becomes loose and can escape into the pulmonary circulation, which can lead to pulmonary embolism. So to avoid that, we put the filter, and then we go through the femoral access. We go into the vein and suck out the thrombus. Here you can see the thrombus is being sucked through this catheter. There are different types of catheters and machines available to suck the thrombus, called angiojet as well as penumbra. Here you can see a lot of thrombus is sucked from the veins, and this is a pre-procedure image. You can see iliac vein and femoral veins are completely blocked, and this is a post-procedure. Immediately the veins are completely opened up and there is good flow. through the veins. And this is while doing the procedure, the limb was swollen and red. And this next day morning, the limb swelling is completely gone and it was almost normal. And same day, the patient was discharged on oral anticoagulants. So CDT has very good success rate, no major complications, and this is needed to avoid post-thrombotic syndrome, which consists of recurrent leg pain, swelling, skin blackening, secondary varicose veins, and venous ulcers, which can happen later in life. So same CDT can be done for pulmonary embolism. This case you can see there is a lot of filling defect in the right pulmonary artery, which was treated by CDT and it was completely opened up. So this is mainly done for massive pulmonary embolism. Coming to vascular access related interventions, some patients may have vascular access problems. The all peripheral veins are thrombosed, cases of CKD will have problems of access for dialysis. So in that case, we do perm cath insertions on emergent basis. Patients in ICU or any ward needing long-term chemotherapy or long-term antibiotics, we can put peripherally inserted center line, and hence we can avoid sclerosis of the veins of the upper limb. So we treat AV fistulas as well as central venoplasty for the CKD patients coming with thrombosis of those veins. So I'll show some examples. This is a permanent catheter put from left jugular axis with a tip in right atrium. This is a case of AV fistula, radiocephalic fistula, which was thrombosed on Doppler. So unless we treat early, this thrombus becomes organized and we can lose the this AV axis. So this was taken on emergent basis. This was the thrombus which was aspirated. You can see this is an angiographic image. There is filling defect in the vein suggestive of thrombus. And this is after aspiration of the thrombus. It was completely opened up. This was again a case of central venous occlusion of the subclavian vein. Patient was having AV fistula, working AV fistula, but because of swelling, they were not able to access it. So we did open up that vein, and you can see this is a swelling while taking on the cath lab table. This is the next day morning. You can see the swelling is completely gone as we have opened up the central vein. So till now we discussed about the revascularization. Now we discuss about embolization. So embolization means embolus means object which causes obstruction, and we do it deliberately. Hence, it is called embolization. And this is a modern therapy to treat bleeders. So here the principle is we cannulate the culprit vessel, inject embolic agent, which forms the thrombus and blocks the blood vessel. There are the different types of embolic agents available. This is gel foam, PVA particles, fibered coils, balloons, etc. So this can be the indications: massive hemoptysis, GI bleeds, pseudoaneurysms of any artery, AV malformations, angiodysplasias, tumors, fibroids, etc. We'll show some examples. So this patient was having hemoptysis more than 300 ml per day, and this was the bleeding from the right bronchial artery. Hence, we went in bronchial artery and blocked with the PVA particles. The another case, post-cholecystectomy status, large pseudoaneurysm from the right hepatic artery. We went in the hepatic artery. You can see this aneurysm is arising rightly from the hepatic artery. So in this case, what we do is we block the front door and back door of the aneurysm so that it will not fill to the collaterals. That's what is done here, and it is completely excluded from the circulation. The another case, hemosuccus pancreaticus. Here you can see large pseudoaneurysm from the gastroduodenal artery. We go into the gastroduodenal artery, and you can see embolize it with the coils. This is another case of GDA pseudoaneurysm in patient of chronic pancreatitis, large pseudoaneurysm leading to bleeding. We put the coils and block the blood vessel. This is a 28-year male IT professional having RTA, presented to casualty with systolic BP of 60. Immediately we took him for the CT angiography, which showed contrast extravasation from the branches of hepatic artery, and there was large laceration in the liver. We directly took him into the cath lab, blocked the bleeders, and his life could be saved. Similarly, some patients may have massive PV bleeding menorrhagia that due to fibroids or AV fistula, postpartum hemorrhage, and placenta previa. So this also can be treated by uterine artery embolization, and hence one should know that there is an alternative to hysterectomy, that is uterine artery embolization, in which what we do is we go into the uterine artery, put the particles and block the blood supply to the uterus and fibroid. So this is a case of fibroid uterus. You can see there is a lot of neovascularity in the fibroid, and which this is after embolization. This is from the right side, again, lot of neovascularity, and this was also embolized. And this is a post-embolization. The vascularity is completely gone. And you can see the follow-up. The patient's fibroid is reduced by more than 70%, and her symptoms were completely vanished. Another patient with PPH, unrecordable BP, we did angiogram. You can see there is a pseudoaneurysm from the uterine artery. We go in and put the coils, and that's all. The bleeder is stopped and her blood pressure started coming up. Another patient with placenta previa. In that case, what we do is we put the catheter into the internal iliac arteries, and once the baby is delivered, we inflate the balloons in the internal iliac arteries so that there will be no bleeding from the uterus, and there will be no massive bleeding leading to life-threatening complications. Another case of post-PCNL hematuria. We treat a lot of patients having post-op bleeding. Here you can see there is a pseudoaneurysm from the left renal artery post-PCNL, which was treated by putting coils. The artery was blocked. Coming to the AVMs, these patients also can present with to emergency with bleeding. This was a leg AVM presented with bleeding into the casualty. We did angiography. You can see this is the nidus, very vascular, very big nidus, which was treated by percutaneous as well as transarterial embolization by glue. This is a post embolization. It was completely obliterated and bleeding was stopped. Coming to some cancer treatment also, some patients of cancer can present with bleeding due to cancer. The cancer can lead to erosion of the vessels. This is a case of carotid blowout in a case of CA thyroid. You can see there was contrast extravasation from the common carotid artery, which we treated immediately by putting covered stent, and the leak was stopped. Some patients may present with iatrogenic post-coronary plasty problems, like this patient having large pseudoaneurysm in the groin because of puncture-related issues, and there was pseudoaneurysm and hematoma. So this was confirmed with the CT angiogram. You can see this is a pseudoaneurysm. So in this case, what we do is we puncture this pseudoaneurysm with a 21 gauge needle, and through that we put thrombin inside that. Once the thrombin comes in contact with the blood, the aneurysm gets thrombosed instantaneously, immediately on taper, and limb can be saved. So to conclude, interventional radiology has got many applications and many advantages. The access size is less than 2 mm in diameter. There are no incisions, no sutures, no dissections, and immediate ambulation after the procedure is possible. And there is very less minimal hospital stay for the patient, and hence better quality of life. And sometimes it's the only solution for patients in emergency situations. So to summarize, I'm a plumber of human body. So anytime, anywhere there is leak or there is block, I'm always available to do the needful. And this is a growing branch, and many people are not aware about it. So I thought this was a great opportunity for me, given by IMA Occludes. And once again, I thank all the organizers for this opportunity. Thank you.
Thank you, sir. Very interesting case-based and yes, simplified presentation. Now I request Dr. Nilesh Thite sir to thank today's speaker and felicitate him with e-memento. Sir, can you please stop sharing the screen so that I can present e-memento?
Yes, yes.
Yes.
Thank you, sir. It's a very informative lecture. Once again, thanks from IMA Aklus branch. Thank you.
Thank you.
Now I request Dr. Manasi to felicitate today's chairperson. Thank you, sir. Thank you both of you for sharing the session. After this, we move on to urological emergencies. To coordinate the session, I call upon Dr. Rohit Fade to coordinate the session.
Good afternoon, all. Today's topic is urological emergency. I would like to invite Dr. Vidyut Shah sir and Dr. Abhijit Gandhi on stage to chair the session. Dr. Vidyut Shah sir is a well-known and leading practitioner in Akluz. He is practicing urology since last 40 years. Dr. Abhijit Gandhi is practicing urology since last 12 years. Now, Dr. Vidyut Shah will introduce our speaker.
Good afternoon, dear friends. At this juncture, we are in a postprandial somnolence syndrome. And the best way to take all of you out of this is nothing but Dr. Gyanendra Sharma's lecture. As everyone knows, Dr. Gyanendra Sharma, if you go through his credentials, it's a whole textbook. So with his kind permission, I'll tell you a few lines about him. He is a well-known urologist from Sholapur, well-known not only in Western Maharashtra, but nationwide. He is a good academician and he is a practicing urologist par excellence. Whatever an academician wants, all those credentials, all those heights, all those altitudes, he has already achieved and he is still on. To his credit, there are so many publications in local journals, national journals, and international journals. And the best thing anyone can hope for is getting his article in textbooks. That's an achievement. That's the best thing anybody can dream of, and he has already done that. I have seen him operating. Fantastic urologist he is. Worth watching. Just go on watching. One thing I'll tell you about him is there are surgeons and there are surgeons and there are more surgeons. But if it comes to your family member as a urology patient, you can definitely blind-eyed bet upon him. He is one of the best human beings I have ever come across. About his uretry, I better not tell about that anything. You will just witness in few seconds. So I don't want to be an obstacle between you and him for a longer time. Gyanendra, Mike, and the audience is all yours.
Good afternoon, sir, and thank you very much for very kind words. I would at the outset like to thank IMA Akluz for giving me an opportunity to speak on this topic. Am I audible and my slides visible?
Yes, sir.
Now, urological emergencies is a vast area, and honestly, to cover all urological emergencies in a matter of 15 to 20 minutes is beyond the scope of any speaker. So what I have done is looked at only 3 common emergencies which general practitioners or anybody can come across in their clinical practice, be it a surgeon, physician, or a pediatrician. The first one of it would be retention of urine. Now, retention of urine is basically a diagnosis. The patient comes to us with the complaints of inability to pass urine. And when he says he is not able to pass urine, what are we supposed to do? The immediate answer comes is catheterize. But is it the correct approach? I think the correct approach is to remember Karina. Well, it's not the heroine Karina which I am saying, but it's the mnemonic Karina which I allude to. K stands for complaints. It's extremely important that we note the complaint. Has the patient not passed urine? And if he has not passed urine, since how long has he not passed urine? In summer season, especially in areas like Sholapur, which are very hot, it's not uncommon to come across patients who say that they have not passed urine and they feel that they are probably in retention. But very often it is their dehydration and the bladder is very often empty. So it's not. I often ask the patients in the months of April and May to sit under a fan and drink lots of water, and very often they pass urine comfortably. So knowing the complaint is very important. And we need to differentiate whether it is retention or whether it is anuria. Because the patient will come with the complaint that he has not been able to pass urine. If it is retention, then any clinician would be able to tackle it. But if it is anuria, which is absence of urine in the bladder in the last 24 hours, then this is a real emergency which needs to be tackled by a urologist and would require an emergency sonography to know whether it is an obstructive or a pre-renal or a renal cause, and then treated accordingly. So when it comes to retention of urine, that is the patient has a sensation to pass urine but is not able to pass urine, we still need to differentiate between two entities. One is the acute retention of urine, where the patient is having a painful sensation in the lower abdomen. He has a strong desire to pass urine, but is unable to pass urine. Now, in this particular scenario, the first thing that needs to be done is relieve his agony by passing a catheter. As against this, the other situation is chronic retention of urine, where the patient says he is not able to pass urine comfortably. Very often these patients present with complaints that they are wetting their underpants or they are passing small quantities of urine, and at times they present only with complaints of nocturnal enuresis, because that is the only time in sleep where they are not able to control. Otherwise they keep on going to the washroom very often. Now, chronic retention of urine needs to be first evaluated, and then the bladder needs to be decompressed. Because if there is a sudden decompression in patients with chronic retention of urine, and especially if that is associated with bilateral hydroureteronephrosis or presence of raised creatinine, then there can be troublesome hematuria, and especially if he is on any of these antiplatelet agents. The next thing that we need to know is how do we evacuate? And the way to evacuate is by catheterization. And if time permits, at the end of my talk, I would present a small video showing the correct way of doing a perurethral catheterization, especially in a male patient, because often this is a very neglected procedure, but which has catastrophic complications in the form of stricture in the long run. So acute retention of urine, you evacuate the bladder and evaluate, while in chronic retention of urine, you first evaluate by doing renal function test, sonography, a good clinical examination, and then evacuate the bladder by slow decompression. But there are three things which one should never do. Never do a suprapubic aspiration. Never do a blind urethral dilatation, because once you damage the urethra, the person would curse you for a lifetime because you have given him a stricture which is extremely difficult to treat. And paradoxically, I have seen a lot of clinicians, especially in rural areas or even in cities like Sholapur, where they have given injection Lasix. So an acute retention gets converted into chronic retention. The patient passes some drops of urine, which is because of overflow of distended bladder, and the clinician feels that he has emptied the bladder. So never do suprapubic aspiration, never do a blind urethral dilatation, and never give injection Lasix. And at the end, I would say that just catheterization is not important. It is mandatory that we should do it. But at the end, we need to find out the cause and subsequently treat it. Catheterization is relieving the emergency, but admitting the patient is of paramount importance so that complications like hematural times, sepsis, and infection can be identified and treated very quickly. Now, when we talk about how to treat retention of urine, it would be catheterization. And as I have mentioned that if time permits, I would show a video of the same. Now, when it comes to catheterization, what are the basic principles? So when I said when it comes to a patient coming with inability to pass urine, remember Karina. So if you remember Karina, you need to also remember SAF. And the principles of catheterization are, you need to remember that the size of catheter should be only 14 to 16 French in an adult patient. It should be smooth catheterization, which means that we need to instill good amount of 2% lignocaine jelly in the urethra so that the passage of the catheter is painless. It should not be an event which is imbibed in the psyche of the patient to an extent that he has nightmares regarding catheterization. And we need to remember that for a painless retention, that is chronic retention, it is always slow decompression. Now, very often I am asked that how do you achieve a slow decompression? One of the ways which is described in books is that you pass a catheter and tie it to an IV stand, which is at the level of the patient, that is at the level of the cot of the patient. And with each movement of the diaphragm, there is some rise in the intra-abdominal pressure. And with that, there will be slow decompression of the bladder. I had tried it initially in the early stages of my career using this particular modality. And I very quickly realized that our staffs or somebody, some mama or maushi is very quick to realize that this is the wrong thing. And they immediately put a for urine bag down and the bladder gets decompressed very fast. So the easiest way would be, what I have realized is, pass a small sized catheter, like that is a 12 French Foley catheter, and this would decompress the bladder pretty slowly. Out of SAF, we have seen S. Now when it comes to A, catheterization should be done with asepsis. We all know about catheter associated urinary tract infection, but it is obligatory on our part to see that we do not introduce infection. So a procedure of catheterization should be done as a surgical procedure is done, with all aseptic precautions, explaining the procedure to the patient and instilling good amount of jelly so that adequate anesthesia is present. Now, when I say good amount of jelly, in a male, one should instill at least 10 cc of 2% lidocaine jelly. Ideally, they say it should be 1 cc for per centimeter of urethra, and a male urethra is about 18 to 20 centimeter long. But you can take out about 3 to 4 centimeter of the prostatic urethra. So instill the jelly at least 10 ml and wait for a minute or so, talk to the patient, explain the procedure, and then do catheterization. I stands for inflation of balloon of Foley catheter and taking care that infection should be avoided. Now, this is important because very often the juniors look at the Foley catheter and it is written over there that 30 to 50 ml, and very often the catheter is inflated, the balloon is inflated to about 30, 40 or 50 ml. Now 30 to 50 ml, which is mentioned on the Foley catheter, is the maximum capacity of the balloon and not the amount of fluid that we need to inject. we need to inflate the balloon by about 10 ml of sterile water. And I reiterate, it should be sterile water. Now, why this is important is because if we use normal saline, especially in the summer months, I have seen that there is some precipitation of salts, and this causes blockage of the catheter, and then there is an emergency that the Foley catheter cannot be deflated. Infection should be avoided by asking the patient to take care of the catheter as if he would take care of his body. Very often I tell the patients that you treat the catheter as part of your body. So when you are taking a bath, you clean the catheter with soap and water as you would clean your limbs. And the catheter should be kept in a way that it is not in touch with the perineum, because perineal part is one part of the body that despite all your precautions, there would be billions of bacteria over there, and that would cause ascending infections. So fixation above and not below the thigh is mandatory. Now this also helps in one way, because very often patients with chronic retention of urine tend to have a catheter for a very long duration, which could be even for a few weeks, 3 to 4 weeks. And this causes undue pressure at the pinoscrotal junction, resulting in stricture at the pinobulbar junction. Now, this is fine that you have passed in a catheter, but what to do if the catheter does not go? So you remember S stands for Sharma. So the other thing is, if the catheter does not go, remember 3S. Use a small sized catheter. One can pass an 8 French or a 10 French infant feeding tube, and if it goes in easily, the emergency is taken. One can do a suprapubic catheterization. It's a very simple procedure. Suprapubic cystostomy can be done by any clinician. If he has seen it once or assisted one SPC, he can do it very easily. And if either of these things, that is the catheter does not go, even a small sized, or an SPC is not possible due to whatever reasons, it is better to send a patient to a surgeon or a urologist who would tackle the emergency. The second urological emergency which I would like to discuss with you is management of renal colic. This is one of the commonest emergency that a urologist or a surgeon comes across, especially in the months of April and May. The first and foremost thing when a patient presents with colic is pain relief. It is not investigating the patient, but it is pain relief. And the analgesic of choice is either we use NSAIDs in the form of diclofenac or ketorolac, or use opioid analgesics in the form of tramadol. Injection paracetamol 1 gram is also a very good analgesic. If you look at the EAU guidelines 2021, NSAID are the first choice, followed by opioid analgesics and then paracetamol 1 gram. The dose of diclofenac is injectable intramuscularly, it's 75 milligram. If it is given in the form of an IV infusion, it's the same dose. While ketorolac can be given intravenously straight away in a dose of 30 milligrams, but slowly over 15 seconds. And the way to inject it over 15 seconds would be to dissolve it in saline in a 20 cc disposable syringe, so that whosoever injects it does it slowly. Or a better way would be to inject 60 milligram intramuscularly. Each ampule of ketorolac contains 30 milligram. So 2 ampules IM also works equally well. If NSAIDs are contraindicated, as if the patient has history of allergy to these drugs or is an asthmatic, then one can use injection tramadol in the form of an IV bolus of 100 milligram or IV infusion. And if one is worried about the side effects of opioids in the form of vomiting, one can even try injectable paracetamol 1 gram. By and large, antispasmodics in the form of buscopan and rotavirin have very little role to play, because the cause of pain in a patient with renal colic is obstruction causing stretch of the renal capsule and the release of prostaglandins. And hence NSAIDs are the first choice antispasmodics virtually have no role in relieving pain in patients with renal colic. Now, another very common tendency on part of people is patients presenting with colic are immediately put on IV fluids. Now, these are indicated only if the patient is dehydrated or there is history of vomiting 4 to 5 times, which again indicates dehydration. But I would like to stress here is that there is no role of flush therapy. In fact, all the listeners and if they can carry home one simple message that there is no role of flush therapy in patients of ureteric colic, I think I have achieved my purpose. Now, what is basically flush therapy? Now, flush therapy is the procedure which a lot of clinicians follow is giving 1 or 2 IV fluids fast and give an injection of furosemide. That is there is a thought process that this flushes out the stone. In fact, when I was a undergraduate student, I had seen this being done very often, even in government medical colleges. But now let us understand what happens during a colic. Initially, the renal blood flow increases and the pressures are high. This is within the first 6 hours. Now, from 6 to 18 hours, the renal blood flow steadies and then it starts to decline, but the renal pelvic pressures are still high to the tune of 50 to 75 millimeters of mercury. And then it is after 18 hours that the renal blood flow decreases and the pressures start to decrease. So when a patient is having an acute episode of colic, he is having obstruction in the ureter. Now, whenever there is obstruction, there is back pressure effects, and this results in certain physiological changes in the kidney, which are in the form of decrease in urine production, decrease in the concentrating ability of the kidney, and decrease in the excreting ability of the kidney. So now, if you look at these effects, it would be very obvious that if a patient has received IV fluids and has been subjected to an injection of furosemide, that is Lasix, the opposite kidney is producing more urine. The opposite kidney is throwing out urine. This particular kidney, which is affected and has obstruction due to a stone in the ureter, is not excreting that amount of urine, which might help the patient to flush out the stone. So the best way is settle the pain of the patient. And then once he is not having vomiting, ask him to take good amount of fluids so that he can have a urine output to a tune of more around 2.5 liters per day. And I think that achieves the effect and there is no need for giving any diuretics. In fact, by giving flush therapy, we are exactly producing the opposite effect. Because for a stone to be thrown out, the only good effective mechanism is good effective peristalsis of the ureter. And a good effective peristalsis of the ureter is possible when the walls of the ureter coapt with each other. If there is a steady column of urine from the kidney till the level of obstruction, the effective peristalsis is never produced. And by giving patients flush therapy for over 3 to 4 days, we are just binding, tying him down, but not achieving any clinical purpose. So friends, the simple take home message is you're not supposed to take her home, but remember that Rani, that is renal colic, is treated by analgesics and not by injection Lasix. Now, once the pain is settled, the next thing to be done is investigate the patient by doing a CBC, serum creatinine, blood sugar levels, especially if the age is more than 30 years, and serum uric acid levels. Now, Western books mention that the incidence of hyperuricemia in patients with who are stone formers is around 5%. But my data over the last 20 years indicates that this incidence in our part of the district is more than 20%. The next investigation for which we are not supposed to hurry is doing radiological investigations in the form of KUV, sonography, or a CT scan. Radiological investigations to diagnose a calculus should be done only and only after the episode of colic has subsided. Never advise a KUB or a non-contrast helical CT scan without knowing the LMP in a young lady. If it is more than 15 days old, especially in a married woman, confirm the absence of pregnancy without having an exposure to radiation. A few words regarding ultrasound. Now, over a period of time, I realized that people have started trusting ultrasound to an extent that even if you say that the sun is rising in the east, they would ask that does sonography mention it? And especially when it comes to patients with colic, they feel that the gospel truth lies in the ultrasound report. There are certain things which all of us we need to understand. In the best of hands, with the best of machines, sonography would diagnose a ureteric calculus in not more than 60 to 70% of patients, which means that 30 to 40% of the patients will not be having a calculus picked up on a sonography despite undergoing a test by the best in the world with the best of the machine. Also, if sonography is done within the first 6 hours of an episode of colic, there is not adequate hydronephrosis which has developed. And in the absence of a window which is provided by a dilated ureter and fluid, it is very difficult for the most experienced sonologist to pick up a stone, and more so ever if it is lying over the ala of sacrum. And if unfortunately this patient has received few doses of buscopan, then the bowels are dilated and the gaseous shadows interfere a lot. There was an old study in British Journal of Urology which mentioned that if the clinical suspicion is strong and you order an ultrasound, you are likely to pick up a calculus more than 50% of the times. But if the clinical suspicion of a ureteric colic is less and still a sonography is done, then the chances of finding a ureteral calculus would be less than 5%. So in the end, when it comes to a diagnosis of a ureteric colic, it is the clinical judgment which supersedes all other investigations, with the exceptions of a CT scan, because that would pick up a calculus in more than 98% of cases. And the only calculus which cannot be picked up by a CT scan is the indinavir calculus, which is because of the drug indinavir given in patients who are receiving ART. Now, very often these patients are started on antibiotics, and I think we all need to realize that India is one of the Southeast Asian countries where there is rampant abuse of antibiotics. And I think the days are not far when we will be knowing that the patient is having infection, but no antibiotic will work. And hence, it is imperative that we all use antibiotics highly judiciously. The indications for giving antibiotics in patients with renal colic is if there is presence of fever, urine is showing more than 15 WBCs per high power field, or if the total count is more than 15,000. All patients of colic can be managed by any clinician, but the subsequent management need to be individualized. And we need to understand that when we should refer a patient to the urologist. So the easiest way to remember when a patient should be referred to a urologist is, remember की जेव्हा खडा तुम्हाला आणि त्याला पिडायला लागला की you refer him to a urologist. PIDLA is the mnemonic which stands for persistent pain, infection, deterioration of renal function, that is serum creatinine is high or there is presence of anuria or oliguria. It's a large calculus which is more than 8 millimeter in size, and I am sorry that it is written 6, it's more than 8 millimeter in size, or abnormal situations, that is it's a solitary kidney or there is pregnancy with colic. The third urological emergency which I would like to discuss with you is an acute scrotum. Now, out of these three emergencies, if you ask me, a colic can be managed by a urologist on phone. Retention, by and large, you can train your staff to manage retention by putting in a catheter in a judicious way. But if there is one emergency for which a urologist has to get up, even in the middle of the night at 2 a.m., is a boy presenting with acute scrotum. Consider a case study where a 10-year-old male complains that while he was playing, there was a sudden onset of left testicular pain. This persisted. There is no change in the severity of pain with position. There is no burning micturition, no fever, no chills, no nausea, no vomiting. On examination, he is afebrile. he is in distress because of scrotal pain, he does not allow you to touch the scrotum. There might be edema and erythema over the scrotum. The testicle is lying in an abnormal lie or is lifted upwards, and very importantly, there is absence of cremasteric reflex. Now, if these features are present, it's a strong indications that there is testicular torsion. Very often, we ask for CBC urine examination. Now, if they are going to be available in matter of minutes before the operation theater is getting ready, then it is worthwhile doing it. Otherwise, there is no point in wasting time getting these investigations done. Likewise, referring this patient to a sonologist for a color Doppler scan is again not needed. I am extremely particular when it comes to choosing a patient for surgery, but I strongly believe that if there is one surgery where even a negative exploration is pardonable, this is an acute scrotum, because if you are able to salvage that testis, it is far worthwhile than trying to confirm the diagnosis by means of investigations, which again are not foolproof. And color Doppler sonography will also be able to give you a diagnosis in about 80 to 90% of cases, not 100%. So such a scenario is basically an emergency where exploration, and if you are judicious in your clinical evaluation, you would be diagnosing testicular torsion far more accurately than with any investigation. And if it is found, the treatment is twist the testis, do detorsion, fix the testis. And the way to fix the testis is by using non-absorbable monofilament material, that is proline. 3-point fixation is done to the dartus tissues. And very importantly, the opposite testis is also to be fixed by 3-point fixation. Now, why this is important is because one testis which has undergone torsion, this torsion is on account of an anatomical abnormality which is present on the other side also. It is equally possible that the opposite testis would have a torsion at some part of the in some part in life. So it's mandatory on part of the surgeon that he should fix the opposite testis also. The commonest deformity which results in torsion is the Bellin-Klepper deformity. Overall incidence is about 2 to 6%, very commonly seen in patients who have undescended testes following strenuous exercise, and especially during puberty where there is a sudden spurt in the size of the testicular volume. So this is one scenario where the diagnosis is critical. Why is it so important? Because within the first 4 hours, there is obstruction, there is interference with the blood flow, and within 6 hours, you lose the testis. So ischemia occurs in less than 6 hours. Some people believe as soon as 4 hours, and it is certain in 24 hours. So if you diagnose testicular torsion and undertake a surgery within 6 hours, there is a more than 90% chance that you can salvage the testis, which drops down to 50% if you have done an intervention within 6 to 12 hours. And it is less than 10% chance of salvaging the testis if you undertake an intervention after 24 hours. Acute scrotal pain, which is not associated with fever or burning micturition in an adolescent age group, is testicular torsion unless proved otherwise. Of course, there are certain other differential diagnoses in the form of epididymitis, orchitis, and incarcerated hernia, or very rarely torsion of the appendix of testis or an idiopathic scrotal edema. But again, I emphasize that a good clinical history and a good clinical examination, palpating the lie of the testis being pulled up, and the absence of cremasteric reflex are quite good indicators of presence of torsion. I would not deal into a lot of these issues, but if there is a testicular torsion, the first thing that you can try is do detorsion. The way you can do a detorsion is as if you open the book. That is, the left side testis is turned in an anti-clockwise direction, and the right side is turned in the clockwise direction, as if you are opening a book. This might, suppose there are 3 or 4 turns which have resulted in torsion, and you are relieving 1 or 2 turns also by the time the theater is getting ready, probably some degree of blood supply is restored, and this can make a difference between orchidectomy and doing an archaeopexy. So friends, don't delay a surgical consult. This is one test, one emergency where do not rely on investigations, rely on your clinical judgment and intervene as early as possible so that you can salvage the testis. Thank you so much for a very kind hearing. Sir, is there time that I can show the video of catheterization, or I can pause my talk?
Please proceed. Please show the video.
Yeah, thank you, ma'am. Is the screen visible?
Yes, sir.
There is some problem in playing the video.
Hello.
Yeah, ma'am, there is some issue. I think,
Yes.
yeah, it is working. Is the video seen now?
Yes, yes.
Yeah, the most important thing during catheterization is, as I had mentioned earlier, you should approach it as you are approaching a surgical procedure. And the first part in a surgical procedure is painting and draping. You should paint the lower part of abdomen, the thighs, and the genitalia with an antiseptic solution like 5% betadine. In a male patient, it is extremely important that we retract the prepuce and clean the glands, because if this particular step is done, you can prevent ascending infection for more than 96 hours in majority of the patients. Very often, this particular step is not done, and this results in ascending infection, which patients come back to you with a lot of troublesome burning. Then next step is draping with an sterile towel. We usually keep a tray ready for catheterization, and then instill 2% lidocaine jelly and tie a small gauze piece at the distal part of the penis so that the jelly stays in place. And this is the time where I have trained my assistants that they should talk to the patient, ask a few questions so that there is some effect of the anesthesia. Hold the penis straight so that there are 2 curves in the penis, one at the scrotal junction and one at the bulbomembranous junction. So one curve is straightened. Introduce the Foley catheter till the Y touches the glands. Wait till the urine comes out. This is one of the commonest mistake which is done, that you put the catheter and you inflate the balloon. Wait till the urine comes out, and then you inflate the balloon by using 10 cc of sterile water. Another small piece of caution would be that when the prepuce is retracted for cleaning the glands, it should be brought back to normalcy so that there is no paraphimosis, which again would become a urological emergency. So this is a small video regarding catheterization. Thank you so much for a very patient hearing, and I'm really impressed with the way Akluj IMA has conducted this particular conference in an absolutely flawless manner. 3 cheers to the entire team who have done a commendable job.
Thank you, sir. Thanks a lot. And I must say that you are a born teacher and म्हणजे असे हाताचे शिक्षक असतात तसं, and it was a pleasure to listen to you, especially on Teachers' Day. And I am sure apart from photo of Rani Mukherjee and Kareena Kapoor, everyone would definitely remember all the basics and mnemonics that you have told. So excellent talk, sir. Thank you. And I request today's chairperson to please thank sir and present him with e-memento.
मित्रांनो, आज टीचर्स डे. या क्षणापर्यंत माझा असा गैरसमज होता की टीचर हा नेहमीच सिनियर असतो, तो नेहमीच बायोलॉजिकली क्रोनॉलॉजिकली एल्डर असतो. पण हे लेक्चर ऐकलं आणि माझी खात्री झाली की टीचर नीड नॉट बी elder one. Gyanendra is junior to me, but every time I listen to his new lecture, I tend to learn something new. Gyanendra, thank you very much. You are a person who knows your stuff, and you know that stuff. And the better part is you can explain the same clarity into audience. So thank you, Gyanendra. Thank you very much. And I asked the audience, do you agree with me? This was one of the best lectures of the conference.
Yes, sir.
Thank you. Thank you, Gyanendra.
Cleared so many basics. Thank you. Thank you, sir. And I request today's coordinator, Dr. Rohit Phade, to felicitate today's chairperson. There was no somnolence, sir. Vidyucha, sir. The lecture was so good. There was no post-meal somnolence at all. Everyone was very vigilant. For the next session, the session is on Dermat. I request Dr. Aditi Thitte ma'am to please coordinate the session.
Thank you, Dr. Revati. I know this is a post-lunch session and it's a bit difficult to concentrate on the lectures. When we say dermatology, we thought that it is a non-emergency, glamorous, stress-free branch. But this is not an absolute truth, because even in dermatology, there are certain conditions which should be treated as an emergency. So our today's topic is emergencies in dermatology. And we feel very privileged to have Dr. Arun Inamdar sir as a speaker on the occasion of Teachers' Day, because sir is a great UG and PG teacher, and sir's lectures are always an academic feast for all the dermatologists. Now I would request Dr. Ranganath Harpanhalli sir to chair this session. Dr. Harpanhalli sir is a senior dermatologist of Akluz, and sir did his UG and PG from VM Medical College, Solapur, and practicing since last 25 years. Sir has interested in clinical and aesthetic dermatology. Now I would request Dr. Harpanhalli sir to please introduce our today's respected speaker.
Hello, friends. It takes me immense pleasure to introduce a very honorable name in the field of dermatology, Dr. Arun Inamdar. He's a professor and head of the department, BLD University College, Bijapur, Karnataka. He has got 30 years of UG and PG teaching experience. He has 200 publications on his name and 11 books he has edited, 70 chapters. He's a huge academician. So please welcome Dr. Arun Inamdar.
Well, good afternoon to all of you. I'll be sharing my screen first. Okay, I hope everybody is able to see the screen.
Yes, sir. Yes.
Okay. Well, thanks to IMA Close, Dr. Aditi, and all the team members of IMA Close for inviting me to be part of an interesting session. In fact, I learned so much from the two speakers, intervention radiology and also the urology one. Well, as Aditi was telling, talking of emergency in dermatology, maybe around whoever has finished dermatology long time back would laugh at us. People think that, okay, dermatology in olden days, it was just application of gentian violet. Now it is cosmetology, laser surgery, and many more things. But well, there is a role for dermatologist in emergency also. But I will be, as the audience are of a different specialty and all the IMA members, I thought I will give some 3-4 case scenarios wherein there is a role of emergency dermatology and dermatologist also, and how best a primary physician can look into and when he can refer to the dermatologist for a better outcome. This is what I'm going to talk. The very definition of emergency in the medical field, emergency stands for immediate action to tackle the unforeseen, that means expected or unexpected complication of the disease process, or those arising from use of therapeutic agents also. This is very important from point of view of a dermatologist. The therapeutic agents, especially drugs, are the main bane of many of the conditions. Let me start with one scenario wherein you can encounter is the urticarial lesions all over the body with or without the angioedema. This is really an emergency, especially if there is a lip edema, angioedema is there, or even the tongue angioedema is there. Definitely it calls for an immediate action, which is very the life-saving method only. Then I was called to see this patient wherein the patient had an acute urticaria and also the other respiratory symptoms also. There was a history of eating some fish which was overnight cooked, and the fish was the cause actually in this patient. So how do you manage these things? If you really think simple urticaria as an emergency, especially in children, they can come because parents are also worried, and antihistaminic would definitely do. But if you find anything over the face, especially the lip edema or the tongue edema, any respiratory difficulty, probably you have to give injection adrenaline 0.4 cc or 0.2 cc for a child for subcutaneously is a must. And then it has to be followed by the antihistaminics, which are known to all of us. So the idea of telling this is adrenaline has to be given. And if it is really needs some more things like steroid can be used for about 3-4 days. What is the steroid which we have to use? Hydrocortisone, hemisuccinate, 100 milligram 8 hourly for about 3 days. So adrenaline 0.4 cc subcutaneously and hydrocortisone, hemisuccinate, 100 milligram 8 hourly would be the best choice. And of course, you have to continue with the antihistaminic for about 3 days or so, or even 24 hours. If things are come down, only antihistaminics will do. Here also it is same. But if it is, it's not easy that, okay, urticaria is there, you just forget it, you can give these things also. But there has to be an evaluation by the dermatologist where he can decide whether it is acquired or hereditary angiogenetic edema, then whether it is arterial vasculitis, whether it is chronic spontaneous urticaria or chronic inducible urticaria. These are the areas where you can just take a decision. Otherwise, if a patient is with comorbid condition, ACE inhibitor-induced urticaria can also be, or angioedema can also be seen. So for this reason, once the urticaria is controlled, probably you can send to the dermatologist wherein they can evaluate and further treatment can be advised. Generally, the first line treatment for any urticaria would be second generation antihistaminics. Second line would be, you can also increase the dose about 4-fold. And then third line, biologicals like omalizumab. And we also use fourth line, sometimes cyclosporin. Anyway, this is just to give an academic explanation about how we really manage. But the role in emergency is adrenaline hydrocortisone, hemisaxilin. Then the second scenario would be, well, any of you must have prescribed the anti-epileptics. After 2 weeks or so, or within 1 week or so, patient may develop this, both the mucous membrane involved and all over the body, there can be blebs like this, target lesions we call in dermatological literature. They may develop it. So this is another one, wherein the child was again given some anti-epileptic. He came with this type of picture to our OPD. I was referred from the pediatrician for these lesions. This was a long time back, about 30 years back, when I was just started my journey as dermatologist. The rampant use of cotrimazole was there then, not now. So this is after cotrimazole, Ceftriaxone was used, and the patient almost was denuded of the skin, almost like if surgeon sees this, or any general physician would see this, okay, this must be a burn-like thing, almost burn-like condition. So there can, I will just tell you what are those things later. There can be even sometimes just fever with target lesions, which are erythema multiforme minor and major we call. And if there are target lesion, then it is Stevens-Johnson syndrome. Here you can also see with many of the drugs which we use, especially sulfonamide was a drug which was to cause, and now of late it is anti-epileptic, carbamazepine, phenytoin, those are the causes also. And then if there is any fever, generalized erythema, skin tenderness, and target-like lesions, which I showed you from the first slide itself, the diagnosis is toxic epidermal necrolysis. This is the picture. Well, you can also see good number of patients like this. We see often after the drugs, especially I was telling you the anti-epileptics, you should be careful enough. Then what are the definitions, which I already told you? How do you divide these cases? Lesions and epidermal detachment between 10 to 30%, we call SJS and TN overlap. Or if more than 30% of the body is involved with mucous membrane involvement, then we call it as a toxic epidermal necrolysis. What is interesting is they are essentially drug induced. Almost 70 to 90% of the cases, it is drug. So history is very important as far as these cases are concerned. You must inquire about the drug, and the culprit drugs has to be taken note of it. And nowadays the therapeutic armamentarium is widely expanding. So you may be using good number of new drugs also. You have to check in with the Medscape or some other literature whether the new drug is also causing it. And then what are the complications which you should look into is, immediately what all you can do is that fluid and electrical imbalance has to be corrected. Super infection should be looked into, because the whole body is peeled up there in toxic epidermal necrolysis. Secondary infection going in for septicemia is also there. And skin is an important organ for temperature regulation. There will be impaired thermoregulation, and a lot of energy expenditure will be there. Immunological function alteration, hematological abnormalities will be there. And even the GIT and tracheal epithelial will also be there. What would be our aim of treatment? Our aim is to reduce the mortality, block the extent of the disease, reduce the associated morbidity, and also prevent the sequelae. I've just put 10 commandments for supportive care. All of us can go through, but mainly it is for dermatologists. But generally, a person who recognizes this condition, you can do all these things. First, discontinuation of all non-essential drugs. Only keep the essential drugs. Of course, it's for dermatologists to look into that biopsy. Admit or transfer to burn unit, or sometime in some of the institutions, we have got dermatology intensive care in our university. You have to look for the fluid and electrolyte nutritional supplementation. Don't give any prophylactic antibiotics, because their antibiotic themselves may be cause for the TEN. And then always use non-adherent silver based dressings, almost like managing the burns actually. Bland emollients, pulmonary toileting, that means sucking, and then the ophthalmic care, because the prevents of the complications of the ophthalmic part has to be taken care. And initially you can do a culture for the skin and body fluids, because then only there are indications for antibiotics. And anyway, that is how you can just look into. Here in general physicians or general practitioners can recognize those conditions. So if at all you want to, nowadays it is so easy, not, I would like not to tell so easy, so blessed with drugs which can take care of these type of severe disease also. If the case is referred to dermatologist, definitely he would use the cyclosporine. This is what happened to one of the cases of Stevens-Johnson syndrome within 7 days. Only 7 days treatment is enough. The clinical resolution is seen in 5 days of the cyclosporine. And then this was a case of drug-induced TN. Nevirapine was given. The patient was also a HIV individual, and the patient developed the drug-induced TN. And see, child was on ART. This was a nevirapine-induced Stevens-Johnson syndrome with TN going in for. And this is a response after cyclosporine. Day 1, day 2, day 3, and by 6th day, everything is dried up. So this is one good thing, development and therapeutic armamentarium where we can use. But I feel the case should be referred to dermatologist wherein he can efficiently use it. And if at all you want to start the fluid and electrolyte supplementation, well, normal saline is the first line treatment, but human albumin and fresh frozen plasma are also other treatment options. Now coming to the emergency number 3, the scenario where you can come across, this is also another one with the drug itself. The child, the first picture shown, where again given the dapsone for his leprosy, the patient developed almost whole body peeling, that means exfoliative dermatitis we call, and there was hepatomegaly and liver was deranged. And similarly, again, this patient, carbamazepine, drug-induced hypersensitivity syndrome we call, and obvious jaundice is also seen in this patient. So these are the conditions called as a drug hypersensitivity syndrome. There are various criteria, but for a generally physician and all, or the general practitioner, well, if you give any drug within 6 weeks or so, if you can see this type of exfoliation, hepatitis, jaundice, and deranged LFT, well, you should suspect drug hypersensitivity syndrome and stop the drug. And these are the various drugs which can cause. Best way of seeing all those things is you download the Medscape in your smartphone, and you always check what are the drugs which can cause these things. From A to B, whatever commonly used also here, like the carbamazepine, then the dapsone, hydroxychloroquine, ibuprofen. Of course, nowadays people do not use cyclin, phenobarbital, and phenytoin. The drugs list keeps adding also. And what you do is assess the assessment of the extent of systemic involvement. You have to rule out the hepatic is the first one, then the renal and pulmonary one. And the drug of choice is steroid actually. And definite indications are interstitial pneumonitis, nephritis, rapid improvement of symptoms on laboratory parameter will be there. There will be an impact on long-term disease course. Usually these patient may develop autoimmune thyroiditis also. Hence, earlier you give corticosteroid, probably those complications should be avoided. And then how do you, I've been telling you drug, but how do you really find out the drug timeline and suspect that? The most important data in determining if a rash is medication related is timing. By preparing a drug timeline, you can help find likely medication causes. Start with the onset of the rash as a day 0 and work backwards and forwards. For exanthematous drug eruption, the initiation of the medication is often 7 to 10 days before the rash. For repeat exposure, it may be shorter. I will just give you an example here. Day 0, red line. What was started within 7 days was ceftriaxone. So the probable culprit is ceftriaxone. Though the patient is taking since many days albuterol, morphine, hydromorphine, lisinopril, Coumadin, or heparin. So this is how you can find out probable link between the drug, probable cause of the causative agent rather, because you can't stop all the drugs here. Then the last one, the scenario 4. I talked about the drugs. Now some infection can also be an emergency. There can be children with fever, diffuse sheet-like desquamation, beginning of the face. We call some Nikolsky sign, wherein they can peel the skin with the pressure. And you can see in a newborn also feeling like almost again scalded or burnt like thing. They are nothing but the staphylococcal scalded skin syndromes. They are caused by staphylococci. The superficial blistering of the skin disorder is by the exfoliative toxin of the some strains of Staphylococcus aureus. The following may be noted: fever will be there, tenderness to the palpation. Body, the patient, you will touch the skin, the child weeps or the person, in fact, it is more common in children, hence adults very rarely you can get it. And then perioral crusting, which I showed you some pictures, and the Nikolsky sign, where gentle stroking of the skin causes the skin to separate at the epidermis itself. So these are the diagnostic one. How do you manage? Well, all cases of SSS, systemic penicillin-resistant antibiotics should be used. Usually cloxacillin is the best one, but only cloxacillin is available. It's not available now. Dicloxacillin plus the amoxicillin or other combination would be there always. And then for tender skin, you can use acetaminophen or fentanyl. And sloughing of the skin, you have to dress it, and aviofluids also should be given, because whole of the skin can also be peeled in this case also. The last one would be another one. Well, a child with fever and headache with rash can be a presenting symptom. The classical things which you can observe here is bilateral periorbital edema here, stuffiness of the conjunctiva, obviously seen here, and also edema of the hands and feet, and history-wise, frontal headache would be there. That's nothing but the rickets cell fever, which are very commonly seen in our part of Karnataka, northern and southern part of Maharashtra, or western Maharashtra, what do you call? The eruption will be fever with rash, headache is an important one, and the nausea, vomiting, diarrhea would also be there. What is more important is the type of lesions. What do you get all over the body? The ecchymotic lesions would be like fern-like one, actually fern leaf-like things, and there can be one, the ankle swelling, that joints arthralgia would also be there. So highly suggestive findings, which I just narrated: bilateral periatrial edema, suffusion of the conjunctiva, edema of the hands and feet, and frontal headache. And the lesions on the palms and soles are very important, and centripetal distribution. So some of the investigation which any practitioner can look into is decreased leukocyte count. And more interestingly is the thrombocytopenia. If there is facility, you can also see the sodium level, where you get the low serum sodium level. And commonly we do the Weil-Felix test. This can be used as a screening test, which detects more cases than misdiagnosed ones, and when positive is reasonably specific. Weil-Felix test still serves as a useful and cheap diagnostic tool for laboratory diagnosis of rickets cell disease, which you can do it. And what is more important, when you clinically suspect, don't have to worry about wait for the Weil-Felix also. If these things are which I mentioned, if we have ruled out other conditions, especially nowadays dengue or meningococcemia, well, you have to give doxycycline. Doxycycline is a drug of choice for treating presumed or confirmed RMSF. Oral treatment is used unless patient is vomiting or difficult, and dose is standard 5 mg per kg in 2 divided doses. In children below 45 kg, 200 mg per day, 2 divided doses. Duration of the therapy should be at least 3 days after deference, or minimum of 5 to 7 days. Once the fever comes down, add at least another 5 days treatment. And of course, books mention, of course, there are concerns like use tetracycline to children, whether to use it or not below 8 years, tooth staining, all those things are not, I don't think it is very important. It has been observed that cosmetically perceptible staining of the teeth requires 6 to or more multiple days course of therapy, hence probably 3 to 5 days, and the life-saving nature of the drug should be more important than any other things. Thanks very much. I just narrated few stories wherein drug-induced ones, especially SJS10TN and drug hypersensitivity syndrome, which you have to look into, and urticaria, how you can encounter and manage it, and some infections like the rickettsial fever. Thank you very much. And I'm really thankful to the IMA Close for giving me an opportunity.
Thank you, sir. Thank you.
The
Dermatology nowadays is just equated to mostly cosmetology with fillers and lasers. So it was really nice to listen to an elaborate talk about emergencies in dermatology. I would request today's chairperson, Dr. Harpanari sir, to thank sir with an e-memento. Hello. Sir, yeah, you have to just thank him.
Thank you very much, sir, for a
Thank
nice, wonderful lecture. Thank you.
And I request Dr. Aditi to felicitate today's chairperson for chairing the session. We have been blessed with excellent orators. That is why still at the end of the session, we still have more than 370 participants who have still logged in. So moving on to the last session, that is psychiatry. I call upon Dr. Marti Namdar to coordinate the session.
I request Dr. Nivant Harare sir to chair this session. Dr. Nivant Harare sir is senior psychiatrist practicing in Aklus since last 20 years. He has done his MBBS and post-graduation from BJ Medical College, Pune. Now I request Dr. Harare sir to introduce our today's respected speaker, Dr. Vidyadhar Vatve sir. Thank you.
Hello, good afternoon everybody. सर्वात शेवटचं लेक्चर आहे. टाइम कन्स्टंटमुळे शेवटचं ठेवण्यात आलं. सरांचं नाशिकला ॲट अ टाइम लेक्चर असल्यामुळे आपल्याला हे पुढे ढकलावं लागलं होतं. It's a great pleasure to introduce me my teacher Dr. Vidyadhar Vatve sir. He is a consultant psychiatrist in Pune Hospital since last 40 years. He is also past president of Indian Psychiatric Society, also member of American Psychiatric Association, fellow of Indian Psychiatric Society. Also, he has contributed in research journals, conferences, workshops, CMEs, and also in panel discussions. Saranni also contributed in 2 books, some written. Also, which सरांना जीवन गौरव पुरस्कार पण देण्यात आला होता. तसंच लाईफ टाईम अचीवमेंट अवॉर्ड पण देण्यात आलं होतं. आणि सर्वात महत्वाचं म्हणजे सायकॅट्री बरोबर सरांचं इतरही छंद आहेत. सर जसं सर्वांना माहित असेल की मोहन आगाशे सरावर सरांनी घाशीराम कोतवाल या नाटकामध्ये काम केलं होतं. तसंच आणखीन खेले या नाटकामध्ये पण काम केलं होतं आणि उंबरटा या फिल्ममध्ये काम केलेलं आहे. इट्स ग्रेट प्लेजर टू इंट्रोड्यूस मी sir, over to you.
Can I start?
Yes, sir.
Yes, sir.
Thanks for the invitation. Can you share the first slide? Can you share the screen for me?
Just a second, sir. Just a second. Hello, sir, can you just give me 1 minute? Sir, you have the PPT with you right now?
Oh, okay. It is not able to make. You are not able to share it.
So if you have it with you right now, please share it. Otherwise, I'll just check it again on the mail. Just a second.
I'll to get it. the emergency psychiatry.
Hello.
Trying.
Sir. No. We have opened your presentation. Please stop the screen share so that I can share your PPT.
Yes. We will do it now.
Yes.
You are sharing it for me?
Hello. Yes, sir.
You are doing it? You are sharing the screen?
Yes. So we can start the lecture, sir.
Well, good evening and sorry for this minor issue.
No,
and
sir.
Thankful to Nivant and all the organizing team of this conference. My topic is emergency psychiatric medicine. Can we go to the next slide, please? No conflict of interest. Next slide. Okay. I joined psychiatry, friends, because I thought there will be no emergency problem or emergency cases in this branch. But I was completely proved wrong. Emergency psychiatry is a subspecialty of psychiatry, which has gained now great momentum in the recent past. Because in 70s, the mental hospitals were closed, mainly in Western countries, mainly in America. The number of mental hospitals were started closing down and patients used to come in community and stay in community. They used to get community care. That led to more and more cases of emergency psychiatric problems and crisis situations because patients in the mental hospital came out in the population and that's how it increases. Emergency psychiatric medicine, it's a psychiatric emergency service. We call it PES. Now this PES is there, it's a concept in West. But in our country, I think our casualty medical officer is the emergency psychiatry service center. The first contact person of any patient for any disease coming to hospital for admission is a meets casualty medical officer. And he's one of the most important person and with great responsibility is working. But if you at all have maybe in future psychiatry emergency service particularly designated for this problem, then what you can have academic services. You can teach people. You can trainees of many disciplines and come and discuss with you. For example, medicine interns, medicine graduates, or people who are doing general medicine, people who are doing nursing, people who are doing psychiatry, people who are in social worker, and including now even Ayush doctors can be trained. They come from various specialties and they can be trained in this emergency psychiatric service. We call it CMO level. All mental health professionals, one day or the other, will be faced with situations involving patients in crisis. Today, when I say mental health professional, what is included? Psychiatrist, psychologist, psychiatric social worker, psychiatrically trained nurse, and all Ayush doctors. They are all mental health professional and all can start a rehab center or a psychiatric hospital. We call it mental health establishment. So all, including Ayush, they can all start and they are all now called as mental health professional. Only thing is, if a Ayush doctor is treating the patient, we are not, this is a gray area whether they should treat it with their own pathy medicines or they should use allopathic medicine. That's a gray area which can be settled soon. Now, when such a patient comes to the emergency room or CMO in our case, what you have to do first? Rule out general medical condition or GMC presenting with psychiatric symptoms. Any general medical condition, acute myocardial infarction, can present with disturbed behavior. Acute stroke can present with disturbed behavior. Acute toxic substance inhalation or consumption can present with psychiatric symptoms. So what is important that you have to sit down and take history, including history of substance use or abuse. Substance is a new word, means addictive agents. Benzodiazepine is a substance, alcohol is a substance, marijuana is a substance. So all charas, bhang, ganja, everything is a substance which can cause tolerance, which can increase tolerance and ultimately lead to habituation and finally addiction. So take very important to know proper history of substance use, because in cities like Pune, rampant use available are charas, bhang, ganja. Cannabis is available anywhere. Hookah is available anywhere. So first rule out all that, then rule out organic mental syndromes. A brain tumor can present with epileptic seizure episode and come with confused behavior, come with behavioral disturbance. Psychosis, the major psychiatric problems of a severe mentally ill patient are a psychosis. Friends, all psychotic illnesses are not schizophrenias. Schizophrenia is a very important psychotic illness, but there are non-schizophrenia, severely disturbing psychotic illness also. We'll see later. Mood disorders, bhavananse azar, acutely ill manic patient can come with a grandiose idea and jump from here and there and come to hospital in a CMO setup or emergency setup. He will be in the top of the world and he'll be shouting, screaming, singing and whatnot. So mood disorder mania is very commonly presenting with emergency treatment, for emergency treatment. Depression, generally what is expected, depression where the patient is hopeless, helpless, sad mood, but agitated depression. When the patient is agitated, he can land up in the emergency unit for treatment. Delirium, delirium of whatever etiology, hyponatremia, toxemia, sepsis, simple bladder distension can bring the patient in a disturbed state. It's a case of delirium. Find out the cause and treat it. It is 100% reversible. Anxiety. You will wonder why anxiety patient should come to emergency, but he comes severe panic attack. If it is a first or second panic attack, the person doesn't know where to go. He rushes from this doctor to that doctor. The doctor probably is not available. Then he comes to emergency. Ki doctor, I'm having palpitation, perspiration. I feel I'm going to die. Marun jaina se vatta. Please treat me. So all these problems, they come with an emergency symptoms, but you have to rule out all this, right from medical condition to anxiety condition. Next, please. Next slide. No, earlier. One slide earlier. इसके पीछे, okay. One slide earlier. और पीछे एक मागची slide क्या? Yes, now next slide, please. Okay. Now next, we have done this. Next slide. Next slide. Okay. So when such a patient, when all this variety of psychiatric patients, psychiatric symptoms and patients come to you, what should be done? Safe environment for emergency evaluation. थोडे शांत जागेमध्ये घ्या आणि मगच बोला. शांत आणि सेफ फॉर यू अँड सेफ फॉर द पेशंट अशी एक थोडीशी आयसोलेट केलेली जागा धरा. पण बाकीच्यांचंही लक्ष तुमच्यावर असू दे, कारण पेशंट कॅन अटॅक यू. Basic investigations. You can do lab, X-ray, CT, MRI if required, if you are suspecting a stroke, presenting with behavior disturbance. Drug screen, very important. In metros, drug screen is easily available, qualitative as well as quantitative. They do all screening for all common drugs that are used or abused and available in the market. Then the restrain. Restrain म्हणजे पेशंटला पकडावं लागतं. What I would suggest, physical restraint with holding the patient at joints. बरोबर, तुम्ही जर तुमच्या कितीही मोठा पैलवान असेल आणि तुमच्या बरोबर जर 2-3 लोक स्टाफ असेल तर दोघांनी मनगट धरायचं, दोघांनी शोल्डर जॉईंट पकडायचा आणि तिसऱ्यानी दोन्ही नी जॉईंट पकडायचे. ह्याच्यावर जर प्रेशर दिलं, जॉईंट्स पकडले तर पेशंट हलू शकत नाही. बरोबर, आणि सेक्ल्युजन म्हणजे त्याला कोपऱ्यात घ्यायला पाहिजे. आणि अजून एक गोष्ट एथिकली अलाउड आहे की नाही प्रश्न वेगळा. पेशंटला ब्लाइंड फोल्ड करा, पेशंटच्या डोळ्यावरती टॉवेल टाका. कोणीही मोठा टेररिस्ट असेल, हे 2-3 जॉईंट पकडले आणि जर डोळ्यावर पांघरून टाकलं तो हेल्पलेस होतो. त्याला तुम्ही करून बघा, अंधारात डोळ्यावर टॉवेल घेऊन चालता येते, अवघड होतं ते. आता मेडिकेशन काय द्यायचं, औषधं काय वापरायची इमर्जन्सी. यू कॅन गिव्ह डिस्पर्सेबल मेडिसिन, म्हणजे पाण्यामध्ये घालून, चहामध्ये असो किंवा ज्यूसमध्ये घालून. पण पेशंटला आजकाल पक्क माहिती आहे की याच्यात औषधं घातली आहे, तर ते घेत नाहीत, ते जस्ट थ्रो इट बॅक टू यू. इंजेक्टेबल. इंजेक्टेबलमध्ये 99% ऑफ द इमर्जन्सी सर्व्हिसेस अँड द CMO, any disturbed patient, they give Fortrin Phenergan invariably, which is the biggest mistake. If the patient is severely disturbed, unless he's an opioid addict, he will not be quietened down with injectable Fortrin Phenergan. But all other patients, they do not need Fortrin Phenergan. They need Phenergan with haloperidol injection. Injection haloperidol 10 to 15 milligram mixed with 25 to 50 milligram of Phenergan in one syringe, the same syringe you can give on the lateral aspect of the thigh. Keep the patient restrained with your 3 friends. In big hospitals, corporate hospitals, they have actual bouncers. In my hospital, there are bouncers. They just they even don't touch the patient. They are just 3 bouncers standing, and you can imagine the patient becomes quiet. So they don't even touch the patient. There are female bouncers also available for female patient. So dispersible, okay, you can mix haloperidol, dispersible is available, Praxi available. You can use it dispersible in a glass of water or injectable. No Fortrin Phenergan. No Fortrin Phenergan. Give Phenergan 25 to 50 with 2 to 3 ampoules of haloperidol, easily available, syringe bag. ECT. Electroconvulsive treatment as an emergency medical treatment if the patient is severely agitated, suicidal, and he said, and he's brought from the home because he tried to hang himself. Just to rule out medical problems, you can give ECT. But the new Mental Health Act, the new Great Mental Health Act of 2017, does not allow us to use ECT, the most cost-effective treatment in emergency setup, in emergency condition. Friends, it's the biggest flaw in this law. ECT is meant to be treated in an emergency situation. Acutely ill psychotic patient, acutely disturbed psychotic patient, violent patient. If he's of course, all medical causes ruled out. Severely ill, suicidal patient, ECT is the treatment of choice. But this law does not allow you to treat as an emergency treatment this ECT for first 72 hours. According to this law, 72 hours is taken as an emergency period. Now that 72 hours starts from the patient, which started from home. It started yesterday evening. You have to wait for 72 hours, put the clock, and then 73 hours you can give VCT or whatever. This is the flaw in this Mental Health Act. Psychological interview. When everything is little quiet, then you can request a psychologist to have interview, or you can do basic psychological interview and mental state examination, etc., which includes standard psychiatric interview. Okay, next please. Next. Can we go to next slide, please? Okay. Now, legal principles. I have already said so much about this Mental Health Act. ज्या वेळेला इमर्जन्सी ट्रीटमेंट असते त्यावेळेला हा मेंटल हेल्थ केअर ऍक्ट ऑफ 2017 आल्यामुळे बऱ्याच अडचणी येणार आहेत. त्याच्यामध्ये काय कलम आहेत? ऍडव्हान्स डिरेक्टिव्ह म्हणजे सायकियाट्रीचा हा ऍक्ट आता इम्प्लिमेंट झालाय, प्रत्येक हिंदुस्थानभर इम्प्लिमेंट झालाय. वापरता जातो की नाही हे गोष्ट अलग आहे, वापरायला पाहिजे, कारण त्याच्यावर आधारित लोक तुम्हाला त्रास देऊ शकतात. ऍडव्हान्स डिरेक्टिव्ह म्हणजे पेशंट हिमसेल्फ राईट्स कि I am so and so. If I get my next manic attack, I should not be treated with this and this drug. I should not be treated by XYZ doctor. The patient writes as if it is assumed that he has got the ability to take his own decision. But who decides the ability? The law says he can write. Then when the patient comes in an emergency situation, you can imagine you are trying to control the patient. First question you have to ask, Baba, तुम्हारे पास एडवांस डायरेक्टिव कुछ है क्या? बोलने का काय का एडवांस कुछ नहीं है, तो फिर अभी कुछ लिखना चाहते हो? He can there and there he can ask for a piece of paper and write I should be treated or should not be treated. I may go and kill myself but I should not be treated. अगर ऐसा हो गया तो you have to inform that XYZ hasn't made an advance directive, he has done it just now, and we are supposed to contact the mental health review boards. Those review boards are there for every district. In Maharashtra, we are supposed to have 37 or 36 review boards. Hardly 2 or 3 are formed. Nobody is working. There they will. What are the people who are working? Retired judge, patient representative, one psychologist, one psychiatrist from the practicing psychiatrist, private practitioner. ये सबका बोर्ड होता है, उसको पूछेंगे पेशेंट आया है, बहुत हंगामा करता है, लेकिन बोलते हैं ट्रीटमेंट नहीं देगा. Can you imagine this situation is today because of this Mental Health Care Act? And Indian Psychiatric Society has made an public interest litigation in Bombay High Court, which is pending. We are waiting for some modification. What is the other thing? Nominated representative. म्हणजे काय की आजपर्यंत फॅमिलीचा मला सपोर्ट होता, पण मी आज म्हणणार की मला माझे आई बाप भाऊ कोण नको, मला शेजारच्या जोशांचा मुलगा इज माय नॉमिनेटेड रिप्रेझेंटेटिव्ह. आणि तो सांगेल तसं ऐका. बसले गरीब फॅमिली जी आतापर्यंत आपल्याकडे फॅमिली सेंट्रिक फॅमिली वेअर द फर्स्ट केअर गिव्हर्स, त्यांना बाहेर काढल्या कायद्याने, आणि तो XYZ जोशींचा पुतळा किंवा कोणीतरी माझा पाहिजे तोच माझ्या वतीने निर्णय घेईल असं जर पेशंट म्हणला तर ते ऐकावं लागतं. त्याच्यानंतर येते इन्फॉर्म कन्सेंट. या सिच्युएशन मध्ये इन्फॉर्म कन्सेंट घेण्याचा प्रयत्न करावा लागतो की मी तुला हे देणार आहे, तसं देणार आहे, हे देऊ का, मी तुला आता बांधून ठेवणार आहे. 3:42 बांधलेलं लिहावं लागतं, 3:53 ते काढलेलं लिहावं लागतं. त्याची सही लागते. जो शेजारी नातेवाईक म्हणजे तो नॉमिनेटेड रिप्रेझेंटेटिव्ह असेल तर. लकीली काय एक्सेप्शन्स आहेत? इफ इट इज इमर्जन्सी, वी आर डीलिंग विथ इमर्जन्सी. इनकॉम्पिटन्स, पेशंटची क्षमता नसेल की माझा निर्णय मी घेण्याची क्षमता नसेल तर इन्फॉर्म कन्सेंटची क्लॉज फेकून द्या. थेरॅप्युटिक प्रिव्हिलेज, थेरॅप्युटिक वेव्हर, याच्या चर्चेत आपल्यात फारसा अर्थ नाही. पुढची स्लाइड. नेक्स्ट स्लाइड. ओके, पण मॅन्डेटरी डिस्क्लोजर काय? सगळी कॉन्फिडेन्शियलिटी म्हणजे सगळं या कायद्यानुसार आहेच, पण मॅन्डेटरी डिस्क्लोजर इन इमर्जन्सी काय करावं लागतं? Child abuse or child neglect. If the child tells you, it's mandatory to inform police. Elderly abuse or elderly neglect, new law is there even in our country about elderly abuse. Duty to protect third party. We call it TORS of duty. That means If my client tells me that I am going to murder my wife tomorrow, forget about confidentiality. You have to go and inform police that XYZ is going to murder his wife. So it's a duty to protect third party. May not be his wife, may not be his friend, but they सांगावं लागतं. This is a mandatory disclosure. Past treasonous act. देशद्रोहाचे पुढील वर्तन असेल तर ते कळवायला लागतं, करावं लागतं डिस्क्लोजर. इंटेंट टू कमिट फ्युचर क्राईम. आता माझं सगळं ठीक आहे, परंतु मी पुढच्या काही दिवसामध्ये मी माझ्या मास्तरनी यांना मग कमी मार्ग दिले, त्यांचा मर्डर करणार, मारायन त्याचे हाड पाय तोडे, असं जर तुमच्याकडे आलं तर फॉरगेट अबाउट कॉन्फिडेन्शियलिटी, इन्फॉर्म द पोलीस. HIV is, of course, you all know, it's a mandatory disclosure. Next slide, please. Psychiatric ethics. जनरल मेडिकल मध्येच आपल्याला एथिक्स आहे. एथिक्स, मॉरल्स, प्रिन्सिपल्स, राईट्स, एथिकल रिझनिंग, हे सगळे डायलेमा आपल्या पुढे येतात. त्याला वेळेअभावी आता चर्चा नको. पण मेडिकल काउन्सिल ऑफ इंडिया, नाव नॅशनल मेडिकल काउन्सिल, महाराष्ट्र मेडिकल काउन्सिल, जे अजून अस्तित्वात आहे. नॅशनल मेडिकल काउन्सिल तसे आपल्या सगळ्या स्टेटच्या मेडिकल काउन्सिल जाऊन तिथे त्यांचंच यायचे अशी शक्यता या कायद्यानुसार होती. अजून आलेलं नाहीये. थँक्स टू ग्रेट एफर्ट्स बाय द IMA अँड ऑल अवर कलिग्स ऑब्जेक्टिंग टू दिस. आत्ता तरी महाराष्ट्र मेडिकल काउन्सिल, स्टेट मेडिकल काउन्सिल थोडक्यात ते आहे, आणि तुम्ही पास झाल्याचं तुम्हाला रजिस्ट्रेशन करता तेव्हाच कोड ऑफ एथिक्स अँड कंडक्ट तुमच्या हातात मिळतं. अजूनही ते माझ्याकडे ठेवलेलं आहे. तर ते एथिक्स आणि सायकियाट्रिक प्रॅक्टिस मध्ये एथिक्स मध्ये फार फरक नाही. कुठल्याही जगभर असेल ते एथिकलच प्रॅक्टिस करावं, आणि कंडक्ट काय असावं त्या इश्यूज आत्ता इथे मी सांगत नाही, पण सायकियाट्रिक एथिक्स मध्ये हे सगळे इमर्जन्सी सुद्धा बघावं लागतं. नेक्स्ट स्लाइड प्लीज. नेक्स्ट स्लाइड. ओके, नाउ ऍक्च्युअली व्हॉट आर द चॅलेंजेस इन इमर्जन्सी. पहिली गोष्ट सुइसाइड. सुइसाइड इज अ लॅटिन वर्ड फॉर सेल्फ मर्डर. पॅरासुइसाइड म्हणजे काय? अटेन्शन टू वन सेल्फ रादर दॅन इंटेन्शन टू डाय. म्हणजे लक्षवेधी वागणूक जास्त करायची, मरायची इच्छा नाही. उगाच 5 गोळ्या घेतल्या, थोडे 2 चमचे ऑर्गनोफॉस्फरस तोंडाला लावलं, या सगळ्या गोष्टी पॅरासुइसाइड म्हणतात. किंवा डेलिबरेट सेल्फ हार्म, DSH, मुद्दाम हातात कापून घ्यायचा. पर्सनॅलिटी डिसऑर्डर मधली मंडळी करतात. सुइसाइड इज डिफरंट, पॅरासुइसाइड इज डिफरंट. What are the risk factors for suicide? Age, adolescent and elderly. फक्त तरुण वयामध्ये प्रेमभंग झाल्याने सुसाइड होते किंवा मॅट्रिकला 18 वर्षी नापास झाल्यामुळे होते असं नाही. Adolescent suicide is very common now in our country. Previously Japan was a main country where adolescents used to kill themselves. हे आत्ताचं ब्लू व्हेल, हे सगळे जे आहेत गेम्स, they lead ultimately they end into kill yourself, etc. So adolescent suicide and elderly also. की मला जगण्याचा कंटाळा आला, माझा मुलगा माझ्याकडे बघत नाही, माझी सून मला बघत नाही, मी सुइसाइड करतो. हे या एल्डरली ग्रुपमध्ये सुद्धा सुइसाइड होतो. पुरुषांच्या मध्ये सुइसाइड जास्त. तो अनमॅरिड असेल किंवा विडोड असेल तर जास्त सुइसाइड असेल. मेल और फिमेल. पुअर फिजिकल हेल्थ, दीर्घ आजाराने मी जर्जर झालेलो आहे, आय फील लाईक कमिटिंग, एंडिंग माय लाईफ. मेंटल इलनेस व्हेरी कॉमन. फक्त डिप्रेशन मध्ये सुइसाइड होते असं नाही, स्किझोफ्रेनियामध्ये होते. पर्सनॅलिटी डिसऑर्डर मध्ये सुइसाइडचे सुडो अटेम्प्ट पण असतात, कधी कधी खरं पण होऊ शकतं. आयसोलेशन, एकटेपणाची भावना, एकटं पडलेलं असणं, कोणी नाही जवळपास. या पॅन्डेमिक सिच्युएशन मध्ये काही गोष्टी झाल्या. अनएम्प्लॉयमेंट, पॅन्डेमिक सिच्युएशन, ऑपोजिट टू दॅट वर्क स्ट्रेस can lead you to, can be a risk factor for suicide. Financial stress, risk factor. Previous suicide attempt, definitely a suicide risk factor. Religion, काही धर्मामध्ये सुइसाइड जास्त असतात, काही धर्मांच्यात कमी असतात, जास्ती चर्चा करत नाही. फॅमिली हिस्ट्री ऑफ सुइसाइड. माझी आत्यांनी सुइसाइड करून ती गेली, माझा मामा सुइसाइड करून गेला. बी केअरफुल, पक्क आहे. आणि अल्टिमेटली टेररिस्ट सुइसाइड तो एकदमच वेगळा प्रॉब्लेम. काहीतरी एक विशिष्ट समज घेऊन ही मंडळी बॉम्ब बांधून मरतात, तरुण लोक मरतात, त्यांना डायरेक्ट स्वर्गात जायला मिळतं असं त्यांना ब्रेन वॉशिंग झाल्यामुळे झालं असेल. पण टेररिस्ट सुइसाइड हा नवा फिनॉमिना आहे. नवा म्हटलं तरी गेली 10 वर्ष आहे. नेक्स्ट स्लाइड प्लीज. ओके, काय करायचं? अक्युटली इल सुइसाइडल पेशंटला ऍडमिट विथ अ रिलेटिव्ह. ऍडमिट विथ अ रिलेटिव्ह इन अ हॉस्पिटल वेर जरा थोडी फॅसिलिटी पाहिजे. पॅडेड रूम असावे, डोसका आपटून घेणे, हुक्स, फॅन्स आणि विंडोज तर ग्रिल लावा, फॅन्स असतील तर काढून ठेवा, हुक्स बघा. मेडिकेशन काय द्यायचं? पहिल्यांदा क्वाइट कराय करता त्याला अक्युटली इल पेशंटला देऊन मग यू स्टार्ट वॉट एव्हर यू अँटी डिप्रेसंट वॉट एव्हर यू वॉन्ट टू, डिपेंडिंग ऑन द कॉज ऑफ हिज सुइसाइडल इंटेंट. It may not be only depression, it can be schizophrenia. 15% of the people do it. MLC is a must. Any suicide attempt patient comes to your general hospital, takes one bottle of organ of phosphorus, recovers and goes home. ऐसा नहीं होगा. Medical legal case registration is a must. Although people will say abhi suicide according to Mental Health Care Act is removed from the Criminal Act. The Supreme Court has given order that suicide is not a criminal act, but the main issue is if Hawaldar comes to take a statement of the patient and the relative, आणि तुम्ही म्हणलात की आता तर सुइसाइड नाहीये, क्रिमिनल नाही, तुम्हाला साहेब अगदी बरोबर आहे. आम्हाला अजून एक्झिक्युटिव्ह महाराष्ट्र शासनाची एक्झिक्युटिव्ह ऑर्डर आलेली नाहीये. त्याचं कारण अगदी सोपं आहे. ते येतात हशाप करायला, मिटवायला, हलकं करायला, कमी लिहायला पैसे खातात. तर मी पेशंटना असं सांगतो, तुम्ही सांगा की करा केस, करा की दिवसाला 4 रेस्टिल खाल्ल्या किंवा 1-2 चमचे फेनेल प्यायलेले प्रत्येक हॉस्पिटलमध्ये 2 पेशंट येत जात असतातच. तर त्यांची MLC करा, बरं देत खटले. पण प्लीज रिमेंबर, जरी ते आता कायद्यानुसार गुन्हा नसला तरी एक्झिक्युटिव्ह ऑर्डर ग्रेट महाराष्ट्र शासनाची पोलिसांना नसल्यामुळे 2 पोलीस हवालदार येऊन एका पांढऱ्या कागदावर स्टेटमेंट घेतात. ते काही का करेना, तुम्ही MLC करायची, ते तुमचे नातेवाईक मागे लागतील, करू नका. आणि याच्यामध्ये काही विशिष्ट बाबतीमध्ये सुइसाइड करण्याचा प्रयत्न तुम्ही लपवलात आणि नंतर लक्षात आलं की इट वॉज अबेटमेंट ऑफ सुइसाइड. जे आपल्या प्रणब रॉयनं जे आपल्या याचा रॉय जो आहे त्याला अबेटमेंट ऑफ सुइसाइड करता मागे लागले होते. ते अबेटमेंट ऑफ सुइसाइड असला आणि तुम्ही ते लपवलं असेल तर तुमच्या बाबतीत सुद्धा तुम्ही त्या गुन्ह्यात सामील आहे असं वाटतं. बरोबर? तर MLC करा, वाटेल तेवढे पोलीस येऊन जाऊ दे. रिफर टू सायकियाट्रिस्ट और सायकॉलॉजिस्ट. आज आला, बरा झाला, परवा इंटेन्सिव्ह मध्ये बाहेर काढला, असं करू नका. सायकियाट्रिस्ट येण्यानी आणि सायकॉलॉजिस्ट येण्यानी एक तुम्हाला एक सेकंड ओपिनियन मिळतं. तुम्ही सगळे इंटेन्सिव्हिस्ट, तुम्ही सगळे मेडिकल डॉक्टर पेशंटचा जीव वाचवायच्या मागे आहात. तुम्ही हे आमचा उद्योग तुम्ही करत बसून वेळ घालवूच नका. ते काम सायकियाट्रिस्ट करू दे, कारण त्यांनी एकदा पेशंट रिस्क मधनं बाहेर आला की त्यांच्याशी बोलून काय फॅक्टर्स होते, काय झाले घरामध्ये, सासू सून भांडण आहे का, इंटरपर्सनल इश्यूज आहेत का, हे सायकियाट्रिस्ट किंवा सायकॉलॉजिस्ट बघतो. आज माझी खात्री आहे प्रत्येक छोट्या गावात, तालुका प्लेसला सुद्धा सायकियाट्रिस्ट आहे who can work also as a psychologist. सायकॉलॉजिस्ट नसतील, कमी आहेत, पण करा आणि तुमच्यावरचा कायद्याचा बोजा कमी करा. तर तसं न करण्याने नंतर जाऊन हे लोक म्हणतील बघा आम्हाला बरं केलं, सायकियाट्रिस्ट कडे नाही पाठवलं. ते करा, काही बिघडत नाही, एक ओपिनियन घेतलंय. नेक्स्ट स्लाइड प्लीज. हा मॅनेजमेंट मधला इश्यू. आता पुढची केस काय, पोटेन्शियली व्हायलंट पेशंट. तो तुम्हाला मारू शकतो असा व्हायलंट पेशंट. त्याच्यामध्ये कोण कोण असतं? सायकोसिस. मी सांगितलं स्किझोफ्रेनिया इज प्रोटोटाइप ऑफ सायकोसिस. एक सायकोसिस स्किझोफ्रेनिया, पण अनेक सायकोसिस आहेत. दारूमुळे निर्माण झालेला सायकॉटिक इलनेस, अल्कोहोल इंड्यूस सायकॉटिक डिसऑर्डर, अल्कोहोल इंड्यूस मूड डिसऑर्डर, हे सगळे तुमच्याकडे येऊ शकतात इमर्जन्सीमध्ये आणि दे आर पोटेन्शियली व्हायलंट. पर्सनॅलिटी डिसऑर्डर्स, विशेषतः अँटी सोशल पर्सनॅलिटी. माझं मिळवाय करता मी तुमचा गळा कापून वर जाईल, त्याला क्लस्टर बी अँटी सोशल, ऍक्च्युअल अँटी सोशल पर्सनॅलिटी. म्हणजे सगळेच क्रिमिनल जर अँटी सोशल नसतात, पण बरेच क्रिमिनल यांचा प्रवास लहानपणापासून बघितला. लहानपणी वयाच्या 18 वर्षाच्या आत त्यांना कंडक्ट डिसऑर्डर म्हणतात, वर्तन समस्या. ते पुढे होतात तेव्हा त्यांना आजूबाजूच्या झोपडपट्ट्यामध्ये काय करणार, झोपडपट्टीमध्ये तू कुठेतरी खेळत बसलेला असतो, घरे सिगरेटचं पाकडी घेऊन आणि तो आणतो. मग त्याला बारीकस हातात देतात की एक 20 रुपये घ्या, एक दारूचं पण आणतो. असं करत ही मुलं जशी वाढतात तर ते जेव्हा सगळेच असे होतात नाही, त्याच्यातून खूप छान झालेली पण मुलं येतात झोपडपट्टीतनं. परंतु जर इन्फ्लुएन्स असा असेल तर मुलाचे पाय पाण्यात दिसतात ओळखून यांचं कंडक्ट डिसऑर्डरचं रूपांतर व्यक्तिमत्व दोषात होऊ शकतं. असे लोक दे आर पोटेन्शियली डेंजरस. आतापर्यंत सायकियाट्रिस्टवर हल्ला फारसा कोणी केला नाही, एकाच केसमध्ये त्याला केलं होतं. डिमेन्शिया विथ बॉट behavior and psychological symptoms of dementia. Dementia with BPSD. Dementia is a blanket term. 10 प्रकारचे डिमेन्शिया, अल्झायमर आहे, फ्रंटोटेम्पोरल आहे वगैरे. त्यातल्या कुठल्याही उपप्रकारामध्ये बिहेवियर अँड सायकोलॉजिकल सिम्पटम्स ऑफ डिमेन्शिया असतात. तुमच्याकडे जे पेशंट येतात ते बिहेवियर बिघडले म्हणून, माझ्या पेशंटला अल्झायमर झाले म्हणून ते इमर्जन्सी रूमला येते, विचित्र वागतोय, म्हातारा मारतोय सगळ्यांना, कपड्यामध्ये सू करतोय, ते ह्या प्रॉब्लेम करता येतात. Please keep in mind that dementia patient can be severely or potentially violent. He can hit his wife or hit you also. Severely manic, मी आत्ताच सांगितलं, जगाच्या वर राज्य करायला निघाले, अति उत्साहात असतो. Agitated depression. The lady, elderly lady about 50, 60, she's so tired, so agitated, she may hit you. General medical condition, I have told you. Infarction, tumor, stroke, epileptic episode, all this can be potentially violent. If it is just after 1 or 2 seizures is not there, he can be into post-ictal confusion state and be dangerous. Delirium, confused state of mind. Delirium, by definition, is reversible if you find out the cause and treat it. Commonest alcohol withdrawal delirium, cannabis withdrawal delirium, अनेक सबस्टन्स, बेन्झोडायझेपिन विड्रॉल डेलिरियम. कारण हुडका आणि त्याची ट्रीटमेंट करा. पण ही कॅन बी पोटेन्शियली डेंजरस. बांधून ठेवायचे बघा, पक्क बांधून ठेवायचं बघता येईल डेलिरियस पेशंट. सबस्टन्स यूज, आपण तेच परत परत म्हणतोय, अल्कोहोल या सगळ्या गोष्टी असतील, ही कॅन बी, त्याला जर मिळालं नाही आणि तो विड्रॉल मध्ये असेल तर ही कॅन बी पोटेन्शियली डेंजरस अँड व्हायलंट, ब्रॉट टू युअर इमर्जन्सी. नेक्स्ट प्लीज. ऍक्शन प्लॅन. आता असा व्हायलंट पेशंट काय करा, टेक चार्ज ऑफ द सिच्युएशन. पहिली परिस्थिती काबूत घ्या, ताबा घ्या. तुम्ही कॅप्टन व्हा, सीएमओ असाल, तुम्ही सायकियाट्रिस्ट असाल तर उत्तम. स्टे कूल. सांगायला सोपं आहे, तिथे प्रॉब्लेम येतो मला माहिती. सिक्युरिटी 1, 2, 3 प्रत्येक हॉस्पिटलला सिक्युरिटी असते. प्रायव्हेट हॉस्पिटलमध्ये असाल तरी 1, 2 तगडे बांड सिक्युरिटीचे लोक मिळवा. ट्रेन स्टाफ, स्टाफलाही माहित पाहिजे कसं हँडल करायचं. प्रोटेक्ट युअर सेल्फ अँड स्टाफ. गिव्ह लिसनिंग इयर टू पेशंट. या सगळ्यातून असं दाखवा की बाबा मी तुझं ऐकतोय, सांग काय तुला म्हणायचं. असा एक देखावा तरी निर्माण करायला यायला पाहिजे. तुमच्या आजूबाजूला सिक्युरिटी असली पाहिजे, स्टाफ असला पाहिजे. त्यांनी तुमच्या अंगावर हल्ला केला तर त्यांनी पकडायला पाहिजे. आणि मी सांगितलं असं 2 हात, 2 गुडघे, 2 खांदे आणि 2 रिस्ट पकडायला पाहिजे. किती आडवा असून ब्लाइंड फोल्ड करा. असा ऍक्शन प्लॅन पाहिजे. त्याच वेळेला मेडिकेशन इज बेस्ट इज इंजेक्शन लोराझेपाम or injection haloperidol, intravenous or intramuscular. Invariably CMO मध्ये पेशंट डिस्टर्ब आला की फोर्टविन फिनरगान दिलं जातं. तुम्ही बघा, तुम्ही तुमच्याच सीएमओला विचारा काय दिलं बाबा त्याला, फोर्टविन फिनरगान. कशा रे बाबा, जर पेशंट ओपियाइड ऍडिक्ट असेल तरच तो शांत होईल, तुम्ही त्याला फोर्टविन दिल्यावर. नाहीतर ते युजलेस ड्रग आहे, त्याने उलट निर्माण होते पुन्हा पुन्हा येऊन फोर्टविन घ्यायची सवय. इंजेक्शन लोराझेपाम यू कैन गिव इंट्रामस्कुलर और आईवी 4 मिलीग्राम आराम से. इंजेक्शन हाइड्रोपेरिडोल 2 ampules that is 10 milligram with 25 to 50 milligram of फिनरगान. इंट्रामस्क्युलर द्या नाही तर आयव्ही द्या. इंट्रामस्क्युलर आणि आयव्ही मध्ये 30 मिनिटं, दोघांनाही 30 ते 40 मिनिटंच लागतात. पण इमर्जन्सी मध्ये आजच्या जमान्यात जर तुम्ही आयव्ही इंजेक्शन दिलं आणि पेशंटला काही झालं तर नातेवाईक तुमच्यावर तुटून पडतात. इंट्रामस्क्युलर त्यातल्या त्यात बरं. खरं सांगतो, माहिती त्या क्राऊडची सायकॉलॉजी आहे. शिरतनं इंजेक्शन दिलं आणि पेशंट मेला वगैरे वगैरे. इंट्रामस्क्युलर द्या, तितकाच वेळ लागतो. अजिबात आयव्हीची घाई करू नका. शेवटचं रिस्ट्रेन, मी आता सांगितलं, अल्टिमेटली सगळं पकडून त्याला रिस्ट्रेन करावंच लागतं. नवीन कायद्याप्रमाणे रिस्ट्रेनला त्याची किंवा नातेवाईकाची, त्याची तर मिळणारच नाही, नातेवाईकाची परवानगी. रिस्ट्रेन किती वाजता हात बांधले, किती वाजता सोडले, हे सगळं डॉक्युमेंट करायचं. तुम्हाला वेळ काढावा लागेल, कारण हा नवीन मेंटल हेल्थ ऍक्ट आपल्याकडे आला आहे. नेक्स्ट प्लीज. नेक्स्ट आय टेक जस्ट 5 minutes. आता तेच आपण रिपीट करतो. आणखीन कुठल्या सिच्युएशन सायकियाट्रिक चॅलेंजेस ते पेशंट येतात. मूड डिसऑर्डर, मॅनिया, ॲजिटेटेड डिप्रेशन मी सांगितलं, सबस्टन्स इंड्युस्ड मूड डिसऑर्डर, गांजा इंड्युस्ड मॅनिक डिसऑर्डर, गांजा इंड्युस्ड स्किझोफ्रेनिया एक डिसऑर्डर, हे तर मान्य केलं. पण पॅनिक विथ ॲगोरोफोबिया म्हणजे अचानक आतंक चिंता, पॅनिकचा अर्थ आतंक चिंता, अचानक येणारं पॅनिक जिथे पेशंटला कळत नाही काय करू, कुठे जाऊ, तो इमर्जन्सी मध्ये येतो. आणि इट कॅन बी रिअली चॅलेंजिंग सिच्युएशन जस्ट टू कूल हिम डाऊन, क्वाइटन हिम, जस्ट comfort him, and you can give him one tablet of dispersible clonazepam. It will be quiet. Just give him a helping hand and listening ear. Agoraphobia, एकटं जायची भीती, अशा मंडळींना इमर्जन्सी धावत पळत येत असतात. PTSD आणि अक्यूट स्ट्रेस डिसऑर्डर, पोस्ट ट्रॉमॅटिक स्ट्रेस डिसऑर्डर, हा व्हिएतनाम वॉरच्या वेळेला आलेला शब्द आहे. जिथे अमेरिकन सैनिकांच्या आजूबाजूला रक्ताचा खत, मुडदे, म्हणजे गोळीबारामध्ये मेलेले लोक अंगावर पडायचे, त्यांच्या स्मृती यापुढे अनेक वर्ष त्यांना त्रास देत राहिले. त्यामुळे ही मंडळी ओपिओइडच्या, हिरोईनच्या आहारी गेली. अमेरिकन सोल्जर हा शब्द व्हिएतनाम वॉर नंतर आले. पोस्ट ट्रोमा, सायकोलॉजिकल ट्रोमा, स्ट्रेस डिसऑर्डर और अक्यूट स्ट्रेस डिसऑर्डर. अक्यूट स्ट्रेस म्हणजे काय, तुम्हाला मला होऊ शकतो. म्हणजे आज बर्शेन नाही मिळालं, पेट्रोल नाही मिळालं, ही स्ट्रेस आता राहायचे दिवस गेले, हे रोजच आहे. नळाला पाणी नाही आलं, नाही जाऊ दे म्हणतो. अक्यूट म्हणजे तुमच्या समोर एक भीषण ऍक्सिडेंट झाला, 2 माणसं मिळली, किंवा तुमच्या समोर एकाने दुसऱ्याला वार करून तुकडे करून मारलं. हा रोजच्या आपल्या स्ट्रेसच्या अनुभव विश्वातल्या बाहेरचा आहे. आपल्या रोजच्या येणाऱ्या स्ट्रेस, आपण ज्याला सो कॉल्ड स्ट्रेस म्हणतो, त्याच्या बाहेरचा अनुभव आहे. आणि त्यांनी तुम्ही निशब्द होऊ शकता, किंवा तुम्ही डिस्ट्रेस होऊ शकता, किंवा तुम्ही इमर्जन्सी निर्माण करण्या इतकी तुमची वागणूक बदल. सो इट इज अक्यूट. जोपर्यंत स्ट्रेस आहे तोपर्यंत अक्यूट स्ट्रेस डिसऑर्डर असतो. असे लोक की आता माझ्यासमोर एक खून घडला, असे इमर्जन्सी देऊ शकतात. पुन्हा तिथे त्याला बांधायला लागत नाही, त्याला जस्ट गिव्ह हिम अ लिसनिंग इयर, थांबवा, त्याला बसवा, पाणी द्या, कॉफी द्या. You will be able to do it. Next slide, please. Schizophrenia and psychotic disorder. I told you all psychotic disorder are not schizophrenia. Schizophrenia is a major psychotic disorder. What are non-schizophrenia psychotic? The delusional disorder. म्हणजे काय? Delusion is a false belief not shared by others. आजकाल जे घडू शकतं पण जे नाहीये. आजकाल कुठल्याही बँक ऑफिसरला वाटतं की माझी बायको पण दुसऱ्या बँकेत आहे, ती नेमकी गुरुवारीच उत्तम साडी नेसून जरा खुशीत का असते बरं? तिच्या मोठ्या साहेबाशी काय आहे का काय तिचं? सो इट्स अ डेल्युजन विच इज नॉट शेअर्ड बाय अदर्स. बायको म्हणतो मी शपथ घेऊ का, काही करत नाही, मी आपलं नेहमी देते. असं कसं? मी बघितलं दर गुरुवारीच तुझा मूड चांगला असतो, किंवा शुक्रवारी, व्हॉट एव्हर. सो दिस इज डेल्युजन which is a false belief not shared by others. मी लोकांना उदाहरण काय देतो? डेल्युजनल डिसऑर्डर इज व्हेरी कॉमन, व्हेरी व्हेरी कॉमन. डेल्युजनल डिसऑर्डर मधनं खून घडतात. डेल्युजनल डिसऑर्डर मध्ये बाकी सगळं फंक्शनिंग नॉर्मल आहे. मी बँक मध्ये काम करतो, मी उत्तम आहे, एक्सेप्ट पत्नीच्या चारित्र्याचा संशय. मला काही, मी बँकेचं काम करतो, मुलांकडे बघतो, सगळं रोजचं करतो. फक्त एका विषय मी उदाहरण देतो. प्रभू रामचंद्रांच्या कानात परटाने सांगितलं की सीतामाई श्रीलंकेत होत्या, काय बघा जरा चारित्र्य. तेव्हा प्रत्यक्ष प्रभू रामचंद्रांना खरं वाटलं आणि सीतेला काय करावं लागलं की नाही मी केलं श्रीराम प्रभू, म्हणून त्याला अगदी दिव्य करावं लागलं. म्हणून मी सांगतो की जर एक गोळी हॅलोपेरिडॉलची दिली असती तर सीतेचं अगदी दिव्य टळलं असतं कदाचित, चेष्टेत म्हणतो. सो दॅट इज डेल्युजनल डिसऑर्डर, व्हेरी कॉमन. इट्स अ सायकॉटिक डिसऑर्डर. बाकी कुठलाही त्याच्यामध्ये नसतं, सगळं फंक्शनिंग नॉर्मल. फक्त पत्नीच्या चारित्र्याचा काही शेजारचे जोशी मला अमुक करतात वगैरे, कसलाही संशय, तेवढा एकमेव त्यांचा हे असतो, फॉल्स बिलीफ असतो. जनरल मेडिकल कंडिशन, सबस्टन्स रिलेटेड सायकॉटिक डिसऑर्डर आपण बोललोच आहे सगळं. आणि शेवटी कल्चर रिलेटेड सिंड्रोम, अंगात येणाऱ्या बायका नाही का, नवमीला जे अंगात येतं हे कल्चरली ऍक्सेप्टेड सिंड्रोम्स आहेत. नवमीला गर्दी असते देवळामध्ये देवीच्या, आणि त्या अंगात घुमतात त्या बायका, त्या बघतात. त्या वेळेला त्या बाई, ती जर सून असेल तर तिची सासू समोर असते. एरवी सासू पाय धरणार नाही, दिवशी देवी आली सुनेच्या अंगात म्हणून सासू पाय धरते, आणि ती सून तिच्या तोंडातून देवी बोलते की तुझ्या सासूला सांग की जरा नीट वागत जा म्हणावं. म्हणजे सुनेला बोलताना भीती वाटते, ती देवी तिच्या तोंडातून बोलते. हे सगळं कल्चरली ऍक्सेप्टेड आहे. ह्या इमर्जन्सी गोष्टी भूत लागलं सीएमओ मध्ये विशेषतः छोट्या गावात नक्की येऊ शकतो. वेगवेगळ्या कल्चरमध्ये टोरो अनेक सिंड्रोम्स आहेत, वेगवेगळ्या देशात आहेत, मलेशियात आहेत, जपानात वगैरे. तर हे दे कॅन लँड अप इन इमर्जन्सी and just rule out whether they are culturally related symptoms. Okay, next slide, please. Substance use disorder. I told you alcohol, cannabis, hallucinogens, benzodiazepines. Diazepamच्या 10 गोळ्या घेणारा पेशंट 20-30 वर्ष घेतो. तर असा एक पेशंट ऍडमिट झाला फ्रॅक्चरमुळे, ओल्ड मॅन ऑफ 60. So he was for 2 days because of surgery. He never got his benzodiazepine. He was terribly delirious and terribly restless. Then someone found out that he's taking diazepam. We gave him 1 tablet of diazepam. He was all right. Cocaine हे नव्याने आलेलं आहे. ओपिओइड्स आपल्याकडे स्थिर झालेली आहे. ओपिओइड्स स्थिर झाली आहेत. बॉम्बे सेलिब्रिटीजने तर अगदी पक्की स्थिर केली आहे. कोकेन हे बॉम्बे सेलिब्रिटीमध्ये भरपूर आलेलं आहे. पुण्यासारख्या शहरात मिळतं. आणि इनहेलन्स. अनेक छोटी मुलं असतात, पेट्रोल पंपावर जाऊन नुसतं पेट्रोलचा वास घेतात. इट्स अ ब्लडी ॲडिक्शन. सो इट्स अ सबस्टन्स यूज डिसऑर्डर. आणि ही लोक जर त्यांना ते झालं नाही, ती रेस्टलेस होतात. बाकीचे ॲडिक्शन म्हणजे सॉफ्टवेअर ॲडिक्शन म्हणजे मोबाईल गेमिंग आणि ह्या गोष्टी सुद्धा 10 तास इंटरनेट बघणारे. दिस आर ऑल addict, soft addiction they are called. If they are deprived of this, they can land up in your emergency room. Next, please. Next slide. Okay, this is the last slide. What are the take-home messages? Friends, emergency psychiatry is a new and fascinating subspecialty of psychiatry. Young psychiatrists should think of working in this specialty, which is very rewarding. With the patient acutely ill brought, and in 3 hours you have taken charge of the situation. The patient is comfortable. It's very rewarding. Please remember, you can cure sometimes, treat often, but comfort always. So this is what Hippocrates has said. Cure sometimes, treat often, but comfort always. That is the duty of our noble profession, which is not a business. Thank you very much.
थँक्यू सर. थँक्स अ लॉट. अगदी सोप्या शब्दात तुम्ही अगदी क्लिअर मेसेज दिला. थँक्यू फॉर द लेक्चर and adjusting the time also, sir. Thank you. Yeah, so with this, I declare that the scientific session is over, and I request President IMA Akluz and our Secretary IMA Akluz to please come on stage. And I request Secretary IMA Akluz to deliver a vote of thanks. Before that, I request Dr. Mansi to felicitate today's speaker, chairperson, and I request today's chairperson to thank today's speaker.
Hello. Thank you, sir, for your excellent presentation.
Thank you.
मेडिकल हॉस्पिटल्स मध्ये कुठे कुठे सायकॅट्री इमर्जन्सी होते त्याच्याबद्दल ओव्हरव्ह्यू सांगितलं. तसेच सायकॅट्री मध्ये इमर्जन्सी फक्त सायकॉटिक पेशंटचीच नसते, तर बऱ्याचदा जनरल मेडिकल कंडिशनमुळे पण येते. त्याच्याबद्दल बऱ्यापैकी चांगलं माहिती दिलेली आहे. थँक्यू सर फॉर युअर एक्सलंट प्रेझेंटेशन. थँक्यू. थँक्स.
हॅलो.
मानसी सरांचं फेलिसिटेशन. हरळे सरांचं फेलिसिटेशन. झालं.
Hello. Okay, so after extensive 2 days of scientific sessions, we have come to an end of this conference. I would first give out the winners of the quiz. So those who are still online, we have got still 350 plus online delegates, and also physically people present over here. So for the quiz, we had a tie. The first prize goes to Tamanna Dasani. She is the only sole winner. So she has stood first. The second place was a tie with 3 winners. So we had to look at the submission and the time at which they submitted the answers. So based on that, the second prize goes to Dr. Megha Kanungo, and the third prize goes to Dr. Mahesh Chavan, Mahesh Keshavrao Chavan. So these are the winners of the quiz. Congratulations to them. The gifts, the prizes will be delivered to the respective places after contacting them. So we have come to the conclusion of this conference. The scientific sessions are over. So I, Dr. Nitin Rane, the Secretary of IMA ACLUS, would be delivering the vote of thanks to all the online users and the physically present people. First and the foremost, I would like to thank the online speakers and chairpersons who have given us a tremendous support and given wonderful lectures, and the academic fees they have provided us for the last 2 days was wonderful. The second most important people over here were the IMA ACLUS members who have supported us in each and every aspect and attending the conference in here and building the confidence of us. The most important thing was the online delegates as well, because the numbers were huge. We had a number of around 1600 online people who attended the conference, and it's such a huge accomplishment for IMA ACLUS as well as for AMSCON. So we have got the light is out at our place. So I'll be delivering this on. The online delegates, I would like to thank all of them. They have supported us and they have attended huge numbers. So that is also a very important aspect of a conference. The most important digital support which we have got, the technical support from the team DigiShield. I would like to especially thank Mr. Piyush, who has helped us in giving all the support which he has, and he has helped us in providing all the necessary online and technical things which we have used. Hello. The support staff from all the hospitals. Every doctor has got some support staff from around here, and we have used all the support staff and the support which they have given in arranging each and every tiny aspect has also been very important. Not but least the Krishna Priya staff, the hall where we have conducted the conference is also important. The stage decorators, especially what they have put up, a wonderful stage, wonderful entrance, beautiful rangoli. The ROV decorators, we would like to thank them as well. Last but not the least, we would like to thank all the IMA office bearers who have worked tirelessly for the last 2 months to make this conference here such a huge success. Each and everyone has helped in every aspect. It was not the case that only the person looking after a particular thing was looking at. He was looking, everyone was concerned about the registrations or the food committee, the scientific committee. Everyone has helped in every aspect, contacting the speakers, talking with them, being in loop with them, and presenting wonderful lectures and presentations was a part of it. So based on that, I would like to invite everyone on the stage. First, I would like our IMA President, Dr. Sir, to be on stage, please. Second, I would like to call upon Treasurer Dr. Sanjay Sith, sir, on the stage, please. Our Vice President, Dr. Suryavanshi and Dr. Dobre on the stage, please. Joint Secretary, Dr. Vinod Chete. Clinical Secretary, Dr. Revati Rane. Sports Secretary, Dr. Ninath Pade. Cultural Secretary, Dr. Shrikant Devdikar. Women's Wing, Dr. Priya Kadam. Organ Donation Secretary Dr. Mukund Jamdar, Young Doctor Wing Dr. Sambhaji Raut, and the executive members of our IMA body, Dr. Abhijit Gandhi and Dr. Sachin Fade, Dr. Mansi Namdar and Dr. Aditi Thite, and Dr. Sunil Narute. Everyone on stage, please. So this is the team which has helped us in putting up this conference. Each and every aspect of the conference has been looked upon. There were different committees, the scientific committee, the food committee, the travel committee, the scientific committee, the technical committee, the digital committee. So everyone was prescribed their particular jobs, even from small points like arranging the trophies, designing the banners, putting up the stage. Everyone was looked after by each and every member. So at the end, we would like to thank all and for attending the conference and making this conference such a huge success. I would request all the IMA members, office bearers to please sit on a stage for a staff group photo. And I would conclude from this venue. Thank you very much for attending the conference. Thank you all.